Very good. We're really learning. We'll be really sharp by December 30th. Okay, committee, listening world, welcome to the State of Wyoming Joint Interim Labor Committee, and we are meeting by Zoom to consider the agenda that was posted. We've got a couple of bills. We are going to have a little bit of discussion about telehealth, which is on everyone's mind these days, and get started on some of our regular interim topics. We'll hear some from mental health. So a full day probably, but not our original 2-day schedule that we had intended. Chairman Scott, I believe that you had wanted to say a few things before we got started. I'll call for the roll afterwards, but I'll let you say your bit.
Okay, thank you, Madam Chairman. Committee, I just wanted to express that when it first became apparent we were going to have to do this, we're likely to have to do this as a virtual meeting and not a face-to-face meeting. We discussed who was going to chair it, and Representative Wilson and I came to the conclusion it'd be better if she chaired these meetings because she's got better technical capabilities there. And it wasn't at all clear what technical capabilities, if any, I was going to be able to have. I'm having difficulties getting things set up out at the ranch. So that's why Chairman Wilson will be chairing the meeting. And I think it ought to work just fine. I've got full confidence in Madam Chairman's ability to do this.
Thank you, Mr. Chairman. Okay, now whoever's going to call the roll, Ian or Elizabeth, could you call the roll, please? And folks, remember to unmute yourself when your name is called.
Senator Baldwin.
Present.
Senator Bouchard.
Here.
Senator Pappas.
Here.
Senator Schuler.
Here.
Representative Barlow.
Present.
Representative Clem. Representative Dayton. Representative Dayton Selman.
Here.
Representative Hallinan.
Excused.
Representative Roscoe.
Here.
Representative Stybar.
Present.
Representative Sweeney.
Here.
Representative Yin.
Here.
Representative Clem.
Yep. Unmute. We see him.
I'm here. Thank you.
Co-Chairman Scott.
Here.
Co-Chairman Wilson.
I'm here, and I did just see Representative Hallinan briefly flicker on. You might call him again.
Representative Hallinan.
Wave your hand, Representative Hallinan. He's there. We see him.
All are present and accounted for.
Thank you. Ian or John, I don't think that we talked about this in our preparations, but I believe we have to adopt joint interim rules for the committee.
Madam Chairman, my understanding is that the rules that were adopted last interim last for 2 years. So those should be in effect for this interim as well.
Very good. Then we will begin with the agenda. And I just wanted to say, so we did have, interesting, I see in the agenda we listed a bill up there first. Was there a LSO? Was there a reason why? Do we have an agency that needs to depart or something?
Madam Chairman, I think that might have been an error.
Oh, well, let's start with the agency reports then, if we've got agency people to let in. And as we, did DFS have a need to go, or do we need to move them earlier in the agenda?
Madam Chairman, it was actually Department of Workforce Services
Workforce
has a
Services.
town hall that they were hoping they could go earlier so they could do the town hall with constituents.
Okay, well, why don't we move them to the front of the list then, and you can let them in. And while we're just going through that process, I just want to have a reminder here on these agency reports. You'll note it says brief. Senator Scott and I are planning for, hopefully, which will be our August meeting, to have a regular after action type report from agencies, from providers, from the community on the whole COVID-19 situation, what happened, what worked, what didn't work. So that is not our intention for these reports. We're just doing the one time. We need to get ready for the special session, and we're still really in the midst of things. So the intention, just so the audience knows, and the agency people will be reminded, and you all know, we're not going to attempt to hear everything that they have done over the last 2 months and everything that worked, and we're not going to do that now. What I wanted to do was give them 5 minutes or so to let us know if there are things that we urgently need to know about in the Labor Committee, even if necessary, in preparation for a special session. But that's the goal of this time, not to cover all the material. We'll have more time for that in August. Okay, so Chris, are you there from Workforce Services? Or who's the, I see all of a sudden a lot of people's faces popped up. Who's going to present for Workforce Services? Representative Sweeney, I see your blue, I beg your pardon, I'm not watching my blue hands. Representative Sweeney.
Madam Chairman, if they're have a slideshow or even a partial, if they could just tell us what page that was on to the submitted materials, that would really be helpful.
Okay, good.
Thank you.
And I believe I saw, there was another hand. Did you put your hand back down? Whoever it was. Okay, all right. Who's going to present from Workforce Services? You're muted, whoever you are. Chris, can you unmute yourself? There you go.
Morning, Chairman. I was under the assumption that Director Cooley or our Administrator Holly Simoni would be on.
Oops, for you.
As far as what you were talking about with what is relative to this group, we do have a couple of, as you probably know, we have non-charging and the non-charging issue that we have addressed with LSO. We also have the short-time compensation plan that we have coming up, I believe, a draft bill next Tuesday that the Minerals Committee is working on. I'm thinking those are the main two things that we had. I apologize, I'm kind of on the spot here. I assumed that either Haley or someone would be on here.
I think we were so fast in getting you guys early that we probably took them by surprise. You're doing super. So my understanding then from what you're, and actually that's, it's good because we did only want short, brief statements, really. It sounds like the issues from Workforce Services are progressing through Minerals Committee, and you're working on the various things that we authorized you to do in the first special session bills. Is that what I understand from you folks?
Yes, Chairman Wilson. Mainly what we're doing is addressing everything through the CARES Act that was relative to unemployment.
Mm-hmm.
We did have emergency rules that we did, but as far as actual bill changes, it was the non-charging and the short-time compensation. I believe Director Cooley was also going to give you, through emails, I see that she was going to try to give you the, okay, I just got a chat from Holly Simoni. They're having technical difficulties, and Director Cooley will be on, and she's going to give you as close of a balance of the trust fund as she can. So hopefully she will be on in a minute.
Okay, committee, we will, the Management Council has asked us to also review the follow-on from the various actions that we took during the regular session as far as rate holidays and whatnot. We won't be doing that today. Mr. Brody.
Yeah, Madam Chairman, I just wanted to let the committee know that it looks like Director Cooley has logged into the meeting, and
Okay.
just FYI.
Is that her ending in 7999?
No, I believe the name of the window is Ty Stockton, but we can change that.
Certainly doesn't look like Ty. While we're here, may I just inquire, we do have a telephone number called in, 777-7999. Who is that? Telephone number, announce yourself there.
Line.
Sorry, who's that?
Madam Chairman, this is Stefan Johansson with the Health Department. I believe that's our conference room phone number.
Okay, we just wanted to know who you were. Thank you. Is that Director Cooley there down there? Oh, it's not Ty anymore. Go ahead.
Thank you, Chairman Wilson, Co-Chair Scott, members of the committee. Robin Cooley here today to give you an update on workforce services and what we've been doing to respond to the COVID situation. I will take your comments, Chair Wilson, to heart and keep this short and sweet if I can. I had a lot of information, but I will cut that back considerably for you. I do want to make sure, though, to begin with, that we've been sending all elected officials weekly updates about what's going on in workforce services. If you are not receiving those, please let us know about that. They contain a lot of information, good information on UI claims updates and that type of information, what we're doing with the work with the town halls. So please let us know if you have not been receiving those. The good information, we believe, to keep you updated weekly. I also want to let you know we're doing virtual town hall series on the UI claims, how you submit a claim, what the PUA is all about, what the FPUC is all about, which is the $600 additional payment. PEUC and its parameters is the town hall will be providing this morning. We've also been providing a lot of information as it relates to OSHA and getting workers back to work, back to your businesses safely. So I want to make sure that you're aware of that also. As you saw in the news this week, in fact, I believe it was yesterday or the day before, the unemployment rate in Wyoming has gone from 3.8% in March to 9.2% in April. But I want to provide a little bit of a silver lining to that, to note that Wyoming's unemployment rate is the 5th lowest in the nation. So there is good in that story. Unemployment insurance claims and payments from 3/19/20 to Wednesday of this week, 5/27, the total number of initial new claims filed was 3,497 claims, and a total additional reopens filed were 6,690. So we've been seeing a little bit of an evening off of some of those numbers, although they're not going down. We're seeing some evening, so we don't have those huge spikes. In order to respond to that, we did contract with a call center. To date, that call center has received 6,273 calls, which is pretty significant. However, when you look at what our internal claims center has received, they've taken a total of 29,586 calls. And I want to let you all know, I know that you're hearing from constituents, you're hearing from individuals that are still having troubles getting through in that call center. We're still, the call center individuals, the 30 additional people taking phone calls, are basic information calls. They can respond to basic information, but they don't have access to the individual's claim per requirements from DOL. So if the claims center individuals determine that those calls are too difficult, that they have to actually dig in deeper into that person's file, then they are then referred to our actual internal claims center where we have the experts that can answer those questions. So in case you are getting questions from your constituents, I wanted to that you are aware of those issues. As it relates to unemployment and payments made out, I want to give you some figures on that. Our total UI administrative grants we've received in order to implement some of these programs was $1,774,804. And we're continuing to request additional funds for those as well, including funds for the FPUC, the PUA, and the PEUC. But as it relates, getting back to payments that have been paid out to Wyoming constituents, regular UI payments, state payments, has been $45.6 million. Federal payments has been $596,000. FPUC, which is the $600 additional payment for anybody that has any kind of UI payment being made to them, has been $74.2 million, by far the largest payments being made out to date. PUA payments, which are the payments that are going to the individuals that are self-employed, gig workers, contract workers, those individuals that wouldn't otherwise qualify for unemployment, those payments have been $4.5 million to date. So total payments paid out is $125 million. I did ask for an up-to-date amount on what our UI claim or UI trust fund looks like this morning, and I have not yet received that. So once I do get that, I will send that along to the committee. Our team worked tremendously hard, putting in probably a year's worth of work to get these federal programs up to date. And I'm very proud to say that the two programs, the FPUC and the PUA, are up and running very successfully. And we're working hard on getting the PEUC, which is the additional 13 weeks of unemployment assistance. We're working on getting that in place as quickly as we can. I know that you also are aware that we've been in the news somewhat for some UI fraud issues. And I want to update you on our fraud detection activities if I can. Since 5/13 of 20, we've detected over 152 ID theft claims. We have 4 people working almost solely on these ID theft claims. We have a number of them that we've been able to stop. And in fact, we've stopped the large majority of them. And our monetary losses, I think the last number that I heard was around $18,000. Certainly that's more than we would like, but it's better than we thought we could with the number of claims, the number of fraud cases that we're being able to stop. And how we're stopping them is we're stopping them through the US bank cards. We're stopping those payments. We're also working with the banks that if the payments are made into the banks, we're working with the banks to try to stop those. As soon as we determine they're fraudulent claims, we're stopping them with the banks before the payments are made out to the claimants. I also wanted to give you an update, though. I think an incredibly important component of what this agency is doing is working through our OSHA program team in tracking the complaints and discrimination cases filed from businesses and from employees. So updating you on that, we have both a compliance and a consultation team in our OSHA. The compliance team, which is actually the regulatory team that does go out and do an investigation if they receive a complaint, have received 18 complaints that are being investigated. 3 of those complaints are related to state entities and 15 are private entities. We also have COVID-related discrimination cases that we're looking at. We have 3 of those. 1 of those is a state entity, 2 of them are private entities. And those relate to retaliation for addressing COVID safety and health-related issues. Our consultation folks that really are there to assist businesses before a problem comes up and provide technical assistance to businesses. They've had 47 technical assistance calls with employers to assist them with COVID-related safety issues, such as how do you bring back your employees safely into your workplace. So OSHA's been very active in helping businesses in that regard. They've been helping a number of other state agencies like DFS, ANI, Weed and Pest, and some of the school districts, and the Wyoming Montana Safety Council to help navigate the path toward COVID safety. They've been helping employers walk through the risk assessments in their businesses and the controls that they can implement to ensure the safety of their employees, but in turn, the safety of their customers and clients as well. They've also themselves been participating in town halls with the Wyoming Business Council, the Petroleum Association of Wyoming, and UW to provide information and answer questions on these very issues. So OSHA has been out there. They've been busy working with businesses to try to help them and assist them bring their employees back, bring their customers back in a very safe way for them to do so. Another tracking element I wanted to update you on is workers' compensation. That was a big topic in the special session. So I think providing you those numbers just to give you a feel for what's going on in that area would be appropriate. We've had 47 claims filed as of 5/27. 4 of those claims tested positive, 11 tested negative, and the remaining 32 are pending a test or were not tested at all and so were denied. So that gives you a little bit of an idea of our teams that are actually on the front lines working. And I want to make a point of saying that our workforce centers out there, 24 workforce center or 20 workforce centers across our counties have been open as the only workforce centers in the country that have remained open throughout this time frame. Their normal walk-in clientele during this time frame would be maybe, I think the number was around 5,000 people during a normal year. They are trending now at over 20,000 people coming into the workforce centers for assistance. And what that tells me is that was an important component of making sure that people were assisted with unemployment, with work services, and just overall getting them into the system to help them, because a majority of the people that are applying for unemployment right now have never done so ever in their lives, and that's creating some problems. They don't know the process. They don't know what they're going to need to apply. So that's been part of why we've had the town halls, but also those 20 workforce centers out there staying open has been critical to the success of getting so many people on those unemployment rolls and getting some money out to them for assistance. But I also want to let you know what our workforce program teams are doing to help with reemployment services, as we're now starting on maybe a next phase of our processes. The workforce program team did apply for an emergency dislocated worker grant of $200,000. That will help dislocated workers. It will help workers laid off as the result of the pandemic, because they have to miss work to care for a family, or because they cannot come to a regular workplace in order to socially distance appropriately. So it's gonna help a lot of individuals, we hope. That funding will be braided with our current formula funding in order to help these dislocated workers. So we're looking forward to that money and the assistance it can provide. I just got my super duper team here in the room with me just did provide me with an update on our federal UI trust fund balances. Our federal balance as of 5/26 is $346,704,481. That was as of 5/26. As of 3/20 of 20, it was $373,650,262. So some significant payments out, but I would have to say that our fund is still looking healthy as we move forward with that. I do want to make a point too. Our state balance is at $51,460,891. So again, I think we're looking healthy in that regard thus far. I would like to end on a positive note here with a program that we've implemented that wasn't implemented as a part of COVID, but I think it's going to play a critical role in our COVID response. Some time ago, several months ago, 4 or 5 months ago, we started considering an internship training fund through our Workforce Development Training Fund unit. That has gone through the rules process, and we were able to get emergency rules through the process in order to start getting these funds out as quickly as we can. That was about 3 weeks ago that the governor signed those emergency rules into place. I want to make it clear that there will be no general fund money spent on this internship program. The funding will be through other funds that we have in our agency. And to date, even though we're waiting on providing any kind of messaging out about this, because we're waiting on the ability to use some CARES Act funding for this, but even without any messaging on this, Wyoming, we've received 8 internship applications, with 4 of those are already under contract and the remaining 4 in process. The total requested amounts are $91,534 and are in industries like agriculture, arts, construction, hospitality, law, manufacturing, medical manufacturing, and technology. So I am so hopeful of this program. I think it has a lot of potential to it, and I'm looking forward to providing you an update that program is going great guns the next time we meet. And with that, I would stand for any questions.
Super. Are there questions for Director Cooley? Senator Schuler.
Thank you, Madam Chair. Just a couple of quick questions. First of all, I think you guys have done an amazing job. I really appreciate the fact that you went to an alphabetizing system for unemployment claims. I think that was really helpful. I try to pop into our workforce services, every couple of weeks, and I think that was very helpful for our citizens. And I think it probably helped you guys in order to get the claims through quicker. Just a couple questions. I guess when I stopped there the other day, they said the system was down. I guess I'm wondering, have you guys had a lot of problems with technology? Is that something that we need to be aware of? And then I have a follow-up question, if that's all right.
Director Cooley, you want to take them all at once or answer them one at a time?
Chairman Wilson, Senator Schuler, thank you for the question. We did run into a problem with a server these past few days. We had Microsoft on board along with ETS, and we believe we've got that issue resolved. And to respond to your question overall, no, we have not had a lot of glitches. As you know, our system is new. It's a new program, entirely new system. We set up the benefits portion of the system in 2018, and we just went live to launch the tax portion of the system, in November 2019, which was fortuitous that we had that done when this hit, and we're very thankful of that. But overall, the only real glitch we've had has been that server that went down, and we think we've got that resolved. Now, we did have information that we put out on Facebook about that as soon as we knew that payments were going to be delayed. So the payments were delayed, we think are going to be delayed about 2 to 3 days is the last that I heard on that. So money should be going out here fairly quickly to our claimants.
Senator Schuler, did you have a follow-up?
Yes, thank you, Madam Chairman. The other thing that was brought up yesterday was they said there were some issues with the PECs, which I'm not familiar with, but it sounds like maybe your town hall that you're having later on today may deal with that situation. Is that correct?
Director Cooley.
Chairman Wilson, Senator Schuler, that is correct. The PEUC is causing us a little bit of issue in getting it implemented. So we're not quite ready to implement it. It may be later into next week, but we wanted to get the information out in the town hall today about applications for it, what you need for it, just get general information out in that town hall today at 10 o'clock to individuals. So we're ready to go. The minute we've got that program ready to go, people are ready to get that benefit.
Thank you.
Representative Stivar.
Thank you, Madam Chairman. Director, the hold times on these people calling in on the lines are, an hour, hour 50 minutes, 2 hours, 4 hours and 19 minutes, 37 seconds, and then they're being disconnected. Is there a problem there?
Director Cooley.
Chairman Wilson, Representative Stivar, there is a problem with that if individuals are not calling into that toll-free number to the individual call center. I think the last I heard on the call center waits, it was only maybe 4 minutes. 4 minutes on that call center wait. It's the numbers, it's the calls into our existing claims center in our UI with our UI staff where those wait times are extensive. So that is an issue. I understand that. We're getting messaging out, continual messaging out, that individuals need to initially call that call center where they won't be on the line for quite so long. But certainly, I'm hearing that same information. It's an issue. We did everything we can initially to upgrade the phone line system that we had within our existing claims center in Casper. We put a new circuit in that we thought was going to give us a number of new phone lines. We rerouted other state lines away from that line, and it just did not give us the resolution that we needed. So I certainly understand that's an issue. But again, please, people need to call into the claims center toll-free number first. And from there, if we can address their issues, that is the quickest way to do it. If their issues are too complex for those individuals to answer them, they will then be routed over to the claims center where the experts, with more in-depth knowledge of our state UI system can respond.
Well, yeah, and like I said, this I got this email yesterday. This happened on the 26th of this month. Yesterday, the individual went into the office in Gillette and got the problem taken care of. So, but spending that much time on the phone and getting disconnected, we need to work on that. Thank you.
Chairman Wilson, Representative Stivar, I absolutely recognize that. It's an ongoing issue for us that we're continuing to work on. So thank you for that.
Representative Clem.
Yeah, thank you, Madam Chairman. Director Cooley, thank you for being here this morning. I have a couple questions here. So I'll fire them both at you and hopefully you remember them. So in regards to the state unemployment trust fund, you said it's around 51 million, but I didn't hear what that was prior to. So for instance, the federal numbers you gave were 346 million from 373. So I'm kind of looking for that other number, 51 million from what? And then given our current burn rate on that, our current trajectory, how long can we continue going the route that we're going before things start looking more critical in your eyes or more concerning in your eyes? So, I mean, is that 6 months? Is that a year? I am under the assumption that this is going to go on, I think, in our economy for quite some time. So I'd like to know what your thoughts are on that. And then the other question that I have, it has to do with our unemployment numbers. I appreciate that 3.8% in March to 9.2% in April. But if you could give me some context here, I mean, what is our denominator, I suppose, I guess is the right phrase for the amount of workers that we have in Wyoming. I mean, what is the Wyoming workforce? And then out of that Wyoming workforce, how many now are unemployed to give that 9.2%? Thank you, Madam Chairman.
Director Cooley.
Chairman Wilson, Representative Clem, thank you. Some good, tough questions. our state balance, we don't pay out of this balance until we've actually exhausted our federal balance. So our state balance at that 51 million is actually has been a consistent number. Okay, so we have to pay down all of our federal balance first before we even get into that. And what is our current burn rate? I don't know that rate, but we have been keeping our eye on it. We've been working with our national organizations to try to determine what our burn rate is and how long we have, how many months we can go at this existing rate. It's considerable. I wanted, at some point, we did figure that out. I want to say it was 300 and some months, but they're giving me some numbers here. It was quite an extended period of time. And what those numbers were, and I'll get back to you, Senator Clem, with better information on that. But that was not even accounting for monies that are going to be continuing to come in to pay into the fund. So I will get you more specific information on that. But I feel comfortable about where we are right now, and recognize that a lot of the money, the amounts that I just gave you, that's complete federal funding that will be paid for those federal programs. They're 100% federally funded. So if that helps, but I will get you more information on that as we go along. We've got right now total employed, or maybe what I'll do is I'm going to ask our expert in that area if she would be willing to, Andrea Hickson, to come up and give the numbers that are of employed and unemployed, so she can give you some context on that. We did it this way so that we could have the experts in the room that could get down in the weeds with you and get you these really good answers. So thank you for your indulgence while we get her up here and give you those responses. Thank you. Thank you, Andrea.
While we're waiting, Co-Chairman Scott, I do see your hand as soon as we finish this off. Let's just go ahead, Andrea.
Good morning, Mr. Chairman and committee. The total labor workforce for Wyoming is about 290,000. So we have employed as of April 2020 of 266,000. The unemployed is 28,208. Prior to that, in March of 2020, we had about 280,851 with 12,754 unemployed in March.
Okay, anything else, Representative Clem?
No, thank you, Madam Chairman. Thank you for the answers.
Okay. Co-Chairman Scott. You're still muted. I'm trying to unmute you for you, but it doesn't seem to want to let me do that.
Yeah, it
there you
did
go.
something wild to me. Okay, I've got
You're
it
on.
now.
There you go.
General request for all the presenters. Remember, not all of us work in all your areas all the time. Please spell out some of the acronyms because you're losing us sometimes. And specifically for Director Cooley, you talk PEC and I don't know what the initials stand for.
Director Cooley.
Chairman Wilson, Co-Chairman Scott, thank you. And I apologize for that. The PEUC is Pandemic Emergency Unemployment Compensation Program. And that's, again, that's the program that provides an additional 13 weeks of eligibility to individuals that are seeking unemployment insurance benefits. When I talked about the PUA, that is the Pandemic Unemployment Assistance Program. That's the program that allows the gig workers, unemployed or self-employed individuals compensation. The FPUC is the Federal Pandemic Unemployment Compensation Program. that is the $600 additional for any person that qualifies for unemployment benefits. So I think those were the acronyms I used, and I apologize, I did not spell that out for you.
Okay, thank you.
You bet.
Right, any other, Representative Clem?
Yeah, thank you, Madam Chairman. I did have one that came to mind. Director Cooley, and can you give us, I know we're not through with May yet, but we're toward the end of the month. Can you give us an indication of where our unemployment numbers are going from here? So I just did some quick math, and 15,454 workers that are unemployed from March to April. Where are we kind of in the context of things? Where are we at, or where's our trajectory in May? And I also want to commend you and your staff for the work that you're doing given the circumstances, and also highlight the fact that Wyoming, as you mentioned, is better off than many other states. And I think that is due in part to the fact that our governor did not issue a stay-at-home order, which I think really played an effect in other states. And so I think that should be counted as a success here in Wyoming. Thank you, Madam Chairman.
Director Cooley.
Chairman Wilson, Representative Clem, we were going to provide you with a Tableau document that showed some of that graphing, but I thought that might take too long, so we did not. But I can refer you to that, and what that shows is we had an initial, at the start of this in March, we had an initial, of course, influx of unemployment benefit, both renewed claims and new initial claims. What you've seen on that chart is that has slowly gone down, and we've now plateaued off with the numbers that we're seeing both in new initial claims and reopened claims. So I think that we've seen a level of plateauing that I don't, it's been plateaued now for at least the past 2 weeks, which does give me a level of comfort that maybe we've seen from unemployment purposes, we've seen the worst of it, and now we're coming down just a bit with those numbers.
Okay, any more questions for Director Cooley? Great, thank you so much. I think obviously your agency is really one of the tips of the spear, so to speak, as far as our ability to help our citizens. So we're glad to hear. If you feel like there's anything that you need to just send out, in a typed up form or something like that to the committee, feel free to do that. But thanks very much. And to all of you that, Chris especially, that pitch hit at the beginning. Very good. Thanks so much. Okay. Committee, I'm thinking if we look at our list on the agenda, we'll, Department of Health, our dear friends at Department of Health are used to always hanging around. And if we perhaps dispense with the other agencies that won't have to be here the rest of the day, we might let them go back to work. So do we have folks here from Homeland Security that want to say anything? Are they in yet, Elizabeth?
Ma'am, we're admitting them right now.
Very good. I feel like I should say the envelope, please. Because I don't know who it will be.
Okay, now.
Madam Chairman, this is Stephanie Pyle with the Wyoming Department of Health, and the sound cut out momentarily, so I'm not sure if you're calling on our agency right now.
No, we were going to actually let you folks sit around and cool your heels for a little longer because you're always with us. So we figured we'd get Homeland Security in and send them on their way.
Representative Wilson, this is Director Budd from Homeland Security, and actually our presentation is a part of the health presentation. So,
well then, seeing as you're all there and ready to go, let's hear from you. Department of Health will have to hang around a bit, but we would be glad to hear from you. And welcome, Director. Are you all at that table? You look very small, but that's fine. We can hear you. And welcome, Director Budd. I don't know in my time that you've been in at Department of Health, but I have to say that I think over the next year or two, you folks will be much more frequent visitors. So, Director Budd, whoever, I can't identify all the little Department of Health heads that look like about 1 millimeter. What's the smaller than a millimeter? A nanometer. I don't know, something very, very small heads. So you'll just announce yourselves as you talk, if you would. Thank you. Go ahead.
Thank you, Chairman Wilson. I believe that our Director, Mike Ceballos, will kick us off. So Director and Deputy Director Stefan Johansson are likely on and ready to kick us off.
Okay, go ahead. Oh, and I don't know, let me just say before you started, I'm not sure if you were here at the beginning, but I did want to be clear, and I've tried to be clear to any people listening in, that we certainly do expect to have a full after action report for our August meeting when we can hear everything that you've done and what worked and what didn't work, as far as going forward. But we don't want to hear all of that today because obviously the situation is still ongoing and you don't know all the answers yet. So we're really hoping for a very condensed version of the situation, and particularly to hear if there are urgent legislative needs that we can accomplish in the next month. Thank you.
Very good. Thank you, Chairman Wilson. I'm going to give one last opportunity for our Director and Deputy Director to jump on, and if they're not on, then I will start us through the presentation.
Madam Chairman, this is Stefan Johansson with the Department of Health. Can you hear me?
I can hear you fine.
Very good. So before I hand it over to Director Ceballos for some introductory comments, just a quick question. You had mentioned that you're looking for kind of the most urgent needs and quick updates on this. So the committee did receive our presentation materials. We're happy to abbreviate that if you'd like, or we can go through the slides on COVID-19 updates. It's really at your discretion, Madam Chairman.
Let me just check. Elizabeth, did that get emailed? I am not. When would I have received that?
Ma'am, you would have received that earlier this week. I'm looking to see if I can find the precise date for you.
Yes. I don't seem to have it. I certainly don't have it sitting up on my screen.
Madam Chairman.
Yes, or I'm sorry, I was looking. Okay. Oh, look, here we have it in front of us. Good enough, but but sorry, I was searching my inbox. But Elizabeth, if you can see when it was sent, just so that I can identify that later. Go ahead, Stefan or Director Ceballos.
Thank you, Madam Chairman. I'll hand it over to Director Ceballos.
Chairman Wilson, Chairman Scott, and committee members. Really, to your point of making it tight, what I would tell you is that all of our divisions have been on mission. They're providing the support. They're taking the actions that they've done traditionally. I would have to tell you, obviously, this has been a different, maybe exploratory time. There's the magnitude or the expansion of the work that we've always done has been to a much greater degree, and all of the divisions. Medicaid certainly has had new flexibilities in some sources. Behavioral health has been working on the task forces. Aging, certainly there are a lot of the folks that are at most at risk, and then public health you've seen daily in terms of what's even on our website. The usage of our site is exponentially high. It's just amazing. So I don't know that there's a lot that I would add. The 5 facilities clearly we haven't been able to have folks work from home there. Their missions are to provide services to folks. And again, they have been doing that. And again, because oftentimes our patients there are folks at risk have really been working extraordinarily long and committed to making sure that we protect, again, the patients and our staff. I think we're going to have one small request that Stefan will talk about later with some help on testing. But other than that, we're really just prepared with the slides that Stefan has up on there to work on the committee's agendas and issues today. So that I would provide you as our quick introduction.
Okay.
Thank you, Director Ceballos. So, Madam Chairman, I will be as brief as possible. I will mention that I'll be joined in the next couple of slides by Dr. Alexia Harris, our State Health Officer, as well as Stephanie Pyle, the Senior Administrator for the Public Health Division. And as Director Budd mentioned, we'll kind of have some joint slides that Director Budd will go through about the unified command structure between the Department of Health and the Department of Homeland Security. So really quickly, like I mentioned, we'll be brief, just 3 high-level topics. I want to show the committee some of the high-level COVID-19 trends, and as Director Ceballos mentioned, where to access that information, both on our public website as well as some sub-pages of that website that shows the data that we're working with, the data that's coming in on a daily basis. We'll also talk about the Department of Health's response, including the infrastructure that has supported that response, a summary of the public health orders, and that's very quick, but we can answer any questions the committee might have about the most recent announcement of the continuation of the public health orders and the changes that were put into place that will go into effect on June 1st. I'd also like to give the committee just a very brief update on the Wyoming State Hospital. Those of you on the committee might know that the state hospital was the only one of our 5 Department of Health facilities that did have COVID-19 patients in their care and custody. I'd like to give the committee an update on how that went and what project resulted from that, and actually some good news about the state hospital, and really a kudos to that facility. And then, as Director Ceballos mentioned, a potential, no bill draft here, no language yet, just a potential concept over the coming weeks and months as this committee meets or additional special sessions with the legislature are held, a concept for a statute suggestion that might benefit us during the COVID-19 pandemic for however long that ends up lasting. So without any further ado, Madam Chairman, in terms of the COVID-19 trends, there's really 2 sources for the committee and the public to access the data, and that's on our public website that you can see there, health.wyo.gov. And in addition to that, we have a hospital capacity dashboard that we, a couple of months ago when this pandemic began, we built it for the governor and the state health officer to be able to see on a daily basis where Wyoming stood with its hospital capacity. We've since integrated that into our public-facing website, as well as released that data to the public about 6 weeks ago. So those are the 2 sources that I wanted to go over here. You can see on the public-facing website, if you go to the COVID-19 page, kind of a summary sheet here with our testing numbers, our cases by county, et cetera. But there's more detail on all of these tabs that you might have seen. We have information for healthcare providers. That's both instructions as well as health alerts that have gone out to various types of health providers or all health providers. We do have a map with some case statistics. Bear with me and I'll blow this up a little bit, where you can see every day kind of what we're tracking in terms of lab confirmed cases, probable cases, recovered cases, deaths, and see that kind of in a map by county that you can hover over and look at what the most recent cumulative data is. In addition, there's a few other graphs using the data that our epidemiologists track and collect. So you can see the lab confirmed cases by the date that symptoms were noticed or the date of symptom onset. as well as, again, some more granular data, like our daily number of cases, daily number of recovered cases, and the percent that are attributed to community spread or unknown exposure. That's a very important metric to that we want to see maintain or decrease, where essentially these cases are not able to be tracked to a known exposure or a direct contact with COVID-19, which indicates that you have community transmission. So a couple of important metrics here, and then some also the data carved out by demographics. In addition to that, Madam Chairman, we do have on the same page here the ability to see the Department of Health testing data. So for all of our COVID-19 testing that's occurring in the state, both at the Public Health Lab, which is shown as WPHL here, Wyoming Public Health Lab, as well as our non-Wyoming Public Health Lab resources, which are generally private, commercial, and reference laboratories, as well as in-house hospital laboratories that result test. What I want to mention here is that you can notice, if you look at the dates, there's a little bit of a lag on this data coming in, especially as it relates to private and reference laboratories. That data comes in generally, several days after the fact, so you do see a little bit of a lag issue, but you can get a sense of the general trend, moving up here in the number of tests that are being conducted in Wyoming. I think the most important metric, Madam Chairman, on this page is really our overall COVID-19 test results, positive and negative. And you can see here that the vast majority of our tests are resulting negative at over 96% of the tests conducted both at the Public Health Lab and private reference and hospital-based laboratories are resulting as negative, with about 3.5% of those tests resulting as positive. That is a good metric. It's somewhat indicative of some of our neighboring Mountain West states, which have seen lower positive rates for COVID-19 testing compared to other states in the country, maybe with the exception of Colorado. What we do want to see, though, is this number again maintain or decrease. When you see very high percent positives of COVID-19 testing, it can indicate a couple of things. The knee-jerk response is to say that it indicates you have more virus in that state or in that area that you're testing, but it can also indicate that you're not testing enough or the right population. So, for example, 4 or 5 weeks ago, the state of Colorado was showing their total percent positives of all of their tests was close to 20%. And that's probably not an accurate population figure, but indicative of testing, a lot of sick and symptomatic patients and less wider scale sort of population-based testing, and also indicative of what every state has been facing, which is some limiting supplies that really prevent broader testing, which we'll get into here a little bit later. Very quickly, Madam Chairman, just to wrap up here, I did mention that we have, like I said, the orders and the guidance documents that are provided, so you can look at the most recent versions of the public health orders, the most recent version of Wyoming Department of Health guidance documents to various entities, provider groups, et cetera, as well as links to guidance documents and resources from the CDC. In addition, Madam Chairman, we do have similar data prepared, not just on the statewide level, but for all of our counties. This is data that the counties and the county health officers receive on a daily basis, really showing the same kind of trending of COVID-19 information on a county-by-county basis. So again, just FYI to the committee, this is kind of a one-stop shop, this website, and a resource for all of your COVID-19 data. The last thing I'll mention, Madam Chairman, is, like I had said, the hospital capacity dashboard, also available on the public website and available to the public. We are trending the reported COVID-19 hospitalizations on a daily basis. This is data that all of our Wyoming hospitals, which we are certainly appreciative of, are reporting to us on a daily basis. So the first graph you see here is every day the number of COVID-19 patients that our hospitals are reporting they have in their facility that day. So if I go to the most recent day here, which was yesterday, we actually have the data for today, Friday, but it has not been entered yet. We're tracking 4 COVID-19 admissions at the Wyoming Medical Center, 1 at St. John's in Teton, 3 at Sage West Riverton campus, 4 at Ivinson Memorial in Laramie, and 3 at Washakie Medical Center. So as you can see, we trend this on a daily basis. And as some of you may have seen in the governor and the state health officer's press conference over the past several weeks, these are all data and metrics that are being used holistically. So that's a point we've been making a lot, is there's not one specific metric like the number of COVID-19 hospitalizations that we have today that would tie directly to a specific administrative or legal decision. For example, if we got to a certain number of hospitalizations, we would take additional legal action or easing of restrictions on gymnasiums. That's very rare that we have a data point in a pandemic or from the epidemiological perspective that would tie directly to one of those. So with all of the high-level metrics that we're looking at, both in terms of the number of cases, the percent attributed to community spread, our hospitalization rate, those are all things that we're taking kind of as a report card to show us as a state and at the county level how much risk from a public health perspective we think is safe and that we're willing to take on as a state or as a county. So as you've seen some of the orders over the past several weeks and most recently this week start to be relaxed, additional number of people allowed in gatherings, businesses being opened, just wanted to give you a sense of some of the data that we're looking at. In addition to the number of COVID-19 hospitalizations, we are also tracking the overall hospital system capacity, not just for COVID-19. So you can see our total number of ICU beds in supply versus the daily use of ICU beds. So we want to see that, be relatively stable as we make some of these decisions as a state and with our county partners on how to respond to this public health crisis. Same thing with ventilators, looking at our total supply as well as those that are reported as being in use. In addition, like I mentioned, Madam Chairman, we are also tracking hospitals that are able in their own laboratories to conduct in-house COVID-19 tests. And you'll see here with the cumulative number of tests that we track on a daily basis, about 2,700 tests have been able to be conducted by hospitals. So that's essentially not having to send samples to the Wyoming Public Health Lab or to a private and commercial laboratory. And we've done work both at the state level and in conjunction with the federal government to try to distribute testing resources to our hospitals and gear up their capacity to be able to conduct these tests essentially on their own. And still get that data reported to us, which is nice. So you can see the total number of hospital-based tests here, as well as the cumulative positive percent, meaning out of those tests that are conducted by hospitals, how many are resulting positive. And you might notice this percentage is a little bit lower than the statewide percentage of positives at around 3.5%. And we hope that that's a good indication of a different population being tested potentially by hospitals. And again, we want to see that number maintain or decrease with the numbers that are resulting as positive. So trying to take many of these metrics from multiple different angles and again, provide a little bit of a universe of information about COVID-19. Finally, Madam Chairman, all of this data with regards to our hospital system, ICU beds, ventilators, isolation rooms, medical surgical rooms, and kind of a most recent snapshot of the entire state when it comes to ICU beds, but broken out by county. Same thing with ventilators. The purpose here is really to keep a daily tab on what's happening overall in our hospital system. Again, it's not reviewed or tracked in isolation, but it's part of that overall ecosystem of data and metrics that we're looking at to give us the best information that we have. None of it's perfect, but the best information that we can gather and produce to inform the state health officer and Department of Health decision making, as well as the governor's decision making. So, Madam Chairman, I know that was a lot really quickly. I will stop there, see if there's any questions before we move on to describing some of the Department of Health's infrastructure and also Homeland Security's partnership with the Department of Health and Unified Command. But happy to answer any questions about the data sources we have or the data that I presented here.
Sorry, muted myself. Questions for Mr. Johansson, and if you've got a question, make sure to put your blue hand up, because while this PowerPoint is up, I can't see everybody's face all at once. Representative Clem.
Yeah, thank you, Madam Chairman, and Stefan, thank you for that presentation. I appreciate, excuse me, all of the data that you guys have been collecting. It's very, very helpful. Here's the thing, though, that I'm kind of missing, and maybe you can speak on this, or I thought about our Department of Homeland Security as well. What I'm struggling with, I mean, this is a really good job at tracking the behavior of this disease. And early on, we didn't know how dangerous this was as far as assessing the actual threat of COVID-19. My struggle is what data or what science, what studies do we have that indicates what kind of threat we're actually dealing with? Because even with those that are tested, right? And I guess one of the questions I have is do we have any idea of how many people were denied testing when we were going through this testing? I know that we didn't have enough and many were denied. And so given the fact that, those tests are only good so as far as someone is actually infected with the disease. But if we need in order to find the true prevalence of this disease and therefore the true mortality rate and the danger that we're dealing with, it seems to me that we need to have some kind of antibody testing to determine how much of the population has truly been infected. And so I know early on, and it's not just our state, but our country, we didn't know what kind of threat we were dealing with. We were going off of models that were based upon assumptions. And I'm wondering where in the time that this all began, how has the needle moved in assessing the actual threat so that we know whether our responses are appropriate or not as far as public policy and shutting down the economy. Thank you, Madam Chairman.
Mr. Johansson.
Madam Chairman, Representative Clem, it's a great question. I'll try to take it in pieces, and then I'll kick it over to Dr. Harris or Stephanie to weigh in from the public health perspective. Just real generally to your many questions and points there, I think there's still a lot of unknowns about this virus. I mean, when you have a novel virus, that's kind of the nature of the beast. That, like you mentioned, in the early stages of this, both internationally and then with this country, there's just a lot that we didn't know about and still don't know about its true transmission rate, attack rate, incubation period. I mean, there's a lot of science that will remain to be known until it's studied further. To your point about antibody testing and what's also called serology testing, we would be right there with you thinking that's something that is needed. I'll let Dr. Harris speak to kind of the current tests that are available, the quality or lack thereof of those tests, but I think in concept, we're all on the same page that in order to really get good information about the true nature of the virus, all of the testing resources, including antibody and serology testing, need to be developed and need to be used to determine some of the factors that you mentioned. In addition, you're absolutely right that in the early stages of COVID-19, both nationally and all of the states, testing was significantly biased towards the sick and the symptomatic. I think that has been gradually improving as supply chains have improved when it comes to sample collection kits and other testing supplies and testing platforms that have been distributed, that we've been able to distribute, that the federal government has distributed, but it's certainly not perfect. And I think as it improves, we hope to do wider scale testing, both from a diagnostic standpoint as well as in the future when the technology is there and when it's developed to do wider scale serology and antibody testing to learn as much as we can about the virus, to hopefully prevent as much as we can a resurgence. And also, I think what we're all gearing toward in state government, Department of Health, Governor's Office, and all of our other partners is to try to have in the fall and winter months, or however long it takes to get to the development of a vaccine and the distribution of a vaccine or some sort of treatment for this virus, we're all trying to develop plans, including the testing that you're talking about, to try to avoid the the response, the legal responses that had to be taken in the early stages of this virus when it comes to economic decisions of restricting business activity, restricting gatherings, et cetera. So that's, I think, what we're all gearing toward. But I would be remiss if I didn't let our fantastic state health officer weigh in on some of the good questions you asked, Representative. So Allie, are you on the line with us?
I am, Madam Chairman, Allie Harris, State Health Officer, Department of Health. Thank you. Madam Chairman and Representative Clem, I'd like to echo everything that Stefan said and agree with Representative Clem that we do need to understand the true prevalence rate and mortality rate of this virus, but unfortunately are just not there yet based on some of the factors that both Representative Clem and Stefan touched on, the lack initially, especially of widespread testing of everybody with symptoms, as well as prevalence testing of the population without symptoms, knowing what we know now of the of the contribution of asymptomatic and pre-symptomatic spread of this virus. To go a little bit more in depth into serology, unfortunately, there are extremely few peer-reviewed studies currently based on serosurveys or serologic studies to determine the prevalence of past COVID-19 infection. Those studies are going to be very key as we move forward, but they are dependent on having good antibody tests. It is becoming very clear that not all of the serologic tests that are in use are good tests, meaning that their sensitivity and specificity is either not known or shown to be poor. There is possible cross-reactivity with the other 4 common coronaviruses that circulate every year throughout the United States. In fact, the FDA has recently withdrawn multiple serology tests from the market for failure to meet standards. Furthermore, it's important to remember that the performance of these types of tests vary according to the prevalence of people with antibodies in the population. So the lower the prevalence of people with antibodies, the higher false positives that you're going to get, to the point where you have a low prevalence, the false positives can far outweigh the true positives with these antibody tests. And so while I absolutely agree that these studies are going to be essential for being really able to understand the percent of the population that has had it and then therefore calculate the mortality rate, we just aren't going to be there yet until we have known good testing. CDC is currently investigating which serologic tests are reliable, and there are large-scale prevalence studies planned throughout the United States, but I do think it is going to be several more months before we have some real answers to that. Of course, the other factor in calculating mortality rate is the number of deaths. It's pretty widely agreed on by epidemiologists that the number of deaths due to COVID-19 is also an underestimate, along with the number of cases, because of the same testing problems that contributed to the underestimate in cases in the first place. There is some data around excess mortality in the US suggesting, again, agreeing that we are likely undercounting COVID-19 deaths as well. So unfortunately, the situation we're in is where both the denominator, the number of total cases, and the numerator, the number of deaths, are likely underestimates, but both are unknown. So I think I'll stop there. Thank you, Madam Chairman.
Representative Hallinan.
Thank you, Madam Chairman. I would ask Mr. Johansson, are all of the graphs that were presented to us, they're very useful, are those all found at health.wyoming.gov? Mr.
Johansson.
Thank you, Madam Chairman. Representative Hallinan, yes. One small correction, it is health.wyo.gov, so health.wyo.gov. And it should, when you go to that page, there's a ticker that comes up for coronavirus or COVID-19, and it says learn more. That will take you to the page that has all of the daily epidemiological data, testing data, as well as links to the county level data and the hospital capacity dashboard. But Madam Chairman, I'm also happy to send all of those specific links and URLs to the LSO so they can distribute based on our presentation here.
Think that would probably be helpful, although I've been looking at them for a month or two now, and they certainly have, they've been developed over time, and I think you're doing a good job on that. Representative Clem.
Yeah, thank you, Madam Chairman. Just a quick follow-up on the serology tests. And Stefan or Dr. Harris, are we doing any kind of studies in Wyoming, or are we, as far as some of the studies that are planned, is our state going to partake in any of those studies? I'm just trying to figure out where we're going from here. And if not, my thought is would the Department of Health be open to that, either in conjunction with the University of Wyoming and our community colleges, or perhaps another university or research institution? My thought is, and I understand as far as, particularly when it comes to, the serology tests and whether they're accurate or not, it would stand to reason that you would need some kind of control group. And those who have already tested positive could serve as that control group. But I'm curious on your thoughts on that. I mean, I've even thought about using some of our CARES Act dollars to maybe commission some kind of study in the state of Wyoming, and even use some of that money to give participants in that, a stipend of like $25 for participating in such a study, so that we actually can determine what the rate of prevalence is in Wyoming. So if you could speak on that, I'd appreciate it. Thank you.
Dr. Harris or Mr. Johansson?
Thank you, Madam Chairman. I'll speak very briefly first and then hand it over to Dr. Harris. I did want to mention, Representative Clem, to your question, just in general, a concept about somewhat of a three-pronged approach that we're taking in terms of planning for COVID-19 testing. And the first is obviously to maintain and in fact increase the diagnostic testing capability for symptomatic patients, as well as some asymptomatic patients when the situation is needed. For example, in what we're seeing in some of our long-term care facilities, that we're doing the best we can to try to prevent outbreaks and clusters, and by nature of that, in conjunction with guidance from the federal government, trying to test larger portions of those populations, both staff and patients, on a periodic basis. So the first prong is really, better and more prevalent diagnostic testing. And the second, kind of continuing from that example of long-term care facilities, is obviously wider scale testing of asymptomatic patients and the general population, whether that's on a random basis, or whether that's with employer partners, or like you mentioned, the university has a lot of students and a lot of staff. We're developing plans to be able to have wider scale population-based testing, both for diagnostics and potentially for surveillance studies using those tests. The problem that we're running into there, and that we have some optimism to hope it will improve in the coming weeks and months, is, as you know, that the current test, the best test and the most sensitive test, is using a pharyngeal swab, which really has to go pretty deep into the nasal cavity and into the throat. It is quite invasive. A lot of reports of unpleasant nature of that test, and it doesn't lend itself well to kind of rapid, easy collection that can be done on a more heavier volume and a more frequent basis. So as other tests become available, we're working with partners in the private sector to try to procure cheek swab tests, saliva and sputum tests, as well as waiting patiently with our partners and others to approve saliva testing for COVID-19 that can be done on the machines that we have. So I think the future is bright there, and going to be certainly better when it comes to easier to administer COVID-19 tests, and basically easier to collect data to answer some of the questions that you're having. And finally, the third prong would be exactly what you're talking about, which is antibody testing and serological surveys of the population to really determine after the fact what you were mentioning in studying not only the prevalence of the virus now, but what was the prevalence of the virus, and how is it represented in the general population? What does that mean for employment, for economic reopening, or vice versa? But that's kind of the three-pronged approach that we're looking at, and trying to take kind of a diversified investment strategy, for lack of a better term, to, in the absence of many of these tools and supplies, trying to go across the board to either procure or develop our own capability to achieve the goals in those kind of three prongs. But Dr. Harris, please weigh in and correct me if I misstated anything.
Madam Chairman.
Dr. Harris.
Thank you. And I really don't have too much more to add from what Stefan said, other than to, confirm that serology tests are in our plans. They are in our plans that we are going to submit to CDC for how we will spend the CARES funding coming through our epidemiology and laboratory capacity grant. Again, we do think that it is, bad data, it does more harm than having no data at all when it comes to these tests. So we do really feel like we need to wait until we know that there is a test that's going to tell us specifically that somebody has been infected with COVID-19 and not another type of coronavirus or other virus. These were discussions that we had with the CDC team when they were here of a potential sero survey, but there was just no test essentially ready to deploy at that time. So we will absolutely continue those discussions, both with our state and federal partners.
Okay, Representative Hallinan. You're muted right now, Representative Hallinan.
Thank you, Madam Chairman. I would ask both testimony makers, what are the efforts being taken to prevent spread in the nursing homes and elder care facilities in our state, and the successes we are having or the lack of it? So that's my question to both testimony makers. Thank you, Madam Chairman.
Okay, Department of Health, whomever.
Madam Chairman, I will hand that question over to Dr. Harris to describe some of the recent developments with long-term care testing and preventive measures that are being taken. And I'll just mention, Representative Hallinan, that here in a few minutes, it's not a traditional long-term care setting, but I do want to give an update on the state hospital, and I think some of the lessons we've learned there that can certainly be applied to other settings. But Dr. Harris, please go ahead.
Madam Chairman.
Dr. Harris.
Thank you. So for nursing homes especially, there were actions taken very early on in the outbreak, which I think were very successful in preventing some of the devastating effects that we've seen in other states in long-term care facilities. And those were following recommendations to limit visitors, to limit interactions between the residents of these facilities, and employ strict symptom screening and isolation protocols when illness was detected in these facilities. More recently, we have begun a testing program in nursing homes. The first part of this is when we do detect a case in either staff or a resident of the nursing home or assisted living facility, or really any communal setting, we go on and test everybody in that facility, at one time, essentially. And the reasoning behind that is that, well, first of all, we need to be able to quickly detect the extent of spread within the facility so that infection control measures can be implemented, but also because it's been very well documented that asymptomatic and pre-symptomatic transmission contributes significantly to outbreaks in these types of facilities. So we can't rely on people having symptoms alone. The other part of this testing is essentially screening in facilities without known cases or outbreaks, testing a proportion or 20% of the population of both residents and staff on a regular basis. Every 2 weeks at first, so that we are identifying any potential cases early before there's extensive transmission, and again, so that infection control procedures can be implemented. Overall, I think that, and this is in large part to the steps that these facilities took, we have been quite successful in preventing spread within these facilities with, of course, really two now major exceptions, the Showboat facility in Lander and now the nursing home in Worland. We have tested a couple of other nursing homes when there's been a case in a resident or staff member and haven't found any other cases. Many states have had multiple large nursing home outbreaks, and so far we've been able to avoid it. However, this is one of the the measures and the factors we need to consider going forward. Preventing outbreaks in these facilities is going to be an essential component of this response for, essentially until we have an effective vaccine.
Representative Yin.
Thank you, Madam Chairman. This is for Mr. Johansson, Dr. Harris, and possibly Director Budd. So I want to thank you all for the work that you've done so far. My question is, do you think that the supply chain of testing supplies and everything required to run testing has stabilized at this point, or is there any risk of us having to ration tests again? And if there is a risk of the supply chain being constricted, what are the strategies that we have to make sure that we can contain any outbreaks that come in the future? Thank you.
Department of Health.
Madam Chairman, this is Stefan. I'll be brief in my comments and hand it back to Dr. Harris and Director Budd. To your question, Representative Yin, I think we have seen some improvements of the supply chain specific to testing supplies over the past 2 months, certainly since the beginning of the outbreak in this country and when we detected cases here in Wyoming. There are still very much present limiting factors at our public health lab as well as other laboratories, I presume. The vast majority of those limiting factors are really the availability of swabs, and those are very specific swabs, not Q-tips, but very specific swabs that are being used to collect the samples, as well as some limiting supply of reagent that needs to be used in a laboratory setting. We have had some success in being able to purchase reagent and also being able to purchase and distribute it from our federal partners and with help from Homeland Security, swabs to send out to healthcare providers and mitigate some of those supply concerns. But I would say, from my perspective, just on the policy and the administrative side, I think it's a mixed bag, Representative, that we can't say that we have a fully improved and stable supply chain for those types of resources right now, and it really does change week by week and is pretty different across the various hospitals and clinics and providers that we have. But Dr. Harris and Director Budd, please feel free to weigh in.
Madam Chairman.
Dr. Harris.
Thank you. I would agree with what Stefan said. There are still specific types of supplies that are really just being allocated now and not sort of available as widely as we want. Swabs being the primary one at this time. Ways we're trying to address that, as Stefan said, is to diversify the types of testing that we have available. So testing that involves saliva, for example, that does not require swabs. Another factor I think is important to discuss is rapid testing. I really feel that rapid testing at the site where the patient is really critical for Wyoming. There is not likely to be another high complexity lab in Wyoming that's able to bring on the type of tests that the Wyoming Public Health Laboratory does. These rapid tests give a result usually within minutes to hours to allow providers both to make recommendations to the patient in terms of isolation and prevent further spread, but also be able to, save the PPE for the patients that actually have COVID-19. These types of rapid tests are being, really carefully allocated by the federal government at this time. Again, not something we can just go out and purchase, even with all the CARES funding we have. So I think it's going to be very important for us to be able to continue to procure these types of tests for Wyoming facilities. And then finally, we are using the CARES funding to expand throughput within our public health laboratory to be able to increase by several times the number of tests that we can run per day. So I agree. I don't think we're out of the woods quite yet in terms of just knowing we're going to have all the supplies we need for testing. I think that's improving as these companies, especially the rapid testing companies, ramp up production of their materials. But we are in a much better place than we were a month ago.
Representative
Madam Chairman.
Oh, yeah, who is this? I'm sorry.
This is Lynn Budd with Director of Homeland Security.
Director Budd.
Yeah, I just wanted to add a quick comment on there, and we'll get more into the role our office plays in this response in a few minutes. But, one of the things that we can do to assist the Department of Health is monitoring those supply chains at the local, state, national, and international level with our other federal partners, and then work in conjunction with FEMA to try and obtain as much testing supplies as we can, as well as PPE. So that's kind of the role that we play in that.
Okay. Representative Barlow.
Thank you, Madam Chairman. Thank you for all the testimony this morning. One of the things we've heard some discussion about was the surveillance and the use of testing. In some of the health orders and other discussions, there's been use of temperature checks. And so, and there's obviously there are folks out there wanting to provide services. So I guess my question for Dr. Harris maybe is, as in some of the surveillance type work and looking for trends and early detection type things, is taking of temperatures, whether in a specific setting or across a population, what kind of merit or value might that have? Thank you, Madam Chair.
Department of Health.
Madam Chairman, Representative Barlow, thank you for that question. I think there are a couple of factors that play into this. In the orders, when we talk about screening, we're really talking about verbal screening. So asking, whether people have fever or other symptoms that could be consistent with COVID. I think temperature checks have some value, but it is important to remember that not everybody with COVID-19 will have a fever. We've certainly seen examples of people with relatively minor symptoms, sore throat, runny nose that have COVID-19 and that have transmitted it to others. So reliance on fever in itself, I don't think I would want to put all of the emphasis on that. The other thing about temperature checking is that it can involve, required close contact between one individual and another. I think we'd have to question whether putting people in close contact for screening for only one symptom of COVID-19 would be worth it. However, I do think surveillance for essentially syndromes or symptoms that could be consistent with COVID-19 is valuable. We do that for influenza. We have providers around the state that report to us illness that is influenza-like and send us tests from the patients they see so that we can monitor the extent of influenza-like illness in the state, as well as what types of influenza viruses are circulating. I think that implementing a surveillance system similar to that for COVID-like illness, they're not exactly the same, would be beneficial, and it wouldn't just rely on temperature checks in and of itself.
Okay, Representative Roscoe.
Thank you, Madam Chairman. Dr. Harris and Mr. Johansson, having seen our parks open up and tourists coming in, I was wondering if there are any planned preparations or responses if there were to be an outbreak that we could expect. Thank you.
Dr. Harris.
Madam Chairman, yes, we have worked with both Teton and Park counties, as well as the National Park Service, to address the opening of the parks in a couple of ways. With the help mostly of the governor's office, we procured an extra 500 tests each for Teton and Park County per week. These are the rapid type of tests that can be done at the site of the patient. So 500 extra, essentially, testing supplies will be going to St. John's and Powell Valley Healthcare per week during the summer season, both to ensure that we can test all symptomatic persons, but as well to do some enhanced surveillance. both Montana and Park County, Wyoming are working with Yellowstone to do some surveillance of the National Park Service employees. And we've begun discussions with Grand Teton to do something similar to that as well, to ensure that we're detecting any outbreaks early on before they become widespread.
Okay, Representative Hallinan.
Thank you, Madam Chairman. This is a question for Dr. Harris. What are the recommendations that you give to the nursing homes and long-term care facilities reference their isolation procedures that are given for the positive staff or positive patients that are tested for COVID?
Dr. Harris.
Madam Chairman, Representative Hallinan, for positive patients, we essentially recommend either isolation or cohorting, so ensuring that positive residents are either alone in their room, or if they need to have a double room, in a room with another positive patient. They really do need to remain in their rooms, not have interactions with other residents, as well as staff need to wear, the recommended personal protective equipment or PPE when they go into those rooms. For positive staff, we recommend that they isolate at home until the end of their isolation period or resolution of illness. Symptomatic staff need to isolate at home until they have, till their illness has resolved. This, of course, can create some staffing issues in these places. And so because of that, and according to CDC's recommendations, positive asymptomatic staff can continue to work with appropriate PPE, so 100% masking, which is what everybody in the long-term care facility should really be doing. And they should, again, be cohorted with the positive residents that are there to ensure that, again, we're not spreading the virus through other places in the facility.
Okay, Senator Schuler.
Thank you, Madam Chairman. First off, just a comment for Mr. Johansson. I really feel like the situation at the state hospital was turned out to be very positive, and I wonder if you might walk, the folks through that whole process maybe just a little bit, because I think it was a success story. But I noticed that when the CDC came in to do some testing as a follow-up, there were about 66% of the staff there that were tested. And I guess my question is, were those tests optional, or were they required for the staff and the patients? Thank you.
Mr. Johansson.
Madam Chairman, Senator Schuler, thank you for the question. To answer it simply and directly, the tests were not required. We didn't really have a problem with compliance in terms of patients or staff refusing a testing. I think largely that was due to the nature of where the virus was in the state. Obviously, I think there's a lot of uncertainty and angst around people who work in healthcare settings. So we did get a good compliance rate. As you mentioned, it was over 60% of staff and patients that were tested in that survey that the CDC helped us conduct. I will mention on the patient side, as you know, Senator Schuler, that is not something that would ever be mandatory for patients unless there was a immediate threat to life safety. So we did make that voluntary as well for the patients. But like I said, we got a good compliance rate, and the good news there, kind of preempting a slide a couple minutes from now, but I think it's a good opportunity to talk about it. We did have 0% of those tests result positive, so all of the tests at the state hospital came back negative, and I think it's just attributed to the plan that we put in place there, which really was some substantial physical plant modifications, creating an admission unit for all of the admissions that we were doing, to go through a certain unit, do as much isolation and quarantine in those initial days as we could, knowing that it's a psychiatric hospital setting, so our well-being and treatment of the patients is of utmost concern, but also their safety when it comes to this viral spread was the balancing act that we and the state hospital staff were trying to manage. So with when we got the patients, there were 2 patients that were transferred to the state hospital, unknown that they were positive at the time, but in conjunction with the plan that we implemented, we did have a universal testing policy on all of our state hospital admissions. So the patients were immediately tested upon admission, not commingled with other populations, isolated as much as possible while we waited on the results. And when those 2 positive results came back, we had created a unit at the state hospital using some unused space of a wing that has not been inhabited for a number of years to create a COVID-19 unit where treatment could be given both psychiatrically and health conditions, as well as Dr. Harris mentioned, cohorting those patients and staff together, limiting the number of staff that were assigned to the unit, but also having as much universal PPE adherence as possible with our staff, and everybody did a really great job. I think the fact that we didn't see additional spread in that facility was a huge positive for the state hospital. And after that, what's called a point prevalence survey, that 66% of the population there that was tested with the help of CDC. CDC has decided to do a write-up, both very positive feedback on our infection control processes, what we did with admissions, what we did with isolation. But I'll let Dr. Harris speak to this too, because we have been given word that they are moving forward with a joint publication between the Department of Health and the CDC, not only publishing the results of the positive outcomes from the state hospital's experience with COVID-19, but also using some of the protocols as a model for other mental health and psychiatric institutions around the country. So again, not to sound braggadocious, it really is the credit to the state hospital leadership and all of the staff there that implemented the plan that we devised in early March and held true to it. It really is the pat on the back goes squarely to the state hospital leadership and staff. But Dr. Harris, feel free to weigh in with any other information about the CDC study.
Okay,
Madam Chair.
I'm going to recognize Dr. Harris in a minute, and I'm just going to say I see hands up from Representatives Clem and Representative Hallinan. After that, let's pause on the questions just for a minute and let Department of Health finish their presentation, because it's possible that we may get some of our questions answered in an orderly fashion. Obviously, I was under an illusion to think that we would have 5 minutes or so per agency, but go ahead, Dr. Harris.
Madam Chairman, thank you. I'll just add that this is a publication that we hope to be in CDC's Morbidity and Mortality Weekly Report. There was never any guidance published specifically for infection control for mental health and psychiatric institutions. And clearly these institutions present unique challenges for infection control. So that is the reasoning behind publishing this is to share what we've learned with around the country.
Very good. When it's published, I hope you will circulate a link, but I think we will all like to know. Representative Clem.
Thank you, Madam Chairman. Just a clarifying question for Dr. Harris or Director Budd. Is it fair to say that all of our responses to mitigate the danger of COVID-19 is predicated on the assessment of the threat as compared to other communicable diseases? And with that, then, I just want to make sure or get a clear answer. Has the needle moved from March until now in assessing the threat, or are we still operating under the original assumptions that were made when this all began? Thank you, Madam Chairman.
Dr. Harris.
Madam Chairman, I would say that, one of the major goals throughout this entire response is to ensure that our healthcare systems weren't overwhelmed. We saw that happen in other places, including in places in the United States. When that happens, providers essentially have to choose which patients get beds, which patients get ventilators, which patients get life-saving care. The actions were took. Unfortunately, we knew that this virus was going to come to Wyoming, and once it was here, that it was going to cause illness and to cause deaths, and it will unfortunately continue to do that. that for, I don't know exactly how long, but likely until we have a vaccine that can, prevent people from getting infected in the first place. We have seen that our hospitals weren't overwhelmed. I do think that was in part because of the actions that we took, and is why now that we can start relaxing some of the restrictions, and to find that balance between knowing the virus is going to spread, and preventing our healthcare systems from being overwhelmed and deaths that didn't have to happen because of lack of access to care. That is still our goal. And of course, as we learn more about this virus, how it spreads in Wyoming, we will continue to modify our public health actions because of that. We do know more than we did a few months ago, but we still don't know everything. But thinking of our healthcare systems is still a primary goal.
So Dr. Harris, though, I think just to kind of clarify from Representative Klem's questions, the challenges that we're having across the nation in testing supplies or antibody testing are a significant part of the problem still. Is that correct?
Madam Chairman, I think in terms of diagnostic testing supplies that we're in a good place right now. We're able to test everyone who is symptomatic, and now expanding our testing for asymptomatic persons. But our problem is that we'll never be able to go back to the beginning of March or maybe even late February and know potentially everyone who had it at that point. And that is what we will need serology to tell us once we have a good test that we know tells us somebody had COVID-19. And so we aren't able right now to know exactly, what percentage of the population has had it. I'm not sure we'll ever be able to get an accurate count of the deaths that occurred when we didn't have testing. So we'll have to learn more about that going forward. But we just simply don't have all the data we need yet to know exact prevalence, mortality rate, all of those very important factors when we look at infection control.
And Dr. Harris, so clearly though, I mean, we don't do testing across the entire population for diseases anyway. I mean, we haven't tested the entire population of Wyoming to see if they have precancerous cells or something like that. I mean, so the thought that we would be able to just test everybody, we don't test everybody for all sorts of things. And to conceptualize saying to the citizens of the state, hey, everybody go by your health department or your doctor's office and get a test. Who will pay for the test? Where is the test? I mean, we don't do that for anything, really, do we?
Madam Chairman, you're correct that we don't. I would say the closest that we come is our influenza surveillance, where we really do get a sense of how prevalent influenza is in our state, but the numbers are never exact. We will never know the true number of people who have influenza. However, there are testing strategies and research strategies to develop estimates for prevalence, and that is where serologic testing comes in, or well-planned epidemiologic studies involving diagnostic tests that could take a sample of the population and test them regularly to sort of understand over time what percentage of that population is impacted. That is some of what we're trying to do with our long-term care facility testing, and then expanding that to other communal settings as well. And so a sero survey to be able to estimate prevalence is certainly something that we would want to pursue when that testing is available. But you are right that there is no disease for which we test the entire population. And for this disease, especially for the tests we have now, we'd have to test the entire population on a daily basis to get a true prevalence.
Okay. Representative Hallinan.
Thank you, Madam Chairman. I like to focus on the elderly population because that's the highest risk group. I think that we've made a success at the state hospital, and we've learned from that, and we're spreading that around the nation, some of that knowledge that we've gained. But we also have some failures. We have some failures at the Showboat facility and in Worland. I would ask Dr. Harris, what have we learned from those failures, and how can we prevent further failures of that sort? Thank you, Madam Chairman.
Dr. Harris.
Thank you, Madam Chairman, and thank you for that question, Representative Hallinan. I think from Showboat, that was extremely early on in the beginning of the outbreak. That was a very clear, that was before really nationally it was recognized that asymptomatic and pre-symptomatic transmission occurred. We focused our testing on symptomatic staff and residents. We've learned from that, along with the rest of the country, that is not good enough. You need to test everybody because you can't tell from symptoms who necessarily has it and who is spreading it. So I think that's one of the important factors that we've learned. In terms of the nursing home in Worland, I agree that I wish that hadn't occurred. I think that, from that we're learning when people come in, from outside of the nursing home or long-term care facility, from another healthcare setting or from another setting, more about the measures that it requires, to ensure that person is kept apart from the rest of the population. The really ensuring that staff, when they haven't had a case in the entire county for a while, continue to take precautions. I'm not saying that the staff did anything wrong in this case, but to keep, reminding everybody that these types of precautions are needed, even when the virus isn't very prevalent in your community, because we see how quickly it can spread in these settings. So I think it really requires vigilance from everybody, from public health, from providers, in caring for the elderly in these facilities.
Okay, Co-Chairman Scott, and then we'll go back to the department and let them work on their presentation a little bit more. Chairman Scott.
Okay, thank you, Madam Chairman. Following up on the question of what we've learned in the past 2 months, I continue to encounter individuals in the general population who say, look, we did succeed in flattening the curve, and who think that this disease has not proved to be more deadly, say, than the common flu, and question why they should take any precautions, including especially social distancing. What do I tell them in terms of what we've learned about how dangerous the virus is if you catch it, and why they really should continue to do the social distancing?
Dr. Harris.
Thank you, Senator Scott. I think, and Madam Chairman, I think the numbers do indicate that this is more serious than influenza, especially for the elderly population and people with underlying medical conditions. At over 100,000 deaths now in the 2 to 3 months since this outbreak has been occurring with COVID-19. That's already double the number of deaths that we saw in this flu season, and that flu season was over a period of 7 months. The same for hospitalization rate. We're at about the same cumulative hospitalization rate for COVID-19 in the 2 to 3 months of this outbreak as we were for the entire flu season last year. I think the other factor is that we don't have a vaccine or any immunity in the population, which many of us do for influenza. And we also don't have any specific treatments. We have very good medications to both treat and prevent influenza, but do not have that for COVID-19. I think that part of the reasons that we've been successful and haven't seen some of the devastating effects that we're seeing in other places is because people did a great job of social distancing. And that is going to continue to be very important, really for the foreseeable future.
So it would be valid to tell people, look, we have learned some things about how to treat this disease. We have made some improvements, but it is still much more deadly than a flu, and still something you really don't want to catch, and continuing to maintain the social distancing, which is in particular what people, the general population has control over, continues to be important in terms of preventing further deaths. Is that a safe thing to tell them?
Dr. Harris.
Madam Chairman, Senator Scott, I would agree with everything you just said, except for potentially that we've learned some things about treatment. We have some experimental treatments. We have remdesivir here in Wyoming. It is being used. These are still investigational drugs. They've shown some promise, which is why we're using them, but are certainly far away, unfortunately, from a known, safe, effective treatment for this virus.
It would seem to me that even though we haven't developed the kind of treatment we'd like to see, that our doctors and our nurses, particularly in the hospital setting, they've got to have learned some things, and we've got to be doing a little better. But my takeaway is that even if there are some improvements, they're not sufficient to justify letting your guard down.
Dr. Harris.
Madam Chairman, Senator Scott, yes, I would agree with all of that.
Okay, so committee, let's let the Department of Health move on with their presentation. We may be able to answer some questions through the presentation, and carry on, Stefan or Dr. Harris or Stephanie Pyle, whichever wants to take the next part.
Madam Chairman, sorry, I'm going to hand it over to Stephanie Pyle and Director Budd from Homeland Security to go through the next 4 slides.
Thank you, Madam Chairman and Stefan. This is Stephanie Pyle, the Senior Administrator of the Public Health Division. And in the interest of time and to avoid any duplication, I will be very brief. I just wanted to highlight for the committee some of the response efforts that are a little more behind the scenes. You've seen the data. We've talked a lot about the lab. I just wanted to speak for a moment about some areas of our division that the committee may be less familiar with, specifically our epidemiology team. This is a small but strong team working as a key component of the response efforts. This team works with individuals who have tested positive for COVID-19, providing them with valuable instructions, precautions to take, and ongoing monitoring in response to their positive test. They also provide contact tracing, an activity that our country has now become very familiar with, and they were probably not familiar with this activity before, but this has been a cornerstone of epidemiology in terms of conducting interviews with those who have tested positive for COVID-19, identifying who may have come into contact with them, and providing the necessary guidance and directions to those individuals to prevent the spread and slow the spread of the virus. The need we have in this area, which we were able to meet with current resources, is reassigning positions to expand this workforce. We've already done some reassigning of positions and pulled people into this realm, and we'll do that more with current positions that we have so we can continue to embrace these efforts and strengthen these efforts across the state. We've talked a lot about the public health lab, so I won't spend any more time on this other than to say our lab staff, through expanded workforce, has been able to expand their hours. Previously, our lab operated from 8 to 5, and now they operate essentially from 7 in the morning until 10 o'clock at night, 7 days a week. They have really stepped up and provided an enormous amount of support to help the residents of our state. And you probably saw the number on the slide we had before. They've resulted 10,850 tests through our lab, and that number will continue to increase as we continue to expand our efforts in that area. I want to speak for a moment about our health readiness and response section. This section houses our public health emergency preparedness and response team. This unit maintains plans at all times for any public health emergency, and we've spent many many hours planning for pandemics. And though this one is not something we could fully be prepared for, nor could anyone in the world, I feel like this team has really embraced their role and provided a solid foundation for our response. This key activity of providing public health emergency response resources and activities has really shown through in terms of providing personal protective equipment, or PPE, to across the state. Prior to this pandemic, we maintained a cache of supplies intended to be a stopgap measure. Early on in this response, it became clear that these materials would not just be a stopgap measure, but rather providing critical items on an ongoing basis to counties for the ongoing public health response. The need here that we can meet with current resources is really ongoing strategies about PPE procurement and distribution. As I'm sure everyone is aware, the supply chain was very impacted in our country and around the world. And so we've had to be very creative in terms of working with other states, coming up with unique ways, even working internationally to secure some of the much needed PPE. And just to give the committee an idea of what we have distributed to date, we've made 6 distributions to county and tribal emergency management for them to distribute locally. And just as an idea, what has been distributed to date is as follows: gloves, 143,750, N95s, 93,366, gowns, 25,863, face shields, 9,835, and surgical masks, 208,990. We have appreciated the partnership that we've had with Homeland Security in being able to make these items a possibility, working both through our strategic national stockpile with the CDC as well as FEMA to coordinate those deliveries in conjunction with the Wyoming Office of Homeland Security. In addition to this, our Office of Emergency Medical Services has provided support to EMTs around the state. In addition, our hospital preparedness program has worked with hospitals on an ongoing basis and as needed. Finally, I want to talk about our community health section, our public health nursing. Our public health nursing infrastructure has been imperative under these circumstances. And this is one system that this committee is probably familiar with due to the work that we've done in this area to establish this system. This system is an example of one that took time to build, and it now operates very well. We appreciate the ongoing partnership we have with counties, and the public health nursing offices have really worked tirelessly on behalf of their local communities to address the issues related to COVID-19, working with those who have tested positive for COVID-19, providing contact tracing in some of our counties, and providing a high level of coordination and community support. We are currently working to get available federal funds to the counties to support their ongoing personnel needs, as well as testing needs they may have. And we just can't emphasize enough how much this partnership has been critical to our efforts across the state, and we're thankful to them for their efforts. With that, I will go ahead and turn things over to the Director of Homeland Security, Lynn Budd.
Thank you, Stephanie. Madam Chairman and committee.
Just before you start, Director Budd, I just want to insert 2 things in here while both of those you agencies are together, just for future reference, not questions. But one is that I take your discussion of the PPE and just the supply chain issues very much to heart, and I am working. I've been talking with the governor's office and the business office, and this is something that I'll be looking into over the year before the next session. But I have a great interest in using some of our business incentives to encourage manufacturing in Wyoming of various types of essential medical supplies, maybe not just PPE, but tubing, that kind of thing, looking at co-op structure possibilities and that sort of thing. So that's something that I'm working on. And then I just put this in, I've mentioned, and I don't want answers to this now, but as we move into our August meeting, I think that it's important for us to consider that bad as this disease has been, and certainly the economic consequences, but realistically, we could see far worse. I mean, if we had a disease that had the mortality rates of Ebola or of AIDS and had respiratory transmission, we'd be way worse off. So I'm going to probably in August ask for a discussion of where we would need to go with that kind of a worse sort of transmission. And also perhaps, I mean, God forbid, but suppose we had a simultaneous loss of the power grid. You know, I mean, that just thinking really worst case, because as I sit in here self-isolating and whatnot and thinking, well, at least I have electricity and so on. So I'm just inserting that now before all of the people move away. Committee, we're not going to talk about that now. We don't want their answers right now, but I just thought this was a good time to insert it. So Director Budd, carry on. Thank you for being here.
Thank you, Madam Chairman. And thank you, Stephanie, for that great introduction. It really has been a pleasure working with the Department of Health. We've been partners for a long time. In this particular situation, we worked in a new coordinated response, and that is a unified command. In the incident command system, you always have an incident commander, but when you have two agencies that are working together and have different expertise, we call it a unified command, because it's very important that as we work through this, that we create a message that is unified for both staffs and the local level and utilize the expertise that we both have. That is generally our role, is to support those that are working in the response of the incident, and that is the same for this situation. Our job is to work in the background and support the Department of Health in whatever way we can, and whether that's gathering information and being able to share it, creating coordination with suppliers for resources needed, all of those things. Essentially, we're here to help Dr. Harris put out the fire. If we're looking at this as another type of incident that we normally deal with, she needs to concentrate on that, and her team needs to concentrate on that, as well as the rest of the Department of Health. And so we can do our job by helping to support them in that effort. We do work together. But we have different authorities and different knowledge. Our job is coordinating response. We look again to that logistical support and also try to learn from other states. We actually were at an advantage, getting a late start, if you will, in this pandemic. For instance, we had an opportunity to visit with the state of Washington, who was willing to share some of their lessons learned early on. And one of the main things that they communicated was the fact that they started their unified command too late. And we did hear that from other states as well. So in working with the Department of Health, we agreed that we needed to work in that type of a scenario, both at the state level, mimicking the federal level, but also at the local level. The partners between the public health and the emergency management at the local levels are strong, but they needed to be even stronger during this particular incident. In addition, our job is to support the cascading consequences and different things that are going on. So for instance, in this particular one, looking at businesses and looking at critical infrastructure. Critical infrastructure is a focus of our agency in support of those 16 different sectors year round, but particularly in this situation where we're looking at the effects on communications, as you mentioned, with the internet being overloaded, also looking at energy and the economic impacts. Unfortunately, the bad actors out there also like to work when we are at a vulnerable position. So in other emergencies that are going on, we are also monitoring cyber attacks, and we have seen an increase in cyber attacks across the nation on critical infrastructure, including the electrical grid, as well as communications, and of course the health sector. We also, our job is to coordinate other agencies too. So when we work at the local level, and I'll get a little more into that in a second, but that's another job. Next slide, please. So we work jointly with Department of Health in natural disasters, in planning, training, and exercise, as well as real world events. And as you mentioned, the key to all of this is to do the after action review and figure out what went well and where we can improve. There are always things that we can do better. We have great planning efforts, as was mentioned, that we have the pandemic plan that we've helped work with the Department of Health on for years. However, you can't ever plan for everything, and it never goes the way you think it will. So this is a unique situation. Again, we are supporting local communities in times of emergency. Our job also is to coordinate with FEMA and coordinate the disaster funding. PA is public individual assistance and public assistance. Public assistance is more what we see usually, which is, say, in flooding situations, it's bridges and roads and all of that, supporting that public infrastructure. In this case, it's with emergency protective measures, which would be those measures taken to respond to this event, including overtime hours that people have spent at the local level and at the state level, as well as the supply of PPE and other testing supplies and those things. Individual assistance is more about the individual, obviously. We've worked very closely with the Department of Health in this particular area, as we were just awarded as a state the individual assistance for crisis counseling. So we'll be working with a plan with the Department of Health. And that's why it is key for us to be in this unified command as well. The money flows through our office and will go to the Department of Health to support their plans and their response at the local level. In addition, we work through public safety communications, also preparedness grants for the local level. I will end that there and keep my presentation brief, and then we'll stand for any questions. But we'll focus on the quote at the bottom of the slide, where the lessons learned that we have will help us be stronger for the next event, which may be a flood. And as you mentioned, you never can tell how many events we can have ongoing at once. But unfortunately, flooding is hopefully not going to be one of those events this year. Thank you.
Questions for Director Budd? Representative Sweeney.
Thank you, Madam Chairman. Director Budd, I'm just curious on our ability for the next potential wave and utilizing the CARES Act. I'm pretty sure the old liquor warehouse is still available. It's not an ideal location next to the refinery, but has there been any consideration utilizing some sort of space the state already has to create a warehousing effect for PP&E? And is that possible? It appears it's possible out of the CARES Act. Is it possible to, if a vaccine is developed, is it possible to get that paid for utilizing the CARES Act? Is it possible to get the antibody test once it's better perfected? I've already had an antibody test. It was $75 through LabCorp, but so that the citizens don't have to bear that cost. And lastly, between the Department of Health and Homeland Security, is it possible to expand our lab capacity for the future with CARES Act money? Are any of those possibilities working with Homeland Security and your vast contacts?
Dr. Budd.
Madam Chairman, Representative Sweeney, yes, to all of those things. We are working on all of those things. We are working in conjunction with the Department of Health to utilize the CARES Act funding, as well as the funding that was forwarded to our office to support businesses to develop that stockpile of PPE as we can find it available. And we are utilizing, yes, several different state facilities for the storage of those supplies. In addition, as a part, and I'll go out on a limb here, and Department of Health can jump in, but as a part of the pandemic planning and the medical countermeasures planning, we do have cold storage available should there be a need for that, as well as other facilities and procedures in place for distribution of vaccines and other things, which would be the normal planning within a pandemic. That was what the plan was focused on. And obviously that changed everything, but those plans did allow us to develop supply transportation systems. We call it the Pony Express because we utilized a lot of state agencies as well as volunteers, including YDOT and the Fire Marshal's Office and the Cowboy State Volunteers, who are former CAP pilots that essentially donate their services for the payment of their gas and oil. So in working with the budget response team, we are looking at all of the possibilities for the CARES Act funding and trying to get very creative. It becomes very complicated. This is probably the most complicated situation we've ever dealt with as far as disaster funding is concerned, but trying to look at all of those possibilities as we work through that, including the FEMA disaster dollars.
Representative Sweeney, did you have a follow-on?
Yes, thank you, Madam Chairman. Can we utilize as a state any of the CARES Act money to, let's say the liquor warehouse was chosen as a potential site. Can we use any of those monies on any building particular, such as it needed more technical air handling equipment than it currently has? Those type of things. Is that available through the CARES Act, or would that have to come out of the general fund?
Director Budd.
Madam Chair, Representative Sweeney, yes, we are able to use some of that funding for those purposes and are doing that at this time.
Representative Clem.
Yeah, thank you, Madam Chairman. Director Budd, along those lines of using some of these COVID funds for testing and whatnot, is it something that you could do to, for instance, if we did have an accurate serology test, to incentivize people getting that test, for instance, giving a stipend of say $20 using CARES Act funds? Is that something that you all can do? And is it something that you'd be interested in doing, or is that something that you would need legislative approval on? Thank you.
Director Budd.
Madam Chairman, Representative Clem, I would have to do some research on that. There are pages and pages and pages of information with regard to allowability of these funds. And then, of course, I would defer to the Department of Health as to whether or not it would be something that we would want to spend CARES Act funding on. So we'd be happy to research that information and get back to you as far as the allowability of being able to use that funding for that purpose.
I appreciate it.
More questions for Director Budd? Okay, excellent. Well, thank you guys. We know you probably have plenty of work to do, so thank you for your report. Keep us posted. We are always interested to read the various dashboards and placemats and whatnot kind of things that we get. And we look forward to, hopefully by August, we'll have enough knowledge under our belt and a little slowdown that we can do an after action report and see what you need. Let me just circle back to Department of Health there for a moment. I mean, there was more that you wanted to present, I believe, something to do with some statutory suggestions, or was that part still, is Stefan on?
Madam Chairman, this is Stefan. Really quickly, we can wrap up here. We did want to stand for any questions that the committee might have about the 3 statewide public health orders, especially in light of the announcement that went out this week for what is changing with those 3 public health orders effective on June 1st. You can see on your screen and in your packet a summary of what the orders contained in terms of restrictions, how they were changed or altered on May 15th. And obviously, we sent this presentation prior to the changes that will go into effect on June 1st. So, Madam Chairman, we're happy to answer any questions the committee might have about the orders. We'll keep Dr. Harris on the line for that to answer any of those questions. And then, Madam Chairman, we talked about the state hospitals, and the last thing that we were going to mention is, again, just a concept for for future discussions that we can follow up with LSO, with the committee chairman, whatever would be your pleasure on potentially pursuing this in terms of session law or statute language that might be part of a special session. Again, as I mentioned, we have a multi-pronged strategy for wider scale testing, including diagnostic testing, population surveillance, and serology when it becomes available. To the questions that were just asked, we have set aside CARES Act funding in conjunction with the governor's office for future purchases, procurements of these various elements related to COVID-19 testing, including serology. So that is something that we can definitely use the CARES funds for. To Representative Clem's question, specifically, incentivizing people to participate, that's something that we will, like Director Budd mentioned, we will research. That would require probably institutional review board consideration and approval when you're dealing with paying people for a study like that. But certainly in the realm of possibility. But Madam Chairman, here this concept would really be an employer program potentially authorized in statute to essentially allow the Department of Health to partner with employees to frequently test if the right and appropriate testing is available, like we were discussing before, easy to administer, potentially done with saliva, easy to scale, et cetera. Those problems are not solved yet, but this could be the structure to bridge the gap between now and the availability of a COVID-19 vaccine to work with large employers or other large entities to essentially accomplish two things. One, get data flowing to the state decision makers on a more periodic and frequent basis, really with those asymptomatic patients and not really testing bias towards the sick or the symptomatic, but getting periodic data flowing in from employers, from their staff that would tell us kind of what the known prevalence of the virus, or at least a better known prevalence of the virus is. So again, this is just a concept, Madam Chairman, that we wanted to introduce to the committee. Happy to answer any questions about this, but between this and the 3 public health orders, the department will certainly stand for questions, and that concludes our presentation.
Okay, committee, I will say that as far as the public health orders, certainly they've been posted all along. The governor's had press conferences and such like. So I think that if there's something that, I rely upon you to use the ordinary information sources for that. So if there's something the department really needs to specifically address, but otherwise let's not spend too much time on the orders, because I think we hear about them regularly. Although, we'll see where we go with that. But then as far as the statute suggestions, clearly we won't be able to generate any kind of statutory draft for the next, I don't think there's time to put those thoughts together, but we'd be glad to take questions on that. And Chairman Scott.
Yes, Madam Chairman, thank you. I wanted to raise one thing for the health department to think about. We got the co-chairman got a communication from the management council that I just learned of the day before yesterday, asking us to consider using, as I understand it, using the CARES Act funding and maybe some other federal funding for enhanced Medicaid reimbursement for providers particularly affected by COVID-19. We obviously didn't get that in time to work up a bill for this meeting. The most we could do at this meeting would be to authorize the drafting of one for the future. Want the health department to think about that. The co-chairman's initial inquiry from co-chairman Wilson to the Medicaid program got a response in terms of you can't use federal funds to match federal funds, which is true, but it shows a misunderstanding what we're thinking of. I think Management Council was thinking of using the CARES Act funding independently as the sole source of funding for a temporary kick to reimbursement. I think that has some potential given the financial stress that this has got to have caused some of the agencies that are very heavily dependent on Medicaid, things like nursing homes. And so I want the health department to put that on their radar and think about it a bit. As I say, we can't take any final action at this meeting, but I think later on we'll talk about a very simple authorizing draft to permit that. So request the health department to think about that issue.
So to the committee regarding that, it's very possible if this works out a little bit further that we might have, say, a 2-hour meeting mid-June in preparation for the second special session. We don't know anything more at this time, whether it's feasible, what the timing is or anything like that, but just be alert of that. Representative Sweeney.
Thank you, Madam Chairman. That's exactly what I was going to ask. If there's a couple of either statute changes or bills that we need to get ready for the second session so that we don't miss the opportunity, because I think the third session, if we have such a thing, would probably be after the primary. And so I some of these things probably can't wait, and I appreciate all your hard work, Madam Chairman, on trying to put something together for us. But I know there's a ton more to do, but that would be my only comment, and I believe you're spot on. And well,
oh, Representative Sweeney, somehow your mute just went back on.
Thank you.
Not sure what happened.
Me. And also, if Dr. Harris is still on the line, I truly appreciate her strength, her courage, leadership during this whole thing. So I know there's been a lot of talk of trying to overthrow her and the legislature taking over and all sorts of things. But I truly do appreciate all of her hard work and effort in her courage during this. Thank you.
Thank you. I'll call on Representative Yin in just a moment. Or no, Representative Clem is next up, but I was just going to put a thought there for the folks at Department of Health, so you can look up the number while we're calling on the other people. The federal government did enhance the federal match for some services, and I know some additional money has gone to nursing homes. If you could just obtain a little information about that for us at the end of this presentation, so that we can hear what additional Medicaid dollars are going to the nursing homes, and I think a few other providers. Just look that up. So Representative Clem.
Yeah, thank you, Madam Chairman. And actually, Representative Sweeney and previous to that spoke on that. I guess what I'm looking for here is, given we only have a one-day meeting here and there is some pressing things, what do you have in mind, Madam Chairman or Mr. Co-Chairman, as far as preparing any potential bill drafts for a next special session here in June? And so I appreciate the understanding that we may have to meet for a couple hours another time. But as far as the direction today, I'm really kind of curious as what your thoughts are as far as what do we need to work, and particularly from the agencies, if there's bill drafts that we need to really dig into and work on, if the things that they brought before us need to be looked at for the next special session, I'd like to get to that. And then the second thing, Madam Chairman, is just in preparation for the August meeting, for our good Department of Health and Homeland Security, I really am kind of drilling down on this idea of what is the threat. And it doesn't sound to me like we really know. It hasn't changed a whole lot. And I understand the cautious approach because we don't know. But we've heard that there's more deaths with COVID-19, and I certainly see that as well. But we don't know what the denominator is, and because this is a novel virus, there's a potential there it could be infecting double the population. So we really don't know the mortality rate. We really don't know the threat as compared to other communicable diseases, or to the threat of a recession or depression, and all the social implications and economic implications that go along with that. So we really would like to see where the needle moves in August, to see if we've if we can identify more closely what exactly the threat is of COVID-19 as compared to some of the other actions that we've been taking. Thank you, Madam Chairman.
Okay, I'll keep taking questions here and then we'll just talk about the various bill drafts, I think probably at the end, but Representative Yin.
Thank you, Madam Chairman. I think I would agree with Representative Clem that if there are bill drafts that we need to get done, I think it'd be appropriate for us to have another meeting before a possible special session. I think my question for the Department of Health is, let's say we do enact a program for business testing. Would that money have to come out of the CARES Act relief funds, or is there a separate part of the CARES Act that has a specific pot of money for testing that program could be stood up under? Thank you, Madam Chairman.
I think we might, I could hazard a guess on the testing funding. I think that's in there in somewhere, but Department of Health, do you have a specific answer to that?
Madam Chairman, this is Stefan. Yes, we have tentatively carved that money out and proposed it to the governor's office to come out of the CARES Act funding that sits in that account, the $1.25 billion. But I will mention that in the week since we developed that plan for enhanced testing, both, like I mentioned, diagnostic, surveillance, and serology, some developments have come to light where additional money has fallen out of the sky from the federal government. Dr. Harris mentioned some of that earlier this morning, where there's CARES Act funds not part of that state government allocation that have come from various agencies like HHS, through CDC and other entities that we're taking a constant daily and weekly inventory of what we have, what's been allocated. So there will likely be some overlap and some offsets, but the general answer to Representative Yin's question is it would most certainly be CARES Act funds, whether it's the state government allocation or other funds that would be used for that type of project. And the last thing I'll mention, Madam Chairman, is the reason for that is when we talk about the public health response and what we've already done with CARES Act funds or continue to do with increasing our laboratory capacity, supporting counties and communities with testing, with supplies, et cetera. The point of all of that as a top priority for CARES Act funds is that it does represent kind of the least amount of audit risk from the Inspector General, where on the back end of this, we just don't know a year from now, 24 months from now, if these various expenditures will be audited and potentially have some clawback risk. So when it comes to the public health response, testing, surveillance, contact tracing, support for communities and counties when it comes to COVID patients and COVID surveillance, that really is kind of the heart of what those CARES Act dollars, at least for the Department of Health, are intended for. So that's something I think we can move more quickly on, and I don't think it requires any additional legislative authorization other than what's already been approved during the special session that gave the governor some general authority and direction on that state government allocation. Thank you, Madam Chairman.
Co-Chairman Scott.
Thank you, Madam Chairman. In response to Representative Sweeney and Representative Clem, we're aware of two other possible bill drafts at this point. One is the authorization to use CARES Act or similar funds to enhance Medicaid reimbursements. That I wrote a potential bill that is technically one sentence long, albeit it's a sentence with 3 bullet points in it. I think Ian Shaw may have distributed that electronically to the committee last night, but it's a very simple thing. We'll talk about that later. It would require an authorization to draft it, and then I think a 2-hour meeting is an accurate description to approve it in final. The other one is an issue that Co-Chairman Wilson discovered. Some of the licensing boards require passage of national tests in order to get licensed. We're getting recent graduates that can't take the test because it's not being offered because of the virus currently. And it looks like we may need again, a 1 or 2 sentence authorization covering all licensing boards, allowing them to issue temporary licenses pending completion of that test. Again, that looks like a very simple piece of legislation. We've each of us contacted our counterparts on the corporations committee, because our committee has typically dealt with health licensure. Corporations deals with a number of other licensures, including accountants and engineers and architects and things like that. And sometimes deals with health licensure issues too. So one of the committees may need to bring a simple authorization bill to allow the licensing boards to deal with those new graduates sensibly. They both look simple. We could handle them in a 2-hour meeting. So those are the two that I'm aware of. Madam Co-Chairman, I don't know do you have any others?
Not at present. So just to pick up on the question about bills. So committee, you'll see that as soon as we finish the 5-minute agency reports, we will consider 3 bills, and the what we were aiming at in these bills was areas where we can spend CARES Act money, but where we need some statutory tweak to existing statute. We figured that was the easiest way to get that money running through. There were a number of other areas that, last month or so when I emailed you all about ideas that, so for example, there was one having to do with reimbursement for childcare expenses through CARES Act. Also looking at providing reimbursement to healthcare practices that had to close down non-essential services for lack of PPE. So there are some possibilities that we early on talked about, like the childcare, which in communication with the agencies, they felt that they were able to run the CARES Act money through what they currently had and didn't need statutory change. You'll remember in our special session that we had, Senate File 1001 gave the governor considerable flexibility and spending authority for the CARES Act money. So if there were areas where we could receive CARES Act money and where the governor could spend it, push it out through the agencies, but the current statute were sufficient, we are not attempting to run a bill on that because the governor can do it without us. Then the one about reimbursing healthcare providers who had to close down due to lack of PPE or just cut back, when we did House Bill 1004 in the special session, you remember we had all those business relief stipend programs, and I worked quite a bit with what kind of offline during the drafting and the amending of that bill to make sure, if you recall, if you look back on those bills, it doesn't just say businesses that had to close down because of health orders, because the businesses that stopped, the doctor's office who stopped doing colonoscopies, let's say, because of lack of PPE, wasn't because of the health order, it was because of health needs. And so those are able to access funds now through the Business Council program that we stood up in 1004. So the bills that we have, the 3 before us today, are ones where it looked like we needed to tweak statute a bit to run CARES Act money through. Hearing, as Chairman Scott said, now we've got the potential at Management Council's direction for doing something with CARES Act money to Medicaid providers. I'm not entirely clear yet. We're awaiting a little bit more information from the department on how we might do that. The licensing board issue, and then I don't have a clear feeling yet from Department of Health about this testing idea, but I hope that answers some of the questions there. Are there any more questions for Department of Health or Department of Homeland Security before we let them? Well, we'll probably, Department of Health will, as always, have to be here forever, but Department of Homeland Security anyway might be done. Okay, I don't see any more questions. So Director Budd, at any rate, thank you for your participation. Department of Health, probably you'll be hanging around a little bit. I do see, let's see. So then on the list, looks like we've got DFS. Elizabeth, do we have anyone from DFS who is still awake and wanting to present on their 5-minute version of what we really have to know?
Ma'am, we do, and they should be joining.
I see them. I see Director Schmidt and Lindsay Schilling. I don't know who else's pictures, but Director Schmidt. Oops, there you are. Super. Glad to see you. Thanks for your op-ed.
You're welcome. Can you hear me?
I can hear you.
Okay. Hello. I was a little slow getting in, so I think I missed a preliminary conversation, but I'm happy to be here.
We're glad to have you. Carry on. And
hello,
remember,
everyone.
Remember, just so as I've told everyone that I hope it was understood that our goal is not to hear about everything you're doing, but to get sort of the short version and hear if there's anything urgently that you need us to tackle statutory wise for special session.
Okay, thank you, Madam Chairman. Mr. Co-Chairman, members of the committee, my name is Corin Schmidt, and I'm the Director of the Department of Family Services. And after listening to the long conversation, I can understand why you would like to keep this a little bit more brief. We do have a slide deck available for you. I believe the LSO may have sent that out. It's also being broadcast. We will not go through every slide in the spirit of time, but it does have some good information for your reference. And if you have any questions regarding any of the data that is on the slides, please email me and we can certainly do a follow-up. So going on to slide 2, the DFS response, our immediate response. So of course, when this COVID experience hit us, our main concern was the children. Children in our care, children coming into care, children that are served at our facilities. So our social services staff quickly deployed a lot of alternative ways to be able to visit with children. We have conducted most of our business either via video or via telephone. However, we are seeing our rates of face-to-face visits increasing. We're at about 36% right now. We modified our intake procedures at the boys' school and the girls' school, which we implemented a lot of the same safety precautions that other facilities implemented in terms of looking for temperatures, asking questions about potential admissions, understanding where those students had been before admitting, and then after admission, then quarantining for a certain amount of time, looking for any type of symptoms. We also conducted foster care mapping, so using some of the technology just so that visually we could see where children are and what was available to us. On our economic security side, looking more at our benefits, we've capitalized on a lot of the flexibility that was given to us by the federal government. Many of the programs through our economic security are federal programs. So we administer those programs to some extent. They divvy out the benefits. So where we could respond the best was through flexibility, with the exception of child care assistance. So with SNAP, we went to online purchasing. We're going to online purchasing. That was a benefit that was offered a little bit later. So in some communities, SNAP benefit recipients will be able to order groceries online and then go pick them up, which was an aid that we discovered pretty quickly when we have people with compromised health conditions that maybe could go to the grocery store, but it wouldn't have been safe to go to the grocery store. This is actually a federal pilot program that in response to COVID, the feds made available to all states. So we will be taking advantage of it. We've also expanded eligibility to families receiving free and reduced lunch through PEBT. That's called the Pandemic EBT. That was in partnership with the Department of Education. They've been extremely helpful, and we're very grateful for the support that they've given us. We've had to rely heavily on their systems in terms of tracking children who are eligible for free or reduced lunches. That program is getting set up, and we'll be able to offer benefits, extended benefits to those kids. In terms of LEAP, we've extended the heating assistance season so we can be taking on more applications or providing more support to those LEAP beneficiaries. Child care assistance has been a large part of our conversation. It's an infrastructure issue as well as an economic benefit to many of our families. I'll touch on that a little bit later. And then I hit on the social services already with remote visitation, modified emergency processes that we've put into place so that we could make foster parents eligible quicker. Moving on to slide 3, the CARES Act funds. Through our existing grant systems, we've already received some of the CARES Act funds. This is not the $1.25 billion that the state as a whole has received. This has been specific to programs within our agency. The first was the 4.1 for child care. We received this early on in April. We immediately made payments to our child care assistance program recipients, meaning that if they were serving a family that qualifies for child care assistance, we were able to pay them for March, April, and May based on enrollment rather than attendance. So about $900,000 in child care assistance paid directly to child care providers. The remaining funds, the 1.5 and the 1.7, we've granted to Wyoming Kids First so that they could set up, it was easier, less paperwork, less bureaucracy for Wyoming Kids First to set up a system to do one-time payments to all licensed providers. The reason why it would have been difficult for us is that we don't necessarily have all child care providers as part of our child care assistance program, meaning then for the state to pay them, they would have had to enroll through Wolves and lots of other things. So we partnered with Wyoming Kids First. It's been a great partnership. So they'll be allocating $1.5 million of that CARES Act funds directly to licensed providers and one-time payments. And then the remainder of the money will be for needs-based grants to providers based on what they have not been able to receive via all of the other federal dollars that are available. As I mentioned, we've received LEAP, an additional $2.4 million for those clients, and then an additional $1.1 million for homelessness services, really looking at prevention of homelessness as a result of COVID. And those dollars were distributed to community agencies throughout the state. In terms of CARES Act funding on our social services side, we haven't seen a whole lot of direct investment into our program, but rather some allowances. For example, we've received a 6.2 increase in our federal participation. This is similar to Medicaid. So when we participate in our federal funding source, that's called 4E, what we're getting is an increased match. So instead of 50% for qualifying families, we are now receiving 56.2. Next slide, we're going to skip a few and we're going to go right to SNAP. So one of the questions that we keep getting asked is around what are we seeing as a difference in our enrollment? And what's important about this particular slide is the small tick upward. What we know is that we've seen an increase from March to April. So in March, we served 25,740 persons, which consists of about 11,500 households. What we've now seen go up is in April, we served an increase of 1,000 individuals up to 26,000 and an additional 436 households. So I can send you that specifically, but the numbers aren't significant. What is significant is the uptick. And this is probably an area that we will see increased uptick throughout the COVID response. This is an area where we will probably have more families qualify for benefits. So we'll be tracking this very closely over the course of the next, I'm sure we'll be tracking it for quite a while. Understanding more, this is kind of maybe the canary in the coal mine, so to speak, where once we start seeing an increase here, it's also an indicator of what we're seeing across the state in terms of family needs. Going into slide 10, we're seeing some concerns with child care assistance. As I mentioned before, we've received $4.1 million already for some child care assistance. However, there are no additional federal funds available through our federal grant. So that is all we will be receiving through the federal government. That will, at this time. Even if we were to have additional state general funds available for child care assistance, the federal government caps that as a block grant. So it would be just strictly an investment of state general fund. If we do see a continuing increase in need, what we will do is institute a wait list. So what that means then is that if a family does qualify and they do need childcare, if we don't have the money available, we will create a wait list, which means then that someone would have to be no longer eligible, come off of child care assistance, and then we'd be able to enroll. So a lot of you are familiar with waiver concept and wait lists. That would be the same idea here.
So Director Schmidt, on this issue, I was thinking that some of these specific, you said that the earlier money was specific to those programs and not CARES Act. And perhaps I misunderstood in our email discussion about the CARES Act money specific to childcare. Can that not be used here outside of this matching program?
Madam Chairman, yes, it can be used. So the 1.25 billion appropriation we can use for childcare funding. This is specific to the child care assistance block grant, where we have federal parameters on how we serve, who we serve. What we're looking at in terms of overall child care assistance is to serve a population beyond those that are eligible for that population. So not every child care provider is enrolled with our assistance program. We wanted to take a broader look. My point here is that there just isn't going to be any more specific assistance dollars for eligible families that may start to qualify as a result of decreased income.
But we will be able to use the CARES Act money, perhaps not in this specific box, but the recipients will essentially be the same. They will be
Yes.
child care centers, right? Okay.
Right.
Okay. Go ahead, Director Schmidt.
Okay. Moving on to slide 11. The importance of this graph is to look at the difference between the gray and the blue. The gray are the child care facilities that have not yet opened. The blue are the facilities that have opened. So you can see an uptick after some of the orders were relaxed. Right now, we are seeing about 223 child care facilities that have not opened their doors yet. We don't know why. We don't know if it's because they're reluctant to open, waiting until maybe the orders are released a little bit more, although with the allowance of 25 or less people in an environment, that captures a good portion of our child care facilities. But we're watching this real closely. We're also watching any impact of a closure after a child care facility is opened, but a closure due to a COVID positive child. So we've seen 3 of those so far, where a child or an employee has tested positive, so they've had to shut down permanently, and then they will gear back up. That yo-yo experience causes us a little bit of concern in terms of how long can a business sustain that kind of model where they're opening and closing, opening and closing. So right now we don't have any information that shows us the impact, but we are tracking that just so that we can stay in tune to the ramifications. It also does a lot to the workforce. If you have a child care facility that closes, parents then have to look for alternative arrangements on the fly. And so that creates just a lot of doubt with parents too about when they can go to work and when they can't. So this just isn't about child care assistance in terms of the eligibility program. This is about the economic support or the infrastructure support for our economy.
So Director Schmidt, are your licensing folks doing any kind of outreach to these centers, whether just through counseling and assistance or just a survey of what the challenges are? How proactive do you have time to be on this issue?
Madam Chairman, we've been working really closely with our child care providers all over the state. So we have licensors spread out. We keep in real regular contact with them about what they're experiencing, what they're seeing. PPE has been an issue. Questions about how to implement the state health orders have also been a lot of questions. So we're working in some respects at maybe a local level with the county health officer, the licensor, and the local provider to work through some of those issues because the orders can differ from county to county. So we're trying to keep them up to date on what we find out in regard to what other financial assistance is available, whether it's through PPP, whether it's through the legislation that just recently passed that the Business Council is working on. We probably have a tendency to over-communicate. We are bombarding them with emails pretty regularly, but that's the best way we can be pretty targeted in keeping them up to date and also to provide them guidance. We've also worked closely with the Department of Health in terms of trying to provide them specific guidance on how they can open or what they need to have available to safely serve children and to protect staff. This is one area where a lot of places stayed open. I know that there's been economic impact on businesses that closed, but I appreciate certainly the state health officer, the governor, and many others recognizing the importance of child care facilities staying open, especially to serve our essential employees. Not just healthcare, but you're looking at people who work in grocery stores, who do a lot of, who've really given us lifelines to what we've needed that do not work in a healthcare environment, and their reliance on childcare in order to provide those services. So some states did a pretty serious closure. We were a little bit more relaxed in that, and I do think that that's been extremely helpful. And we're seeing centers, I think, carefully open, but they've also had the experience then so that when a new center opens, they can rely a lot on partners to help them understand what protections need to be in place.
Okay, thank you.
Next slide is number 12. So lots of questions about what about the kids? What's going on in terms of abuse and neglect? And this is an area where we've had to do some projections. What you see here, what's concerning about this is the dark line demarcates about the middle of March when schools started shutting down. As you look across this graph, you'll see that there's two downward trends and then the black line. Those downward numbers are when schools are closed for Thanksgiving and Christmas. So what you see is a direct correlation to our intakes and school being in session. So when school's not in session, we are not getting the number of reports to let us know what's going on with kids. It makes sense. Teachers, educators are seeing kids every day. They can be the eyes and ears. They give us a call and then we can take up whatever issue we need to take up. Sometimes it may result in an intake or a child coming into custody. Sometimes it's just an offer of assistance, voluntary assistance to a family. But regardless, this is where you see the role of schools and the child protection system kind of interplay. The next slide is the reporter type. What's important about this particular slide is the yellow, and the yellow are our educational personnel who make the calls. Again, at the beginning of the graph toward the left, that's when school isn't in session, that's summer break. Then you start to see more increases as school comes in, a decrease around Christmas again, and then it sparks back up through the first months of winter. Again, a substantial decrease in reports by all of our provider types after the quarantine and self-isolation orders were issued. So we then turned around and tried to reach out through different ways to communities to ask them for their assistance. We've spoken with the superintendents, especially as schools started to get back online, started to show more of a presence, at least video presence, or checking in with kids on homework, trying to connect with whoever we can to say, we really need your help and support in identifying if a child is in some sort of issue, or even just as a prevention measure, just reach out to families. How are you? What do you need? How can we help you? Can I get you a resource? Can I connect you? Can I get you a phone number? The food banks were very helpful in that as they've passed out food. We've worked with the First Ladies Initiative to make those connections. So we were quickly forced to move to some sort of grassroots effort to identify any of those potential cases rather than relying on those standard systems that have been in place for years. So our next slide then is what is it that we expect? So this is looking at an estimation of what we think we would have seen had there not been a COVID response in place. We think we would have seen 605 children come in per month. What we observed is that about 453 have come in per month, meaning that there's 152 children that did not. Okay, so these are 152 children that we don't know much about projected. What we think is 135 would have met the criteria for an in-home case. So what that means is they would not have come into protective custody, but rather stayed at home where we would have offered services, prevention, et cetera. We think 17 would have come into out-of-home placement, meaning into a foster care setting, whether that be with a relative foster care or a non-relative foster care. 12 of those 17 cases probably would have been from just neglect, 4 from physical abuse, and then medical neglect and sexual abuse, about 2 or so. So this is what we think is happening based on previous data. So what we do know then is as more of the orders are lifted and people are starting to experience more of the general environment, in about July, we're going to see an uptick in cases. So next slide, please. So we expect to see another 473 kids come in probably over the course of the summertime. The increase will be temporary, but it will be kind of that onslaught of casework, of families, of people calling us, wanting us to do welfare checks, et cetera. And that will also probably lead to what we think is 60 kids coming into protective care. When we have this kind of surge on our system, it backlogs. So it slows everything down, as you can imagine. Once you start to identify all these kids quickly, we'll see a little bit of a shortage in foster homes, although we've had wonderful, wonderful support from our foster parents who have been extremely helpful. We have not had a child come in that's been COVID positive. But we certainly had numerous foster parents be willing to step up and take those kids, had to. Certainly a system where they've supported themselves and being able to shift children around if necessary. So our foster care system may see an impact, but I also know that they're willing and able and very much wanting to step up and help us. Certainly the onslaught will also result in slower casework, so getting cases through the system. And then we're already seeing our caseworkers at about 18 cases per worker, which we don't like to see that get above 20. So next steps. As I said, we anticipate an increased demand for services all over our agency, economic security, social services. You had asked, Madam Chairman, about child care assistance. We worked with the University of Wyoming, and through some projections, we believe that there's an additional $17.4 million in child care financing that would need to be made available to support the whole system. That's all child care providers. The University of Wyoming actually projected $128 million in revenue. However, we've adjusted for what we think is more applicable to the number of parents we think will be able to continue to pay. Certainly the child care assistance we've been able to provide, and that estimate to maintain existing capacity is 17.4. That request was submitted to the governor's office through our COVID request system. So that's the amount that we would see would be helpful. We don't have any agency statutory needs right now. It's actually been fairly easy, and I say that in terms of, air quotes, fairly easy to deploy those dollars that we've received because we were able to use the mechanisms that are already within our system to disperse any type of CARES Act or COVID response money that we've received through the federal government. So with that, I didn't check my time, but hopefully I kept it within a reasonable amount. And we could
I think it probably wasn't 5 minutes, but you did very well. Any questions for Director Schmidt? Little blue hands. Representative Sweeney.
Thank you, Madam Chairman. It goes to slide 2 in 7 on SNAP. So in the expanded portion, I think I heard you to say something about being able to use the CARES Act money on some expanded portion. So in the one program for the additional food services, will that, with working with the Department of Education and our school district, will that continue? I know our district, I know a lot of districts are doing to-go meals, breakfast, lunch, Monday through Friday. Will that extend through the summer for the kids? Utilizing, some communities have a food for thought program, boys and girls clubs, that type of thing. And that's got to be directly part of the CARES Act, is it not?
Madam Chairman, Representative Sweeney, so what's available right now to kids is 2 different programs. One is administered through the Department of Education, and that's the free or reduced lunch program. And I'm not familiar enough with that specific program to know how it will work over the summertime. I do know, just based on past experience, that they do provide some food assistance to youth throughout the school districts. I just don't know how that works in relation to what we're seeing now in terms of COVID and CARES. The program that we're able to administer is using our SNAP infrastructure, and that we'll be able to issue more benefits to those kids. So it's an enhanced benefit that will last, we hope, throughout the summer, but at this time, we don't know for sure. And those were additional dollars that were provided from the USDA, the U.S. Department of Agriculture, who funds SNAP. So we will be distributing those dollars as best as we can, relying on the federal government to decide how long we can continue doing that.
Thank
Senator,
you.
Oh, did you have a follow-on, Representative Sweeney?
No, that's okay, Madam Chairman. Thank you.
Senator Schuler.
Thank you, Madam Chair. Just a couple questions on, you mentioned at the very beginning of your slide about the services you offer, and you mentioned about remote visitations. And we are seeing definitely some increases with violence, both with kids and in our community with adults. And I think you mentioned one of your slides about we will definitely see an increased demand because of the economic situation. So I guess what I'm wondering is, do you have any idea when we might be able to, or you might be able to, your department might be able to start having more face-to-face visits instead of the remote visitation? Thank you, Madam Chair.
Director Schmidt.
Madam Chairman, Senator Schuler, we're seeing those numbers increase every day. During the height of the isolation, our face-to-face visits were actually around 26%. So just in the last little bit, we've been able to increase those face-to-face visits by 10%, and we expect that to go upward. We are still working primarily in a remote situation. The face-to-face visits that we have been having, we've been trying to do in parents' homes. We've been trying to do some of those in foster homes, but a lot of them also occurring in our own offices, so that we have some control over the environment, so we can know, that we're sanitary, that people are wearing masks, etc. That is something that we do want to increase, and certainly we've been lucky to have a lot of masks being distributed to us. They're not the N95 masks, but certainly they're still face coverings that we can use for our staff and for our families and the children. So we expect that to go up pretty steadily from here on out as we've been able to secure more PPE. And certainly as we recognize the importance of trying our best to keep families connected during this time.
Thank you. Representative Sweeney.
Thank you, Madam Chairman. On slide 16, 15 or 16, you mentioned the additional need for 17.4 million because of the increased need for childcare, which totally goes in line with additional SNAP benefits. It shouldn't be concerning with the unemployment levels that more people are qualifying. But to that end, you do not believe from your comments that any of the CARES Act money can be utilized for that 17.4 that would need to come out of general funds or some other source?
Director Schmidt.
Madam Chairman, Representative Sweeney, let me back up a little bit and maybe explain this in a different way. So the department right now and has historically received a block grant amount of funding for the federal government to pay child care providers for families who qualify due to financial eligibility. So that's been an ongoing assistance program we've managed for years. It's those dollars that are capped on a regular basis. So once the CARES money is gone, we are still under that block grant and we will still not see an increased federal amount of dollars specific for those families who qualify because of financial eligibility. The CARES Act money is entirely different, and that is what we are hoping that we could receive a portion of for the $17.4 million. The 17.4 is for providers beyond those that serve children who qualify for child care assistance. So there are many child care centers in the state that do not serve children or families who are receiving the assistance. The 17.4 is a much broader population and target as an infrastructure issue, more so than from an economic sustainability issue. We can use these one-time funds to support all families, but they're only one time. The ongoing block grant money is the money that's capped. Does that help?
It does, but not to prolong the conversation, I think maybe, yeah, never mind, Madam Chairman.
But so my understanding, Representative Sweeney, is that they should be able to use $17 million of CARES Act funds for child care services. It can run through their existing authority through the governor's office, and they didn't need us, which is why we didn't draft a bill. Am I still accurate, Director Schmidt?
Yes, Madam Chairman, that's accurate.
Okay. Any more questions for Director Schmidt? Very good. Thank you so much.
Thank you.
We wish you all the best.
Thank you.
Okay. I see sometimes people go away and come back because I didn't really remember to give everybody a little coffee break 2 hours ago. So we'll just carry on with the Department of Insurance. And then, folks, we might actually do a bill before lunch just so that we can see that we manage this. Elizabeth, have we got Department of Insurance ready to tell us their 5-minute report?
Yes, ma'am. We are including. We're accepting them now.
Okay. I see the commissioner's name. I see his black box. Evidently no picture. Can you hear me, Commissioner Rude?
Oh, okay, there we are. I'm sorry, I'm not bringing up the picture, but you all know what I look like with a face for radio, so.
We'll just That's right. We'll just division this. So Commissioner Rude, just give us a brief report on what's, and as I've said to the other agencies and just for the people listening, we're not trying to get the whole after action report right now, and we don't necessarily need to know everything that's happening, but a really brief summary. And then if there's anything statutory that you need urgently in the next month, and then I think we might actually you're the end of the agencies anyway, and then we'll have a bill to talk about. Go ahead, Commissioner.
All right, Madam Chair, Co-Chairman Scott, Jeff Rude from the Department of Insurance. Along with me here is Ms. Burke, our Senior Policy Health Analyst. I'll be very, very brief. I don't want to bury the lead. We have no emergency need for statutory changes. There have been no significant increased operating costs due to the pandemic. And actually, our transition went fairly well. On any given day, we have 4 to 6 people in the office. The rest are working from home, and we are meeting our goals and our metrics despite the pandemic. I will have Ms. Burke talk to any specifics in what's going on related to the COVID-19.
Thank you, Chairman Wilson, members of the committee. Very briefly, I'm going to talk about just 5 things that I think you would be interested in knowing that we've done related to the pandemic. First, in March, we issued a bulletin to all Wyoming licensed health insurers asking for their plan for how they were going to be dealing with the pandemic. And they reported back to us what they were doing with testing, coverages, exclusions, et cetera. And we have that data available. Then secondly, I call your attention to a memo that we put out that is in your materials. And that was just a memo because of the large number of newly unemployed and giving them information about the health insurance options that might be available to them. That is something we will continue to monitor. So for example, the special enrollment period, initially the feds said that they were not going to allow a special enrollment period specifically to related to COVID-19. They are reconsidering that, but as we speak today, that has not been changed. But again, that's a fairly lengthy memo. I'm not going to go through it with you now, but it's there. If you have any questions, by all means, feel welcome to reach out and we will try to answer those. We have been doing a tremendous amount of tracking, like all of the other agencies, working with other agencies and so forth. I think one of the things about the Department of Insurance is we're not in really a position to do so much right now as really what's going to be the effect of this into the future. And so a lot of planning at the national level, state level, about what the effect is going to be on rates, what it's going to do into the future. That's the third one. Fourth one, we worked with CMS and the Department of Labor, specifically looking at the effect on employer groups if, as a result of COVID, they dropped from a large group employer to a small group employer, and if that would then force them to make a change in the health insurance coverage that they had for their employees. CMS was very good in getting back to us. We've met with them a couple of times, and they said that the number of employees is determined in the year prior. So it's an average of the year prior. And if an employer is in a situation where they furlough employees, they can keep them, they are technically still considered an employee. And so that does not affect their total number. And so that may be an option for some employers to consider in order to maintain that large group status and not have to drop to a small group status. We will continue to keep track of what might be developing there. Fourth, we have worked with Wyoming insurers regarding a potential premium holiday. CMS has indicated that they will allow a premium holiday or a premium reduction, several different ways that could be approached. At this point, it's been approved for group coverage, and they're trying to figure out how to make that available for individuals because of the marketplace and people getting different APTC, advanced premium tax credit, different subsidy considerations. So trying to figure out how to do that for an individual versus a group. but it is encouraging to know that our insurers are looking at how to get some premium back to their enrollees. I think it's noteworthy that the Wyoming Hospital Association has indicated there has been a 42% decline in non-emergent elective surgery claims. And so the output by the insurers has dropped considerably, and therefore they're trying to do something to be more reasonable with their insureds through this time. And then my last point is a very positive thing. You may or may not be aware that we have coordinated the licensing of a new health insurer in Wyoming, and that is the Montana Health Co-op. And they will be an insurer on the marketplace beginning for the plan year that will begin enrollment in November. So while we're talking about a lot of things that are not as positive, that's a real positive note for Wyoming and for our department that we have been able to get that insurer on board. So that's a very brief overview, but I took you at your word at 5 minutes, and so you had 5 points from me. So any questions?
Very good. Questions for Commissioner Rude or Ms. Burke, Representative Barlow?
Thank you, Madam Chairman. So the decrease in expenditures by insurers, is that going to impact medical loss ratio, and will there be an issue with that? Thank you.
Chairman Wilson, Representative Barlow, that is one of the questions that CMS considered, and they said because of this being a world pandemic, that it's affecting literally everyone. So they are less concerned about that MLR consideration for a group. They are trying to figure out how to deal with that for the individual. It's not unique to Wyoming. This is happening in a number of other states as well, from several of the very large insurers. I kind of get the impression that because of the depth and scope of this pandemic, the CMS is willing to give some wiggle room in order to address this impact.
Representative Sweeney.
Thank you, Madam Chairman. So I took it that it's a catch-22 with COBRA. You've got a large employer, they're able to offer the COBRA through the plan, yet it's totally unaffordable. Is there any opportunity to drop that requirement either within the state or the federal so that they can go to a potential special enrollment period for the marketplace? Does that make any sense?
Madam Chairman, Representative Sweeney, that is a great question. It is a question that many of us are struggling with. Yes, COBRA is a bit problematic. For one thing, as we saw with the earlier mine closures in Campbell County in particular, if the company offers to provide COBRA and the person elects to take the COBRA, that then excludes them to have open enrollment, or excuse me, from getting a special enrollment until the next open enrollment comes around. So I think what you're really addressing is that gap between if they don't elect to have the COBRA until they can get to the next open enrollment. That is a problem. I wish I had a great solution. I can tell you what some people have done. I don't think that it's the best solution, but some people have gone with a short-term limited duration plan. Some have gone with a healthcare sharing ministry. Unfortunately, some have gone without coverage entirely. Obviously, that is not a good choice, but there is quite a bit of pressure on CMS for this very reason to extend the special enrollment period specifically related to COVID-19, so that if a person loses their job because of COVID-19, that they automatically get that special enrollment. I think, in my crystal ball, I think it's likely that that will occur, but as we speak today, that has not yet happened. Representative Sweeney, does that answer your question?
It does. Thank you. Do you see any need through the co-chairs, any need for special legislation that would help in this particular matter to help our unemployed? And you touched on it. The coal mines are a big part of that, but we have some employers here in town, major employers, Wyoming Machinery, that I'm sure would offer COBRA, but the employees won't be able to afford it.
Ms. Burke.
Madam Chairman, Representative Sweeney, unfortunately, I think we have very little control over that because the COBRA, and while we do have a continuation of employment consideration or a mini COBRA in Wyoming, most of the COBRA law is federal. And so it's, through ERISA. And so we would have relatively little, if none, effect on that, other than politically trying to encourage our national elected officials to know how important it is that the consideration of Wyoming citizens be looked into.
Representative Barlow, you had your hand up a little while ago.
Thank you, Madam Chairman. On the COBRA issue, I guess my inquiry would be, can CARES dollars be used to subsidize COBRA payments on behalf of furloughed or laid off employees? Thank you, Madam Chairman.
Madam Chair, this is Commissioner Rood, Representative Barlow. I do not know. That's something we can explore, but we have not thought down that road before.
Before I check for more questions, just seeing Representative Barlow. Representative Barlow, if you desire, communicate with one of the LSO folks on leaving a vote if you need to depart for Management Council, if you want to do that. Okay, any more questions for the Commissioner or Ms. Burke? Okay, then that's the last of the agencies. Folks, I know we're all probably twitching a little bit, but I think we might actually be able to knock off this telehealth bill, dreamer that I am, and let Department of Insurance go before we break for lunch. So let's give that a try. Ian or John, do we have someone that is going to present the bill initially? And while you're organizing there, let me just give the committee a little bit of backstory on this. There weren't too many of you that were with us when Labor Committee, I think it was 2016, somewhere around there. I can visualize us being up in Lovell, and we were looking at telehealth coverage, and we were assured by the insurers that all the telehealth coverage was just as good as in person, and so we didn't pursue any statutory follow-up at that time. A number of us have heard some issues as mental health providers in particular have been going to telehealth during this COVID time. We did hear some discussion that perhaps the coverage was not quite as all encompassing for remote mental health as we would like to see. So that's also a possibility with the physical health issues. However, I felt, you may disagree with me and make amendments, but I felt that the physical health remote coverage was a bit broader of an issue, and we might really need more testimony on that than we could manage by Zoom. So the bill is drafted now to just, my intention was to, or our intention in communication with a number of you, to make sure that coverage for a remote visit for mental health or substance abuse services would be paid assuming it were a certified provider for that insurer, the same as in person, and just that issue. But we can it looks like Ian has revealed himself here, so I suppose he's going to talk. We can hear about the bill, and I think we've got some folks willing to testify. So Ian, it looks like you're up.
Madam Chairman, thank you. Yes, this is 20 LSO 719. And Madam Chairman, you've already sort of given some of the background to it. In current Wyoming law at 26-20-701, we have an existing statute that requires that insurance policies comply with the Mental Health Parity and Addictions Equity Act. That act currently requires that if an insurer provides coverage for mental health, then that coverage can't be different or less advantageous to the subscriber than benefits for surgical or regular medical coverage. That exists now, but what this bill does, it goes in and draws a finer distinction between coverage within mental health and substance abuse coverage. And it establishes that if you do decide to provide that coverage, then the difference between the coverage for in-person service and coverage for telehealth can't be different. And it calls on 3 different areas of that coverage. These are on page 3 of the bill in the 3 subparagraphs. First provision in paragraph 1 says that, again, if you provide coverage for mental health and substance abuse, you cannot deny coverage for telehealth if you provide coverage for in-person services. The second paragraph says that you can't charge higher amounts for that telehealth services like co-payments, deductibles, or co-insurance amounts. And then the third paragraph goes to the providers of that service, telehealth service, and says that you can't discriminate against the amounts that you would provide for reimbursement or payment for in-person services against those that you would then provide payment for telehealth services. Section 2 of this bill draft provides that it applies to policies that are issued, renewed, or modified after January 1st of 2021. And on the last page, it provides for an immediate effective date. That's a fairly quick summary of the bill, but it's a fairly straightforward bill, I think.
Okay, so before we take public testimony, are there any general questions or comments on the bill? Okay, well then, Elizabeth, at your organization. Oh,
sorry, I did have my hand up.
Sorry, I'm sorry, Representative Clem.
Thank you, Madam Chairman. So I do have a question on this. Does the language in here prohibit, for instance, a lesser copay? For instance, I don't know if this could be incentivized in that if if a company or whatever who is wanting or someone who has a health insurance plan that say that that actually the copay, for instance, instead of being $25 as a normal copay to see an in-person provider, that copay could actually be reduced to $15 to actually incentivize telehealth. Is this bill prohibit any of that kind of activity? Thank you, Madam Chairman.
Ian.
Madam Chairman, Representative Clem, correct. It would allow that incentivization. This prohibits higher co-payment amounts, etc., but it does not prohibit lower co-payment amounts.
Any more questions? I'll try to be a little more alert to hands. And I'm trying to pull up my. Okay. Let's see, Elizabeth, it looks like you've got a list of 4 people who want to testify. You want to let them in in whatever order you want to do it?
Ma'am, I emailed you a list. We can start with Andy and then go to Tom, Wendy, and Lindsay. We'll admit them at your.
Okay, Andy Somerville, come on through. I think through might be better than down in this context. I see your box. And you can unmute yourself whenever you like, if you can. Oh, there we go. Oh, we're even seeing you. Very good.
Thank you, Madam Chairman. Andrea Somerville, I'm with WAMSAC, and I just wanted to provide a few brief comments to the committee in relation to this bill. So first, I want to start off by saying that all of your community mental health centers are providing telehealth services. Some of them were providing that before COVID came into our lives. However, obviously the business models and the care model has changed significantly with the development of the coronavirus, and it has become an extraordinarily important tool in the toolbox, both for mental health and substance abuse treatment. And I would expand that by saying it's not just individual treatment, it's also group therapy as well. It's been an important tool for the providers to be able to continue intensive outpatient groups for substance use that are a core part of that treatment program. And so we just want to let you know how important that is. We've had relatively little issues as the insurance companies have made emergency changes to allow for telehealth payment. But what we want to say is we would like to be able to keep that model going forward. As we all know, the business climate and the care model and what that looks like are a little bit uncertain for the future. And because this has become such a critical tool for our care providers, we would like to continue to incentivize telehealth and make that an option. Of course, I think everybody on the committee understands, especially in the rural parts of the state, telehealth has proved to be invaluable, especially during this time. But I think in future, it can help us continue to expand mental health and substance abuse services. So with that, I would stand for any questions, but we support the bill.
Questions for Ms. Somerville? Okay, thank you.
Thank you.
Okay, I guess we've got Mr. Laycock. There he is. You can unmute yourself if you can manage it. There you go.
All
Mr.
right. Thank you, Madam Chair and members of the committee. My name is Tom Laycock. I'm with AARP Wyoming. I wanted to thank members of the committee for taking the time to consider this bill. Our interest in the bill at AARP is our feeling that mental health and substance abuse counseling is a high need for residents age 50 and over. In terms of evidence for that, I'll point out to the World Health Organization suggested over 20% of adults age 60 and over worldwide suffer from a mental or neurological disorder. That study from 2017 suggests older adults may have experienced health problems, bereavement, or a drop in socioeconomic status that may come with retirement. Those stressors can lead to isolation, loneliness, or psychological distress, in which may require long-term mental health care or worse. Wyoming Department of Health numbers from January of 2018 suggest the highest suicide rates in the state per 100,000 Wyoming citizens actually come in age bands age 70 or older, with a particular spike after age 80. Unfortunately, our friends who are the boots on the ground in senior services in Wyoming tell us those numbers are actually higher than are being reported. While we're supportive of the mental health side of it, we can't ignore the need for increased access to substance abuse treatment in Wyoming for older adults as well. The Substance Abuse and Mental Health Services Administration in 2017 National Survey on Drug Use and Health found that 5.7 million adults over the age of 65 had reported binge drinking in the last month. As you hear later today, telehealth adoption in Wyoming is skyrocketing. Our members are telling us they've been a part of that surge. They enjoy it. They like the change. The bulk of the state's telehealth Zoom license distributions through Wyoming Telehealth Network have been in the field of mental health and substance abuse counseling. We think increased telehealth is something that both providers and patients are looking for. So we do appreciate the access, the increased access of services that would result, we believe, from this bill. We also like one thing in this bill, the audio only coverage parity. We are working to bring our members into doing more and understanding more in the world of webinars, in the world of telehealth online. But there are some who don't have access either to the broadband that is required, or maybe just aren't quite ready to jump on the video piece of that. And we think the telephone option is important. So AARP's party in the bill is the coverage parity as well as the audio only aspects of the bill. For all those reasons, we certainly ask for your support in this bill, and thank you for the time and listening today.
Questions for Mr. Laycock? Okay, great. Thanks so much.
Thank you.
Okay, Wendy Curran, I think we have. I'm not seeing her. Oh, connecting to audio. That's probably her.
Madam Chairman?
Oh, connecting to audio.
There you are.
That's probably her.
This is me.
Is that you at
By
phone number 2107?
Yes.
Okay.
Can you hear me?
We can hear you, Ms. Curran. Thank you.
Thank you. Madam Chairman, members of the committee, Wendy Curran with Blue Cross Blue Shield of Wyoming. We are very supportive of the concepts in this bill. We have, during COVID, greatly expanded and enhanced our use of COVID, of coverage, of working with providers.
There you are. Is that you at phone number 2107? Somebody, someone is, okay.
Madam Chairman?
I can hear you, but we hear someone else in the background. Although everyone else seems muted, so I'm not sure who that is. Go ahead, Ms. Curran.
You might ask her to turn down her volume.
Oh, the other possibility, Ms. Curran, is if you were watching the YouTube video, you need to, I think, turn that off while you're on with us. Otherwise, it has a feedback. Okay. Now try. Are you there still? Now we can't hear you, Ms. Curran. Ms. Curran, are you still there? Now we have her in two places with no sound.
Madam Chairman?
Ms. Curran, there you go.
Thank you.
Okay, we can hear you, and I think only you, so that seems good. Give us a try again.
And I apologize for my lack of technology skills. As I started to say, we have worked very closely with providers to expand and enhance the availability of telemedicine through the COVID outbreak, both to protect the safety and health of our members and to assure that members can continue to get the health care that they need while many providers' offices weren't seeing patients face to face. We adopted a number of changes to our older policy, and I'm sure that a number of those will continue into the future as we grasp this opportunity to make sure that we're providing access at a lower cost point. And I think that this bill before you today goes a long way in doing that. I do have just a couple of questions. I certainly hope that we can have further opportunity to discuss this. I think I don't want to confuse mental health parity, which is the coverage of mental health services, and payment parity, which is you have to pay the same for this as for this. And this bill seems to do both. That may be the intention. We certainly comply with the mental health parity provisions that are included in the Department of Insurance statutes, and have tried our hardest to make sure that we are paying appropriate payments. I was not aware of a problem, and maybe it wasn't with Blue Cross Blue Shield, of mental health providers being paid less or differently for their audio or audiovisual efforts. So I guess if there is a significant problem with that, then this is an appropriate measure to take to remedy that. I would just simply point out two things that you may want to consider. There is a difference between telemedicine and telehealth that is becoming more and more recognized across the country. I think that telemedicine is defined both in the Board of Medicine's licensing statutes and in the Department of Health statutes regarding rural health services. And I would encourage you to perhaps make this change to change telehealth to telemedicine so that it complies with what already exists in statutes and it doesn't become confusing because there is not a separate definition of those two things. And the other thing that I would point out is that I absolutely understand the intent of subsection 3i on page 3, but it does enter into the realm of sort of taking away the ability of a payer to differentiate between the kinds of services that are applied. Not to say that an audio session is different than an office session, but when you get into the technicalities of how things are coded and the ability to, as we have for some of our clients, have certain restrictions or limitations, this is pretty broad language that just says you'll have to pay this way without allowing the sort of finite considerations of different billing codes, an office code versus a timed call. We support it in concept. I'm just wondering if this isn't too broad of a statement to make about how any healthcare insurer will reimburse any service provider.
Questions for Ms. Curran?
Yes.
So, Ms. Curran, I guess two things. One is just on your comment about telehealth versus telemedicine. The only place right now, and I'm skimming kind of fast, that I see that word is on page 1, line 2. Is that the only one that you see?
Yes, and in the title, short title, I guess it is the only place.
Right. And so, and I don't have the definition of telemedicine before me. Would that cover substance use counseling?
Yes, it would. It refers to clinical care, and that involves diagnosis and treatment. And that certainly is substance abuse treatment and diagnosis and care.
I wonder whether maybe the word telehealth, it's a little bit of an awkward construction, telehealth delivered, whether we might even just want the word remote delivered instead. Or do you have any thoughts to that?
Delivered remotely, I think is appropriate. I think that's fine. It's just telemedicine or telehealth has a much broader connotation these days that allows for a number of health education and health outreach and non-clinical health outreach activities. And telemedicine, I think, as we use it, is for medically necessary treatment. That was my only observation. It's really not a huge big deal.
Okay, so then regarding to page 3, paragraph, subparagraph 3 there, I think that paragraph though is, I guess to just clarify, that was probably the heart of what we were hearing. And of course, I don't know what the coding would be, but so it sounds like you're saying that in fact, you do want to pay differently if the provider codes 1 hour counseling session in office versus 1 hour counseling session over the telephone. I mean, that's what you're saying.
Well,
so,
Madam Chairman?
Ms. Curran?
Yes, there are certainly complexities and nuances. For instance, mental health or behavioral health providers can bill their services for a audiovisual counseling session that is based on the number of minutes within the session. They have a code for 15 minutes, a code for 30 minutes, you know, on and on and on. An office visit is coded differently by anyone who completes an office visit. And so the intent is not to be able to say we want to pay you less for what we do. We just want to make sure that we have the ability to recognize that there may be differences inherent in the kind of care that is not the kind of care, but how that care. So saying, I've done a 30-minute telephone consultation and I normally would code it this way, but you need to pay it as what you would pay me for an office visit. Little bit of apples and oranges, and I agree completely with the intent of not reducing payments because the sole factor being that they are being provided remotely.
I feel like you're saying two things. I mean, what I hear you saying is that you want them to code differently, whether the patient is seen for half an hour in the office or half an hour on the telephone, and that then you might actually pay them differently for half an hour on the telephone versus half an hour in the office.
Madam Chairman, those codes are developed by the specialists, by the CMS, and by the American Medical Association. We simply pay according to the code. We don't direct how things should be coded. So those are, that's the part of the issue. And in fact, a similar.
Go ahead. Considering that CMS has, during COVID, changed to authorize payments for patients at home, are they changing the code, or I mean?
You know, they did issue a whole set of new codes to support some of the services that had previously not been allowed, such as telephone visits for Medicare recipients. And there are new codes that reflect that. Is it maybe simply saying for the provision of rental service to an amount that is less than the payment? That could we say something like cannot reduce the payment for the provision of mental health or substance use services to an amount that is less than the payment or reimbursement that would be made to a provider rendering similar services to those services in person, or referring to the similarity of the service?
Well, I hear what you have said, although I think that might not be the intention of the bill. So are there any, Representative Sweeney? Representative Sweeney.
Thank you, Madam Chairman. So in other parts of state statute, do we get into the minutia of coding?
Madam Chairman, Representative Sweeney, we do not. The codes are established by the experts. Reimbursement is set by Medicare and everyone else about what that code defines in terms of the service. I don't believe there is any other coding provisions or payment provisions in state statute.
Representative Sweeney, we do have a situation that's not necessarily coding, but I remember, and Chairman Scott will recall, some years back, maybe 2014, 2015, somewhere, we passed a law requiring insurers to not differentiate between, and it's loose in my head, but between oral and infusion cancer treatments. I don't remember the specifics on that, but probably Chairman Scott will recall that. So that was quite a discussion because one of the forms was a lot more expensive than the other one. And I don't remember if it was co-pays or what. Wendy was probably in the room on the 3rd floor of the Capitol, and she will probably be able to remind us.
Madam Chairman?
Ms. Curran.
Madam Chairman, yes, I believe that is included in the insurance mandates section of state statutes. And it is among a handful of things that insurers operating in the state of Wyoming are mandated to do from the provision and charges to the patient of different services.
Chairman Scott.
But
oh, sorry, did I cut off your sentence, Ms. Curran?
No, ma'am.
Okay, Chairman Scott.
Thank you, Madam Chairman. With regard to the provision here in that 3 little I, it strikes me that in the mental health area, this is much less of a problem than it would be if it was applied to the physical health. Because with physical health, you come in the office, you can do a number of things, starting with an in-person blood pressure check that you just can't do over the telephone, and that issue tends to drop out with the mental health. You're much more similar. So I would think that, I guess my question is, am I right in thinking that this would be a major issue if we were talking about physical health here, but in the mental health area, it's a relatively minor issue?
Ms. Curran.
Madam Chairman, Senator Scott, I think that's right, although as you know, we have had discussions about payment in parity of all telemedicine visits over the past few years, and that has been a concern from the other medical side. It is less of a problem here because we all understand the kind of services that are being provided. And if it just, I think we were simply asking to recognize that this sends a state directive about how we will reimburse without acknowledging that we were talking about similarity of codes or similarity of services. And yes, it would be a bigger problem in the medical field.
Which is why we're not bringing the medical field in this bill during this interim. Any more questions for Ms. Curran?
Madam Chair.
Yes, Ms. Curran.
Madam Chairman. We currently reimburse on the medical side, well, on all of them, the same for a telemedicine visit as we do for an in-office visit. That's the parity. And I think we do that across the board. So again, I'm not sure how significant the problem is because that's not an activity that we engage in. But thank you.
Okay. More questions for Ms. Curran? Okay, thank you. And thank you very much. Then we've got Lindsay Simoneo to call in. And then after her, I realized that I forgot to get agency input after I made them sit around. So we'll just finish off the public comment and then circle back to the agencies. Elizabeth, can you let Ms. Simoneo in? Oh, there she is.
Wonderful, Madam Chairman. Can you hear me?
We can hear you.
Beautiful. Members of the committee, my name is Lindsay Simoneo. I represent the Wyoming Counseling Association. When COVID started back around March 13th, what our private providers saw and what our members saw who were working in agencies were initial denials from insurance companies saying that they did not cover telehealth or telemedicine services for mental health and substance abuse. As my colleague Andy Somerville has said, many of those payers and plans have adjusted temporarily to provide those telehealth services. Personally, I can tell you that my caseload, many of them will have telehealth services approved until August of this year, when those payers and providers, I assume, will reassess and extend based on what is going on within the COVID situation. In light of that, we are in huge support of this bill to make this a permanent bar for insurance payers to cover these services. With things being initially denied within that first 7 to 10 days, many people decided to discontinue care across the state with their private providers or within community centers. Now that this has gone longer, now that insurance companies have temporarily provided services, we have seen that number increase within our caseloads, within centers, and within our private providers as well. We think that we are in huge support of this bill, and we think that with the passage of this bill, it will ensure that those who need mental health and substance abuse services during this time of crisis will feel comfortable reaching out for those services, knowing that their plans are going to provide that, regardless of circumstance. I stand for any questions, and I thank the board, or I thank the committee for their time.
Representative Sweeney.
Thank you, Madam Chairman. Lindsay, do you, in the language of the bill, do you think it's too broad, too narrow, that you wouldn't be able to code sufficiently to make it all work?
Ms. Simonelli.
Madam Chairman, Representative Sweeney, as of right now, the way that I personally code is by location. That I am billing the same code regardless of telehealth or in person. It is the same code, and then the differentiation when it gets billed to insurance is within the location line. Did this happen in my office, or does this happen in telehealth? I have not introduced any of the new telehealth codes into my practice, so I don't have any experience with them. As of right now, just with the location setting, I'm not having an issue with billing. Neither are my other private providers, that just by changing the location, they're able to get reimbursed, whereas before they had initial denials because of that. So I think if this does become a more permanent standard, that we will welcome those codes, because we know that we want to keep track of who is providing what and when, and I don't see that being an issue integrating those new telehealth or telemedicine codes within to our practice.
Thank you, Madam Chairman.
More questions for Ms. Simonelli. Representative Stivar.
Yes, the question I have is the number of visits. Is it still 20 visits is all they can have, or is that number went up?
That depends on plan. If an insurance plan does require a limitation on visits, the standard is usually 20, is what I have seen. I see that with some of the state plans. Mainly we run into the 20 visits with Medicaid is where we interact with that the most. I am assuming that the 20 visits would also apply for Medicaid, regardless of telehealth or in person.
But during this crisis, don't you think, through the chairman, that we need to bring them numbers up, them visit numbers up?
Ms. Simonelli.
Madam Chairman, Representative Stivar, yes, across the board, any mental health provider will tell you, especially somebody who is on Medicaid, there's more than likely environmental issues, there's more than likely chronic behavioral health situations that need to be addressed that cannot be addressed in 20 sessions. Medicaid does allow us to provide a pre-authorization in order to get more visits. That becomes a very complicated process within the Medicaid office. And it would make access easier for that limitation to be, or for the number of visits to be increased, yes.
Although Representative Stivar, I do think that's a different issue than this bill in particular. I mean, that's a separate issue. More questions for Ms. Simonelli. Okay, great. Thank you so much.
Absolutely. Thank you, Madam Chairman.
Commissioner Rude or Ms. Burke, if you're still here, I neglected to ask for Department of Insurance input on this bill, which I guess I ought to have done. So if you're still there, we would be glad to hear from you. Maybe they went to lunch. Oh, he's still there. I see his box.
Madam Chairman, sorry, are you calling on the health department? We were just admitted.
I was actually calling on the insurance commissioner because it's an insurance bill.
Madam Chairman, roger that.
Although we always like to hear from Franz. Commissioner Root, are you there still? He's walked down the hall to let out the dog, probably. I don't even know if he has a dog. Ms. Burke, are you there?
There you are.
Oh, good.
Trying to log in.
Thank you.
Thank you for allowing us back in. We'd sent text messages saying, we can't get in. So a couple
Sorry.
of things that
I'm sorry, I've neglected to ask from you on this bill before I took public comment.
No problem. Thank you, Chairman Wilson. We had a couple of comments that we wanted to add. First of all, if I could respond to the question that was asked just a minute ago about a number limitation on visits. That's a much more involved question because that's actually getting into the difference between what is called an NQTL and a QTL, a non-qualified treatment limitation and a qualified treatment limitation. That's much more in depth and down into the weeds than I think we want to go right here. But if there is a justification, if there is a rationale for having a limit on the number, there are some real criteria that have to be met to allow that specific number, because there are many kinds of mental health treatments, substance abuse treatments that are considered not to fit within that numerical limitation. Again, that's far beyond what this bill is trying to do. But one question that we had from the Department of Insurance question, and that is on page 3, line 15, and that is simply the phraseology qualified healthcare provider. Because we are currently working with the Wyoming Telehealth Network and with several other individuals requested by Governor Gordon to be looking at telehealth, there are some questions about who is making a determination of who is the qualified healthcare provider. I can tell you very specifically, for example, in the area of autism, there are different opinions of who is a qualified provider for specified types of autism treatment, and that has become a bit of controversy. So while that is not specifically a Department of Insurance issue, I think that the Mental Health Board and other people working on the telehealth issues do have some concerns about more carefully defining who are these qualified healthcare providers to be providing the mental health services. And if this language is limiting enough or defining enough, maybe a better way to describe that.
So Ms. Berg, before you go on to your next item, thanks for bringing that up, because I think when, and I'm not positive, you can imagine it was kind of challenging drafting things constantly by email, but it seemed to me, or whether I'm remembering or not, that the intention there, and the original word might have even been certified or something. And I think what it was that I understood that insurers, when a person applies to be a provider, an authorized provider, maybe the word authorized would be better, that the insurance company has some methodology of certifying or authorizing that you are a provider for this insurance company. And so I think that was what we were attempting to get at, just that if this person is on your list already, then you can't differentiate. I think that's what we are aiming at. Does that make sense with what insurance folks do?
Madam Chairman, yes, I think that is clarification. I don't know if we want to consider explaining that. I know you're trying to keep the statutory language as clean and straightforward as possible, but perhaps maybe even Ms. Kern could respond to that particular word qualified and how the insurers look at that. We, as the Department of Insurance, really do look to the insurers and how they are interpreting. I believe what you're describing in part is the in-network providers and who they deem that a claim can be paid. I mean, you can't just hang out your services and say, I'm going to provide this mental health because I feel like it. They do look for the licensure, the areas of specialization and so forth. That goes beyond what we regulate. But as I said, this other consortium and group of people, we are looking at how to define who can do what within the telehealth realm. That goes
Okay,
beyond this bill.
So just alerting Ms. Curran from Blue Cross, so we may bring you back in. I see you're still out in the waiting room. I think maybe the word right there might not be what we meant to have. Okay, Ms. Burke, did you have another comment on the bill?
I don't believe so. Thank you, Madam Chairman.
Okay. Ms. Curran, I think I saw you pop back in. Yes, there's your, you'll have to try again by telephone, I guess, or however, whatever works for you, Ms. Curran. We see her black box with white.
Ma'am, we see her video, but we do not see her phone string, so we don't know if she can speak until she rejoins with that phone string.
Ms. Curran, if you can hear us, try to call or send us an email or something. Ms. Curran, if you're talking, we can't hear you. We're getting a message in from LSO. Okay, well, failing answer from Ms. Curran, you will notice, members, that we have an email from LSO stating that they don't really feel like we need any specific word in there at all, just that we could leave out the word qualified and just say provided to a healthcare provider and not need to address that particular issue. Mr. Shaw, did you want to comment further on that? Seeing as I'm reading your email.
All right. Yeah, no, Madam Chairman, that's exactly right. I think the committee could consider whether that qualified language is necessary at all. This statute, this portion of the statute doesn't necessarily need to deal with which providers are qualified for that reimbursement. That's dealt with elsewhere. So that language, that word qualified could simply be omitted. The committee might want to consider that.
Okay, failing any ability of Ms. Curran to enter the system, we'll kind of go with that. Okay, is there any other public? Let's see, nobody else has been let in. Is there anyone else who's hanging around that wants to, I see Representative, oh, beg your pardon, actually, Chairman Scott.
Madam Chairman, thank you. Question for the Health Department. When you look at, or excuse me, not the Health Department, Insurance Department, looking at Section 2 of the bill on page 3, we have on the last line a January 1st, 2021 date. Should we change that to October 1st, 2020, have this go into effect in terms of when it applies to new contracts that much earlier, so we would catch a number of open enrollment periods we might otherwise miss?
Ms. Burke or Commissioner?
Madam Chair, Co-Chairman Scott, you could, the problem you would have with that though is rates and the policies have already been submitted and approved through CMS at this point. And so if there was additional costs, I mean, it would fall to the insurers and they would not have, factored them into their rates. So I guess that's why I only input there.
Well, Commissioner Rude, though, but if it were a policy delivered January 1st, they've also already established their rate, whether it's October or January. We just put January 1 as a typical start date. And Senator Scott did have comment to me a few days ago, the idea that if they weren't providing this service by remote, probably the patient would come in and see someone. So they're probably not losing anything there. But whether it's October or January 1, wouldn't that be the same contracts, Commissioner Rood?
Madam Chairman, this is Denise Burke. I think that the difficulty would be the timing, and we already have a lot of dates changing and so forth for the filing of new plans for the plan year 2021. It could be something we could approach CMS about and the approvals and so forth. It would be a much cleaner process if they go into effect with the plans that begin on January 1 of 2021.
Okay, Representative Barlow.
Thank you, Madam Chairman. So that was one of the questions I had, was the start date. Second question I have is under Romanet little I, it looks like to me now this is a mandate, even though it's not in the mandate component part of statute under insurance, it still is a mandate. So in past, as we have contemplated mandates for different things, there's been a cost, there's been a reimbursable cost that comes out of the assessments. So is there a consideration? Does that come into play in this one? That's my first question. Thank
you. Commissioner or Ms. Burke.
Madam Chair, Representative Barlow, we've discussed that, and it's a concern. On one hand, if you're just mandating equitable payment of two services, you're not getting into that realm. But if you're adding a service, which if you're mandating a particular, remote audio visual, then they could determine, I suppose they could argue that they would in fact consider that a mandate. We do know that they are more active now in holding states accountable for what they view as new mandates. Mm-hmm. They have made that clear to us in past months with various conversations.
But Commissioner Rood, being as the care provided to a person, counseling is not a new mandate. Do you think that this might somehow be perceived as a new mandate nonetheless?
Madam Chair, I suppose it's possible if CMS says, well, now you're mandating, use of remote audio and audio visual where it wasn't before. I think there's an argument that, like I said, we're actually just mandating payments, to be the same for services versus a new service. I think that would be our argument. I can't guarantee how they'll react to that, though.
Representative Barlow, did you have a second question?
Thank you, Madam Chairman. And so that the interaction between Romanet I and 3I is, I think, exactly what I'm trying to get to is, it looks to me like we are mandating it that they both provide both types of services, meaning if they're going to provide, they have to provide one, and number one, they have to provide the same service or they have to provide coverage. And in 3, we're saying they have to pay the same, meaning they'd have to provide in-person services as well. So I wonder how this actually deals with our remote folks, who that's all they do is provide remote health care. And that's probably not a question for the Department of Insurance, but that's just another observation that I've made where I've been trying to sort out. Thank you.
Madam Chair,
Representative.
Madam Chair, if it would help the committee, if you want to proceed as you plan, while you do that, we'll go direct to CMS and see if we can get a reading out of them on this issue.
Well, that seems fine if they actually provide that kind of turnaround.
They have been very responsive.
Representative Barlow, my thought on, because this is to the insurers, I don't think there are any insurers that only pay for remote services and not for in-person, surely. That doesn't seem very likely. Representative Barlow.
Madam Chairman, I agree with you, but I'm talking about the providers. If the provider only provides one type of service and not the other, then that's the issue that I guess I'm pointing toward. Thank you.
Representative Sweeney.
Can we, I know we like to have it all amended and ready to go in a nice little package, but with these times and the limited amount of time, are there some things that perhaps Ian can work through for us that to work some of these fine details out? I think, as I read it, I think Ian's already taken care of a lot of these issues that we're getting weighted down in, but I hope the intent isn't trying to kill this, because I've got to believe other states have got and have already delivered a very similar product, and I'm surprised the insurance commissioner didn't allude to that, or maybe they haven't checked that out, what other states have already done.
Chairman Scott.
Madam Chairman, it would seem to me that a couple of things in the comments here. I don't see how we can construe this bill as requiring a provider to be providing services that they don't want to, whether it's in person or telehealth. I think we're simply providing, if they do provide a service, that the reimbursement's the same. So I don't think we're mandating the providers to do anything. With regard to the question of the is that going to be considered to be a mandate we've got to pay for under the ACA, where we have been burned? I suspect we're well protected, but I think it's prudent to have the insurance department, if we approve this, see if they can get a reading from CMS between now and whenever our prospective special session is. I think there'd be two issues. One would be, is it a mandate? And second, is there any cost to it? If you just, what the state's potentially liable for is an additional cost, and I can't see the additional cost here. So I think that's an issue too. If it was a mandate, if there's no additional cost, it's a so what. So with that, Madam Chairman, if it's appropriate, I would move the bill for introduction in a special session if one gets called in the June-July time frame, and then I'll have a single one-word amendment.
Chairman Scott, if I can just delay you on that for one moment. I see that Wendy Curran did finally show up in the waiting room. Maybe we could just double check with her, since we called on her several times. Ms. Curran. I hear a telephone. Ms. Curran.
Ma'am, Madam Chairman.
There you were. We had a question on page 3, line 15. And we kind of decided to go ahead without our question being answered, but seeing as you're back, the word qualified healthcare provider, I think the original intention was perhaps not even that word, but to capture in some way, our understanding is that insurance companies, if you want to be a provider of whatever, orthopedic surgery or mental health care, you in some way get on some sort of approved list by the insurance company, and you're either certified or enrolled or whatever the exact adjective is. So evidently qualified is not the best word. Is there a word that you folks typically use for someone who is enrolled into your system as an authorized provider? Or should we just where we were going before we got you back was to just delete the adjective entirely.
Madam Chairman,
Yes.
I think
Ms.
that
Curran.
qualified healthcare provider is the term we use very regularly in statute to define those people who provide healthcare services under the right sort of, I believe they include counselors and mental health counselors and all the people who are licensed by the state to provide patient care. And I don't think that removing qualified, we may have something in our credentialing process that requires state licensure. I don't know if it references qualified healthcare provider, but in network or out of network is how we refer to those people who have been credentialed and asked to participate with us in providing care. I don't know if that helps or not. I don't think it's the qualified healthcare provider that
Well, I think
changes the dynamic.
in the ordinary sense of the word qualified, there was some discussion about, arguments as to whether person X is qualified to provide care or not. If we delete the word qualified, is that any detriment as far as you perceive?
Madam Chairman, no, I think that qualified healthcare provider is a defined term in statute, but I don't suppose that it matters if you take it out.
Okay. Chairman Scott, you had your hand up briefly and it went away again.
Madam Chairman, I was simply going to ask the same question you asked.
Okay, well, very good then. Okay, thank you, Ms. Curran. All right, so Senator Scott, back to you. Feel free to re-articulate your statement.
Madam Chairman, I would move that we approve this bill draft for introduction as a committee bill in the coming special session that's planned for June or July.
Okay, is there a second?
I'll
Just wave
second.
your hand. Oh, I saw Representative Stivar. Okay, seconded by Stivar. Are there any amendments?
Madam Chairman.
Senator Scott.
Madam Chairman, on page 3, line 15, I would move that we delete the word qualified, so it would just read provide to a healthcare provider. I think the qualified introduces some confusion, and I don't know that that term is qualified healthcare provider is specifically defined in the relevant section of the insurance code.
Okay, is there a second?
Second.
Just wave your hand. Seconded by Baldwin. Okay, and let's, for this purposes, rather than the blue hands, we'll just use your hand in front of the face. Is there any discussion of this amendment? Okay, all in favor, please put your hand in front of your face. All right, that amendment passes. Any opposed? No, okay, that amendment passes. Any other amendments? I have one, actually. Back on page 1, line 2, I would move to delete the words telehealth delivered. And then on line 3, after the word services, insert delivered remotely. Is there a second? Seconded by Sweeney. Any discussion? Representative Yin.
Thank you, Madam Chairman. Just a question to LSO to make sure that there is no issue with the amendment, given the text of the bill.
Ian or John?
Madam Chairman, I think that works nicely. I did look up in the statutes, and telemedicine, as Ms. Curran indicated, is defined in the medical profession licensing statutes. To me, it's just as you represented, the provision of licensed medical care. The term telehealth is used in the statutes, but it's used when they're setting up programs for the promotion of telehealth/telemedicine. And so I don't have any problem with that amendment. I think it works fine.
Any other, Representative Barlow?
Thank you, Madam Chairman. So just to that point, Title 33, Chapter 1 has a section that allows, a broad section that allows all the licensing boards to adopt telehealth, telemedicine. I think that's what our attorney, Mr. Shaw, is referring to. So that does go to the qualified issue. That does go to those boards being able to set the parameters for how telehealth or telemedicine, as you wish to use it, is purveyed by licensed professionals. And that's the key. Talk about qualified, but these are licensed professionals in Wyoming. So I think it's fine to use remote, but we have to be clear that the board still get to say who's qualified to do this, i.e. licensed.
And that would fall under their licensing and provision of care, not particular to the insurance issue. Okay, any more discussion of this amendment? Okay, everyone in favor of the amendment, please put your hand in front of your face. Any opposed? Oh, one. All right, one. Then this amendment passes as well. Did you get that, LSO?
Madam Chairman, we did.
Okay. Any other amendments? Okay, then Ian, are you taking the roll?
Madam Chairman, I don't believe I am.
Then John or whoever, Wendy, anybody? Franz. John.
Madam Chairman.
Would you call the roll, please?
Sure. Okay. This is the vote on 20 LSO 719 as amended. Senator Baldwin.
Aye.
Senator Bouchard.
Aye.
Senator Pappas.
Aye.
Senator Schuler.
Aye.
Representative Barlow.
No.
Representatives Clem.
Aye.
Representative Dayton Selman.
Aye.
Representative Hallinan.
Aye.
Representative Roscoe.
Aye.
Representative Stivar.
Aye.
Representative Sweeney.
Aye.
Representative Yin.
Aye.
Co-Chairman Scott.
Aye.
Co-Chairman Wilson.
Aye.
The bill has been adopted.
Okay, and I will say, and I don't know if this is Representative Barlow's concern or not, but certainly since I experienced that problem of the mandate falling upon the general fund, I have been very cognizant of that. So Commissioner Rood, I see that your square is still on, or your rectangle. If we can just follow up and double check on that, because committee, if we do end up having another brief meeting before the next session to consider the Medicaid bill and various other things, if we find out that this would in fact be a mandate that falls upon the general fund, we may wish to reconsider this, just to be sure that we know what we're doing. Representative Barlow, you look like you're going to spring forward to ask a question. Even I beat his hand. Representative Barlow.
Thank you, Madam Chairman. I'm sorry, I am participating in two meetings, so I'm
You're doing great.
So Madam Chairman, so the mandate issue was one issue I voted no on. The second one is the bullet 3. One of the biggest challenges we have is healthcare is the overall cost. And for me, this does not help us address the overall cost. And we have a cost-based system when it comes to CMS, Medicare and Medicaid. Providers, this is what it costs us to provide care, and that's what we don't reimburse it 100% for many services, but that's what we base this on. So my concern is that is the cost of delivering care remotely the same as the cost of in-person care? And this goes to Senator Scott's point and others' point about on the medical side, we would not be having this same discussion. But I think it would have been worth having that discussion here. The third thing I would say is that, as you'll recall, the beginning part of this bill, the existing statute, was a bill that Representative Dayton brought, I think 2 years ago, that parity bill. And what I didn't get to ask the question to the department was, based on the discussions we had, I think it was, like I said, 2 years ago, how many insurers are actually covered by this, even though we have that expansive language. It says, even though you're not covered by Wyoming Insurance Department, you have to follow this. And then have there been any exemptions from that as well? Because we gave them authority to write rules for exemptions. So those are the three things that I guess I'm hesitant regarding this bill as far as saying we're going to sponsor it for a session at this point. Thank you, Matt.
Okay, so committee, because we have just barreled on forever, I don't think we're going to attempt to tackle the next two bills, which frankly, I thought the telehealth one would be the shortest. So we will depart for a half an hour lunch now. I recognize an email from Senator Pappas, who will be a little bit back late. Those of you, Representative Barlow, Senator Pappas, if you have got some other committee or something else, make sure to leave in a vote if you feel that you can. Who knows, we might be speedier than we think on these. And then let's see, I think I have a couple of announcements here. Remember, committee members, to turn off your sound and your video when you're on break. Otherwise, I think we've all done really well on having your mic muted when you're not speaking. Initially, they were going to change YouTube links after lunch, but that's not the change. LSO, is there anything that we need to alert people to before we break for lunch?
Madam Chairman, this is Ian. I don't believe so, although I'll let either Elizabeth or Katie speak to that if they have any of the technical issues.
Ma'am, the only suggestion I would have for folks is if they are participating in this afternoon session and they run into technical difficulties, if they would please email Katie or I, we can help them almost immediately because we're monitoring all of what is going on. That'll be the quickest and simplest way if you want to get back on the stream or if you have an issue with your audio or video to reach one of us. I am Elizabeth Martineau. You can find my information on the website under my name, and Katie Talbot is the other individual helping. Thank you.
Chairman Scott, anything before we break for a half-hour lunch?
No, Madam Chairman.
Okay, so seeing as we're all sitting in our houses, probably, except for LSO, we should be able to shuffle down the hall to our kitchens and get our lunch, and let's be back at 1:05 and we'll pick up with the other two bill drafts. Okay, the meeting is in recess. Well, I'm back. Do we have any LSO back?
Madam Chairman, John Brody's here, and I believe Elizabeth and Katie are also just working in the background.
Okay, so are we set to begin again? Let's see, who all do we have? If you're here, put your video on so we can see you. I know, say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so I know Senator Pappas had to go over to Cary Junior High. Senator Bouchard got called out on a job. Senator Scott, we're sort of short on senators. Oh, here's Senator Schuler. Oh, Senator Bouchard. So we have a majority of both chamber anyway. Senator Scott, ready to begin again?
Yes.
Okay. Well, committee, I hope not we don't want to rush through things. It's good we're being thoughtful, but it's a little harder to jam. Well, I didn't try to jam 2 days into one day, but anyway, we'll just progress. So, committee, let's pick up with LSO 716, Community Health Center and Rural Health Clinic Assistance. And let me just, before we have LSO present this, let me just give a little background on this as well. Again, this is part of our project attempting to push CARES Act money through the system in the simplest way possible. And I started working on this even before we saw what we did at the special session. So you'll see that there will be some overlap. This statute 92127 has been around. Actually, Senator Scott confessed to have had an early hand on it. I think 2009 or somewhere in there. And the idea was to provide, at the time, capital construction and startup costs to community health centers and rural health clinics. So that would be FQHCs, and the rural health clinic is also defined by CMS. So the reason that I thought of doing this is because it seemed to me that the simpler, rather than trying to create new programs, if we could run money through existing programs with tweaks, we would just make life easier on everybody. So what we had this bill to do, if you want to go ahead with it, is run CARES Act money through this. I added in, and this is up for discussion, community mental health centers. The idea being that they could use this money, and I haven't taken out the capital construction because we don't want to aim at ongoing operating costs. Obviously, the CARES Act money has to be used by December 30th. So the things that I'm thinking and the ideas that I've gathered from the various clinics would be telehealth hardware, electronic health record hardware. If you needed to remodel your clinic to come up with, say, an isolation room to see folks. So these are, basically these are the clinics that are seeing the low income folks for the most part. You will notice, and I'm skipping ahead a little bit, but we've inserted on page 4, for some reason, and it's not entirely clear to me why this was, but community health center under the feds includes migrant and homeless centers, which we actually have, I think, a couple of in Wyoming. But in the rulemaking process for this original bill, those were taken out. So I don't see any reason to take them out. I mean, certainly if you've got a migrant and homeless population, they have COVID challenges too. So I put them back in just for the purposes of this bill. You will recall that in Senate file, forget which one it was. At 1001, I think it was. There was there were a number of sections where money could go out, and they gave a lot of assignment to SLIB and the State Building Commission. And it seemed to me that we ended up giving them a lot of assignments. And seeing as this program was already in existence, I thought, why not take the particular health center and rural health section and let the health department run it as they're already used to running and have rules for, and are much closer to the situation of what health clinics, they're used to working with those folks. So there's some, you'll see that that's a notwithstanding on the top of page 4. So again, the other thing, let me just, if we do nothing else, I feel like this bill, part of this bill needs to happen either now or next session. On page 2, you'll see there's a repealer, line 12. I discovered when I was reading through this part that this whole program, which frankly has not been funded in like 4 years. I mean, it's still on the books and we haven't given it any money because we were broke. So these people haven't been doing anything for 4 years. The whole program was repealed. And I thought, if nothing else, we should take out the sunset date so that we can, I mean, we all know what the state's financial picture looks like going forward. But anyway, that's my 30,000 foot, and whoever from LSO wants to present it, that would be helpful. Oh, and Chairman Scott has got his hand up. Chairman Scott.
Madam Chairman, I just wanted to add a little background here. This was originally, I believe, a committee bill, and we were wanting to promote these community health centers. They've got a couple of real advantages. They have been, on occasion, they're primarily intended for the part of the population's had trouble affording health care, but they have been very useful in a number of communities when there's a mineral boom on, and there simply aren't enough providers to go around. For a while here in Casper, the one here had a major market share, including a lot of people that had perfectly good access to insurance and couldn't find a provider. They have a couple of advantages. The way the feds have structured their billing system, they avoid some of the incentives for extra procedures that you find in a fee-for-service system. Probably more important, when we're having malpractice problems, these people are under the Federal Tort Claims Act, and that is a very, very effective system the federal government can do and the rest of us can't for dealing with that particular issue. So they had advantages there too. And the conception behind the bill, at the time it was passed, we were having a boom and we had extra money to spend, was we would have it and we would fund it when there was extra spend and not fund it when there wasn't. So if with the federal money concerning the COVID things and the fact these people are going to have some real expenses related to COVID, it makes sense to fund this again. And you cited some of the things they might have to do. So it does make a good deal of sense to me in terms of the original concept and keeping the original concept going forward here.
And
I don't anticipate it having general fund available in the immediate or foreseeable future. God knows when the next oil boom will be, or if there will even be one. But it does make it appropriate for CARES Act fund.
Committee, I did just shoot an email to you with an Excel file that gives the list of what clinics fall under these categories, and there are, well, I can't tell the way I have the thing up here. There's, let's just say there's quite a number of them. So you can look at your, if you can manage to double screen yourself. I'm afraid of losing blue hands if I look at it myself, but you did get it. Representative Clem.
Yeah, thank you, Madam Chairman. So I'm still kind of struggling with this bill. I guess trying to figure out exactly what it does that's different. I guess I'm not familiar with the program that no longer exists but still exists that we're wanting to fund with these CARES Act dollars. And what advantage does it give people right now? I guess what I'm trying to figure out is it absolutely needed? I know we received a large sum of money as far as the CARES Act dollars, but every time we commit dollars to a different program, it just the slices of the pie get smaller. And so I just want to make sure that we're not duplicating services by having such a bill. It sounds like it's not a bad idea by any means, but if we could hear some discussion on that. Is it absolutely needful? Are we duplicating services? Do other entities provide such services already? Those are the kind of questions that I really would like to have answered. Thank you, Madam Chair.
Chairman Scott.
Yes, in response to that, like many of the CARES Act things, it's not absolutely necessary, but it's very useful. There are all kinds of different ways to provide healthcare services. This is just one of many, and frankly, given our provider shortages, we need them all. And what is different here and is appropriate here, these people are going to incur or are incurring or need to incur some expenses to deal with the COVID thing. That's what the federal monies are for. So it makes sense to make them eligible. And that just adds to the flexibility that the executive branch has in terms of how they spend money. They're a valuable part of our healthcare system, and getting capital money the way they're organized has been is an ongoing difficulty for this outfit.
And so, Representative Clem, I see you, and I just, before I call on you, I was just going to say, and because I don't know the clinics that are in everybody's neck of the woods, the ones that are up in your area, and I'm speaking your area kind of broadly, but Rawhide Rural Health Clinic in Lusk is on this list. Regional Health Medical Clinic in Newcastle, Sundance Clinic in Sundance, Regional Health Medical Clinic in Upton. I think those are more or less near you. Okay, Representative Clem.
Yeah, thank you, Madam Chairman. Just to follow up on what the good co-chairman just spoke on as far as expanding as far as expanding services to those who are impacted by COVID-19, do we have any information as far as how useful, I'm trying to think of the word, given our rate of prevalency now, and it seems like the number of cases are going down, I'm just wondering how much this is going to be used. I certainly think it probably could be advantageous for other services as well, not just COVID related, but by and large, it seems our COVID numbers are very, very small. And so I wonder about expanding and using a lot of money for very few cases. So any feedback there would be helpful. Thank you.
Representative Barlow.
Thank you, Madam Chairman. So in the definitions, it includes the community mental health centers. So I don't believe those are included on this sheet. So that would include whatever number of those. And then the second thing, I guess, I don't see how they're actually included into the bill. I see them in the definition, but I'm still reading through, trying to short that. Thank you, Madam Chairman. I'll wait for the discussion of the.
Right, and no, I'll answer that now, and I do have, so that's an interesting question. And the thing is that the program as existing says community health center and rural health clinic. So then what we do in the bill in section 3, so not amending the green book, the green books themselves, but just in this, we say on page 4, for purposes of this section, a community health center means, and then I was going to move something around here because the language is a little awkward, but either a health center receiving federal funding, which would be the community health centers, or a community mental health center. So we've inserted community mental health center into the definition of community health center just for the purposes of this. That was the way that it was drafted. And then it explains community mental health center. So that's how that happened on this. Let's see, any more blue hands? Okay, Ian, was it you that was going to explain the bill? Or John? They've all gone away. Oh, John. Hello, John.
Hello, Madam Chairman. So you have kind of gone over the basics of the bill. I'll just try to kind of go through some issues we've noted and then maybe an explanation on why we drafted the bill, the way we did. So as was previously commented upon, because this is a temporary program, we thought it best to simply amend Wyoming Statute 92127 to allow for the possibility that this grant program would be used for other purposes. So if you look on page 2, the new paragraph 8 basically is just kind of a change to allow for these additional purposes to be used. We then go into section 2, which is, you noted, is the repealer of the sunset date. Of note, the committee should have received in their materials a copy of the statute 92127, just to try and provide some kind of context of how this bill works. Specifically to that repeal provision, this program is set to repeal on June 30th of 2021, just for information purposes. Thought I'd share that. Moving on to section 3, again, this is a time-gated program, so beginning July 1st of 2020 and then ending December 30th of 2020, the grants may be awarded for the purposes that have been discussed. December 30th being the deadline that is provided through the CARES Act for federal funds. The staff comment that we have on the beginning of page 3 relates to one of the requirements under the statutory program. Now that requirement is for the county commissioners to approve a plan for a grant under this program, and then it also requires public notice and a public hearing. I just wanted to raise attention to that requirement and leave it for the committee to decide on whether or not that requirement should be part of the bill, or kind of due to the extreme circumstances that this pandemic has placed Wyoming in, whether maybe something a little bit more streamlined should be contemplated. So again, that staff comment is just to simply try to highlight that. Page 3, line 18, just kind of identifies the parameters of the grant. So $400,000 being the upper limit. And then also one of the requirements in the statute of 127 is that there's a matching funds requirement, and through that, the grant recipient would have to provide evidence that they were going to provide those matching funds. And since as we were instructed to draft the bill, there is no matching funds requirement, so we just simply made note of that in subsection B. Subsection C, the main, I think, takeaway of that is that the Department of Health will have the ability to just make all of the funds provided under the grant available immediately. This is, I think, partly in response to just the nature of the CARES funds and the fact that they have to be expended before December 30th of 2020. Chairman Wilson already noted on this, but under Senate File 1002, the State Loan and Investment Board and the State Building Commission, in a similar program, had to approve money, basically grants that were provided for a similar purpose. And this would simply take them out of the equation and allow for the Department of Health to administer these grants in the same fashion that they have administered this grant program historically. Page 4, beginning on line 4, this is just some definitions. Again, we have community health center, which includes now a community mental health center or a health center that receives federal funding under the Public Health Service Act. And then under Section 330, that also does include migrant workers and homeless populations. So that's just kind of recognizing that fact. Community mental health center, again, just trying to provide some guidance on what is intended by using that term, and same intent for rural healthcare clinics. Page 5, beginning on line 1, this is just kind of a standard insertion, just, I guess, reaffirming that if the Department of Health feels they need to issue or promulgate some rules, emergency or otherwise, they do indeed have that authority. Section 3 is pretty standard language that we'll be using when it comes to these CARES funds. I guess 2 things of note. The bill, essentially Senate File 1001, I believe, gave all the CARES Act to the governor, and it time gated all the release of those funds to the governor for the purposes of assisting citizens. So what this section does is it reappropriates from the governor and gives it to the Department of Health. The Department of Health would then administer this program, and then beginning on September 15th, they would estimate how much money's left, and of the money that is left, that would get transferred back to the governor to distribute as he would as if the money hadn't been diverted to the Department of Health in the first instance. The other point I just wanted to raise, and this was more just an insertion of the dollar amount. It currently has $15 million. Just for everyone's information, LSO does not have any information to really substantiate that number. We don't know if it's not enough or too much, but it was important to obviously put a number in there for discussion purposes. So I just wanted to provide a little bit of context on that. And then lastly, Section 5 on page 6 just is the effective date, and this bill would become effective immediately. So with any questions, I'm happy to answer, or otherwise, that's the bill.
And before I take questions, I will just say I have a few amendments ready. We're not going to discuss them now, but just to clarify the expenses under bottom of page 2, to add, well, to remove out the county commissioners as was in the staff comment, and to kind of rearrange the language a little bit on page 4 under the community health center and the community mental health centers. But those are, we'll discuss those later. Okay, let's see, Representative Clem.
Thank you, Madam Chairman. A couple of questions. One is, did any of, for the entities that qualify in this bill, did they receive any other CARES Act funds? I know our hospitals did, but and I'm sure maybe some of them qualified for the PPP program, but I'm just curious what other kind of federal funds, if any, did they receive already? I guess that's number 1. And I had a number 2, but I forgot it. So I'll just start with that. Thank you, Madam Chairman.
We may have either LSO or Department of Health might be able to answer on that, but I will say it seems to my recollection that PPP, I'm not sure could actually go to public type. I don't know if I guess if FQHC doesn't make it public. So I guess I don't know the question about the PPP.
Madam Chairman, if I do have that second part, if I may, so I don't have to get on here again. The second one question had to go toward, these CARES Act funds were really about making people whole. And so it's part of the question as far as if they received other funds, is it going to be an excessive amount in that maybe some of these clinics would actually profit from these funds and actually kind of make their way ahead. And I'm necessarily opposed to that, given as far as the population that's served. If that's the case, would they be able to serve more people for free, so that these funds are used in that way? I just want to make sure that we're not just loading people up with money to the exclusion of others, and that real people are obviously benefiting from these funds. Thank you.
And I know we do have people from the clinics on to testify later. Senator Schuler.
Thank you, Madam Chair. This is just a really quick clarification, I hope, and I may have just missed this, but my understanding was 92127, they do require a match, a 25% match of cash or in kind or both. And again, maybe I just understand, notwithstanding that, does that mean that they don't? Because I think the flexibility that we need is in this bill is what we need, I think. But I guess I just didn't understand if that portion on page 3, line 21, if that takes that requirement out or just what? If I could get a clarification on that.
That's the intention of lines 21 through 23, to take out the match, because it seemed like obviously if they had to round up the match and pending my amendment, get county commissioner approval, by the time they do all that, they won't get any money. It'll be the end of the care, right? So that, yeah, those are changes to certainly what the original bill back in Chairman Scott's day was, but we're also attempting to push out the money.
Thank you.
Chairman Scott, or no, yeah, Chairman Scott.
Thank you, Madam Chairman. I had a question on the staff comment, and on page 3, it sounds like you're going to deal with that. So that's not necessary. I did want to respond to a couple things with regard to the, looks like the number of COVID cases is going down. It has gone down as we've got the initial wave under control, but it's starting to creep back up. And for the discussion this morning with the state health officer, it does seem to me that people are starting to widely ignore the social distancing. And I think the prediction I've heard, and I think is quite valid, is we're going to have a second wave of cases that's likely to be a good deal more severe than the first one as the virus starts to spread again, because we're getting too relaxed about it, and it still is a very deadly disease. They really haven't found, they may be getting better at treating it, but they haven't found a cure, and it's still quite dangerous. So the need is still there. With regard to the both the local match and the county approval, originally this was conceived as a means of financing some expansions where you were getting new clinics in places that particularly needed them, and capital funding is a major problem for them. It was appropriate there for both the local match and the county commissioner approval, where what we're trying to do is make them whole for additional expenses they have or need to deal with the COVID. That need for those two provisions goes away, I think. So that's part of the explanation for why it's written that way.
And to follow on that, you know, my thought on, and your point about maybe if a few places only have a few COVID-19 cases, my thinking is that these health clinics that are often used by lower income folks, their funding, you know, actually in some ways their Medicaid rate is probably better than the average doctor, but they're not getting as many insured cases. And if we have an opportunity to get them some extra funding for their telehealth equipment or their electronic health records so they can communicate better with the local hospital, or you know, some future contagious situation. You know, suppose you had a measles outbreak in an unvaccinated population, and they came into this clinic, and maybe I'm not a clinician, so I can't say, but Maybe they need some sort of reverse pressure space that would be useful going forward. So I feel like, in my mind, the opportunities to improve the services available is not just about what's happening this summer, but preparing them to be better off in case of other infectious outbreaks or just the various things that they need to do for the population. Let's see, no more blue hands at the moment. Anybody else? We do have some public testimony, but. Okay, Elizabeth, let's see, oh, my message went away. First up, we had, I think, Andy Somerville. Has she gone away or is she still here? Ms. Somerville, you're back. Welcome back. And you're muted.
Madam Chairman, can you hear me?
We can hear you.
Wonderful. I apologize. The YouTube video is running just a little bit behind. Thank you very much. So I wanted, again, Andy Somerville representing WAMSAC, and I wanted to start just by addressing Representative Clem's question about entities or community mental health centers that might have received any other funds from the CARES Act. So far to date, it looks like they're going to receive, a few of them have received funding through the PPP program, which is separate, but they're potentially going to receive PPE funds through a separate SAMHSA grant that's not related to the CARES Act. And there'll be also potentially money there for additional direct services. In general, what the community mental health centers are struggling with right now in terms of COVID response is the idea that we have to balance the need to retain all the providers that we have versus the expenses that they may need to make modifications to the facilities. And so that's been a concern for the centers the last 60 days in terms of where they actually put their dollars. The community mental health centers run on the margin. They really don't, a lot of them have a lot of additional funding behind them every month. It's pretty close. And so they don't generally have a capital construction fund sitting there waiting to finance all of these improvements. And what we've seen during COVID is in several of our residential facilities, the need to move around beds or make other potential adjustments to their facilities to equate for quarantining, social distancing, those types of things. That's resulted in some facilities in a little bit of a reduced bed capacity, hopefully temporarily while we're going through these items. But they are currently ongoing assessments on what those facilities need to do long-term in anticipation of a second wave or a third wave, or we don't know how long this will go on. But again, they really are concentrating on keeping the providers that we have here. So that's a very strong concern in where they put their dollars. In terms of other CARES Act funding for the bills that were passed during the special session, we are uncertain right now whether the centers will be eligible for money that goes through the Wyoming Business Council and or the SLIB board. The SLIB board looks more promising, but the Business Council, we're still waiting for them to promulgate those rules so that we can see if 501c3s will be an eligible entity in those expenditures or for those grant opportunities. We're still waiting. We're not quite sure where the ground is yet. So I hope that answers those questions. I would again stress the need, our centers need to continue to provide services, so they do need to make investments in telehealth infrastructure. Representative Wilson, you said EHR software, that actually has come up to be a pretty major concern. We are incredibly thankful for the Wyoming Telehealth Network in the ability to get everybody that wasn't using telehealth online, but they've continued to come across new problems in terms of how information is transmitted, stored, how we take information from patients on telehealth. And it looks like to solve those problems, we're going to need to make some more investments long-term for those facilities to be able to operate really well. So I think the money could be very important for that use, as well as allowing the facilities to make modifications that they need to address the situation in a more long-term scenario so that we can keep our bed capacity up while still protecting the employees and continuing to provide services. So with that, I would stand for any questions.
Questions for Ms. Somerville? Senator Schuler.
Thank you, Madam Chair. The only question I had was the situation with the lack of access to telehealth. Is it basically a problem with the broadband, or is it a problem with folks who just don't know how to access computers and technology?
Madam Chairman, Senator Schuler, all of those things and more. So telehealth issues range from some of our facilities still don't have that last mile of fiber going to them. So their actual ability to operate from their locations is limited. There's certainly been a learning curve for the clients in terms of how to use telehealth. And we do have a lot of clients that are still working from telephone only service because that Zoom capability is not there. Maybe they don't have a computer, maybe they can't figure out how to make it work. Whatever those things are, I can tell you that the providers are on board 110%. It's just trying to figure out how to plug all these tiny little holes. And I think this is a project that we started quite some time ago, and telehealth has been gaining speed. And I think it was mentioned on a previous item that behavioral health providers are by far and large the largest number of registered users with the Wyoming Telehealth Network. We've just had to accelerate it so quickly that some of these problems have presented more of a challenge than others.
Thank you. More questions for Ms. Somerville? Andy, I do have one. On page 4 of the bill, line 13, when we were trying to come up with a definition for community mental health center, I think I was mistaken. It sounds like from your testimony that I was mistakenly thinking of them as providing only outpatient services. It sounds to me, and I guess I forgot about some places that might be, I don't know, crisis or residential. If you can flesh that out, and it looks to me like we need to delete the word outpatient from that paragraph. Is that correct, Ms. Somerville?
Madam Chairman, yes, I believe that would be correct. That is one of the concerns, and thank you for reminding me that I forgot to mention, is that we'd like to make sure that the residential facilities are able to access this money, because in some cases they actually need, especially for the infrastructure changes, need it more than the outpatient clinics.
More questions for Ms. Somerville? Okay, thanks.
Thank you very much.
Okay, let's see. Elizabeth, how about you let in Jen Cartwright? Oh, I see you. You're on mute. Feel free to unmute yourself. You're still muted. There you are.
Good afternoon, Madam Chairman, members of the committee. I'm Jan Cartwright. I'm the Executive Director of the Wyoming Primary Care Association. I want to thank you all for the chance to speak to you today. I first want to thank Chairman Scott for his work in 2011 on the original bill, the Primary Care Support Program. This bill was a committee-sponsored bill that put $1 million out into the communities. And I don't want to take a lot of time, so I won't go into a great deal of detail about that, but it was very successful. And our reason for wanting to re-energize this program is that it's got a proven track record, it's been successful, and it would be a way that we could get money out into the communities since it's such a time-limited project that you all are working on. I want to say that rural health clinics, community health centers, and free clinics are all operating in Wyoming, and they are all part of the safety net. So in other words, in some form or fashion, they receive some federal support, whether it's Federal Tort Claims Act or whether it's direct funding as the community health centers do. The reason that they exist is because they really, especially community health centers, cannot turn anyone away. So they are the safety net in terms of giving people the chance to seek primary care that's not in the emergency room, and do it in an affordable way, because the health centers have to provide a sliding fee scale to patients that come to them. As with lots of situations during the COVID-19 pandemic, the cracks in the system are showing within the community health centers. One health center actually had several of its staff members test positive for COVID-19, and that health center had to close. At that point, they provided healthcare in the parking lot and over telehealth, and did a lot of work with telephonic care, which we were very grateful to Medicaid for covering, at least for a short amount of time. So we have people giving care in the parking lot. We have people giving care over telehealth. A great deal of the care that was given during this pandemic so far has been over telehealth. In the last week, Wyoming Community Health Centers tested 71 people for COVID-19, and fortunately there were 0 positives during the last week. Right now we have 2 sites that are temporarily closed. I think one of them is related to the school district, the health center up in Pavilion. And right now the number is down. Earlier, about 50% of the healthcare that was given through telehealth, and that number now is down to about 28% of the care that's given in the last week. Again, the reason to support this bill is because it is already there. It's something that legislators have worked on, and we can show success. Not only that, we have one new health center in Powell that was opened based on this money. We have a rural health clinic that was able to buy a mobile van that moved out to all the senior centers and certain work sites up in the northern part of the state and on. So again, this is the reason that we're here to talk to you. The other thing I want to make certain that you know is that even though there is a lot of federal money coming to support, no federal funds can be used by community health centers for capital construction. And so again, all of the things that need to happen, whether it's putting in a negative pressure room or an area where people can go that are contagious, separate from other patients, those are the kinds of things that we would like to be able to use this money for. So with that, thank you, Chairman Wilson.
Questions for Ms. Cartwright? Representative Barlow, are you raising your hand or just itching your ear? Okay. Representative Hallinan. Were you raising your hand, Representative Hallinan?
Thank you, Madam Chairman. I have a question. Is Planned Parenthood, is that included in these centers, the treatment facilities they have around the state?
Ms. Cartwright?
Madam Chairman, Representative Hallinan, there are no Planned Parenthood programs in the state of Wyoming. They are not affiliated with our programs.
Thank you. Mayor Lynn, did you want to testify separately?
No, Madam Chairman.
Just there to back up, provide wingman?
Yes, answer any questions. Thank you.
No more questions for Ms. Cartwright? Okay, well, thank you.
Thank you.
Oh, Representative Barlow. No, he's either lunging forward or.
Sorry, Madam Chairman. So I guess my question for Ms. Cartwright and whoever else is, are all of these set up the same? Are they always private nonprofits, or are there different structures? Are some of them offered within rural healthcare districts? Is there different structures, governance structures for them? Thank you, Madam Chairman.
Ms. Cartwright.
Madam Chairman, thank you. Mr. Majority Floor Leader, the community health centers are all community directed. They have to have a community board and they answer to that board. Rural health clinics are a little bit different in that you're right, they are part of a rural health district and they can be private. So some providers, so the reason that we call both of those healthcare safety net organizations is because rural health clinics are basically in places where you wouldn't normally perhaps find a medical facility, and they're there and they get fair reimbursement for Medicaid because they serve that specific population. And then, as I said, free clinics are self-explanatory, but they also, because they're part of the safety net, have access to federal tort claims coverage, as do community health centers. So we sort of see those three as family, but they all do have different organizational structures.
Okay, more questions? Okay, then public comment is closed on this bill.
Madam Chairman?
Ms. Cartwright.
I'm sorry. I just wanted to look at page 3, the information. Sorry, now I've lost it. Page 3, line 4, talking about community health centers. And then you talk about those being as Section 330 of the Public Health Service Act. So in that
Just a
line,
minute,
on line
I
7.
think you're on page 4, right? Not
Oh,
page
I'm
3.
sorry, page 4. On line 7, community health center means a community mental health center, and that's not correct. So the word mental needs to come out there. If in the next paragraph you want to include community mental health centers, then that paragraph can stand alone. But the paragraph above, because it speaks to Section 330, that the word mental can't be in that paragraph because those health centers do not receive Section 330.
So let me ask you about that. So I understand what you're saying, but what they are doing there is defining community health center just for the purposes of this particular CARES Act thing. But I see the confusion with where the placement of the word or. I'm thinking that we might want to say, and tell me if you think this makes sense, backing up on line 4, for purposes of this section, just this section, community health center means a health center receiving federal funding under Section 330, blah, 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 including, and we don't want that word, and including health centers serving migrant and homeless populations or a community mental health center.
Yes.
You see what I'm doing there grammatically?
Yes, thank you, Madam Chairman.
Okay, so that will be part of my amendment when I get around to amendments.
Thank you.
Okay, then public testimony is closed. Okay, is there a motion on the bill, at least for purposes of discussion? Moved by Representative Yin. There's a second. Representative or Senator Schuler. Okay, discussion.
Madam Chairman, did we hear anything from the Department of Health on this one?
Well, we did not. Would you like to? I'll see if they're here. Department of Health, are you there?
I've just admitted Stefan Johansson, and you might want to ask him again.
Okay. Stefan, are you there? Stefan, I see your rectangle light up. Are you there?
Yes, Madam Chairman, I'm here. Sorry, the lag issue is getting a little hard to follow with the YouTube feed. So if you could repeat the question, that would be great.
You're just young. Those of us who are older had that experience way back in the 70s. And so talking on long distance telephone, we know what that's like. So the question was, I don't know if you heard it, whether the Department of Health had any comments to make on LSO 716. And thank you for that, Representative Sweeney. I seem to be gone into summer mode instead of proper committee mode. I should have heard from them first. Go ahead, Stefan. Have you got anything that you want to input on this?
Madam Chairman, no specific comments from the Department of Health, supportive of the concepts here, but happy to answer any questions about, and obviously we have a telehealth program or presentation coming up for the committee later this afternoon, but no specific comments from Health at this time.
Okay, thank you. I did, just so that you know, I did work pretty significantly with Carrie Wagner at the Department of Health. she back some years ago, I'd worked with her on these rural health type things. And so she and I had a lot of back and forth, you know, when I said, well, this is what I think we want to do. What's the issue with the bill? How should this be worked? You know, how can you get the rules out? What with the, so a lot of the changes actually were worked in consultation with the department.
Yes, Madam Chairman, certainly aware of that and appreciate you working with Carrie. And we'll do our best to, you know, if this passes, to expedite all of the bureaucratic and administrative processes that come with that.
Very good. Were there any questions for Mr. Johansson? Chairman Scott? Yes, sorry, I'm multitasking here. I've got, go ahead,
Yeah.
Chairman Scott.
I was looking at the appropriation on page 5. The question is that $15 million figure come from something that the health department has done? Does the health department have any basis for that?
Mr. Chairman, that came out of my own mind, the brain of Zeus or whoever it was. I just took the number of clinics and multiplied by 40,000 and came up with a big number, frankly. Totally honest about that. By the way, Elizabeth, just a sideways, Elizabeth, go ahead and let Mr. Boley in. That will be fine. Okay, well, let's see. Next, Representative Barlow.
Thank you, Madam Chairman. So Mr. Johansson mentioned getting rid of the red tape. So what would be the rollout if, let's say at the best case scenario, we have a special session that the governor would sign a bill by the 4th of July, how fast could they roll out? Remembering this is capital construction. And so we got to, you know, set up, getting the money out the door is not all that needs to happen. So what kind of timeline would Stefan see based on the rules in place or emergency rules?
Stefan?
Madam Chairman, Representative Barlow, obviously we could do emergency rules that would go very quick, and given the circumstances, I think pushing that with our partners in the governor's office and the LSO to expedite that could certainly happen. On our end, to your point, sir, I think giving the grant funding out in whatever the amount is per center would be relatively easy. I think whether we leverage existing contracts or amend them or develop new ones, that would be a relatively quick timeline on our end, probably less than a month, I would say. But when you're asking about, you know, capital construction that might happen with those grant funds to be able to spend them by the deadlines of the CARES Act, two comments on my end. One, probably not feasible in every case for how they might be used, but, and this might require some legal and financial analysis, if we were to spend those funds to the providers before December 30th, I think an interesting financial question is whether they could then be used for a capital construction project beyond December 30th, 2020, if that makes sense.
And with regard to that, I will just say that that's the reason for, on page 3, paragraph C, because the current grant program, I think they, you know, submit receipts and they get reimbursed, and it kind of rolls out over the course of, it might be a multi-year thing. The idea was, hopefully this would be legal, to enable them to, once they write the contract, and of course, if the contract is to buy $50,000 worth of computer hardware, then they can submit that and get reimbursed. You know, if they're going to build a reverse pressure room, they might, you know, but that's why we say, that's why it says that they can disperse it all at the beginning and not upon receipts over time. Representative Sweeney.
Thank you, Madam Chairman. Stefan, are you aware of any conflict? I mean, we're kind of backpedaling, pulling 15 million back out of what we've done with the governor's office on Flex and putting it into another executive branch. Do you think that's doable and not ruffling any feathers?
Madam Chairman
Stefan, go ahead.
and Representative Sweeney, that's a good question. I think there's an interesting tightrope here between executive and legislative branch. And I think with what the bills did in this first special session were to give broad direction and authority and some priorities to the governor's office, of which something like this might very well fit into those priorities. So I don't foresee a direct conflict if something like this were added. To Senator Scott's point earlier this morning on another issue, I think language that gives flexibility to the governor when it comes to these funds is probably well suited, but that's just my biased opinion as an executive branch employee. But I don't see any major conflict here as this works its way through the legislative process.
Just my insertion here, and just a thought. This might not really duplicate. So I'm looking at my copy of House Bill 1001, which passed as Senate File 1001. But we have the wording in there under the governor's 400 million to provide grants for expenses incurred by healthcare providers and healthcare facilities to respond to the public health emergency or to improve the state's healthcare delivery system and infrastructure, which I'm working that wording into one of my proposed amendments. And the grants have to be approved by SLIB. And then we had a paragraph for capital construction to provide mental health services. And that was to be approved by the State Building Commission. So in some ways, what I'm really doing is not extracting that, but relocating some of the potential of that to what I think is actually a more knowledgeable reviewer, that being the health department. That's just my thought. Chairman Scott.
Madam Chairman, thank you. I would comment particularly on that last point. I think that's appropriate because it sounds to me like this is a bunch of smaller equipment, smaller remodel jobs, not the sort of thing you really need to take to the slip board, and where the just dealing with the health department is very appropriate. I wanted to renew my question to the health department on the appropriations. If they can give us any insight as to that number, right, wrong, indifferent, is it can we at least call it a swag instead of a wag?
Stefan.
Madam Chairman, Chairman Scott, sorry if I missed the question before, but appropriation specific to what?
To this bill. I put in $15 million.
Yeah, I'd have to get my my napkin out and do the math really quick. But Chairman Wilson, I believe it was is it 400,000 or 40,000 per center?
It's 400,000 per center right now.
Then, Madam Chairman, Chairman Scott, again, let me doodle this on the back of the napkin, but I think that's roughly accurate.
If everyone got some, which probably wouldn't happen, but I thought I had another hand there. Chairman Scott, no. We had, Eric Boley was just authorized to come in and add to the public comment. So Eric, have you got something you would like to participate with?
Thank you, Madam Chairman, committee members. I hadn't, I'd registered, but I apparently didn't say that I wanted to testify on this particular bill. I think this is a really important bill, and I think I can add a little clarity to some of Representative Clem's questions about funding streams that have come in so far. And we are very supportive of this bill, and I think that it's vital for a lot of our rural health clinics. As you're probably aware, you went through the list. A lot of the rural health clinics are attached to our critical access hospitals around the state and our hospitals. There was some funding that came to them through the CARES Act that is separate from the pot of money that the state received. didn't really receive very much money up front. But thanks to some of the work that Senator Brasso did, there was a $10 billion tranche of money that was allocated to rural specific. And so our rural hospitals, which were almost all of them, and our rural health clinics received some funding finally late in the game. They all received about $100,000 as a base, and then 4% of their Medicare billing. I think it was their net operating expenses for the previous year. And that money was supposed to be used to kind of help offset some of their lost revenue. We've seen lost revenue across the board. People have quit seeking care and treatment during the COVID crisis. And so that was what that money was to be used for. We also have some of our smaller facilities that had less than 500 employees that were eligible for the PPP program. They originally were left out of that, but when the second allocation of money came out and the program was reauthorized, some of them did receive PPP programming, which is payroll protection program. But I'll tell you, this bill and what you're trying to do here fits perfectly into the guidance that we've received from Treasury and from HHS. The CARES funding that the state received is supposed to be used to help not only prepare us currently, but in the future for a pandemic. And our rural health clinics have had to make modifications to their physical plant in order to have social distancing, in order to protect their employees, and in order to protect the patients as they come in. And so I think this bill is ideal. I think what was passed in the special session and the amount of money that has been authorized to the governor's office to be distributed through the SLIB board is also very, very important. But one of the things that you've identified, I think, very well, is that we need to get these projects going now. We need to get the money out the door. We need to get the money spent. And so I really like the approach that you've taken with this because we can expedite it. I agree that the Department of Health, through license and survey, has the expertise that would be necessary to approve these projects. But the longer that we sit on the money, the harder it's going to be to get these projects done. I also think the other really important aspect of this is it's going to help stimulate and get people back to work, stimulate the economy, because we'll be putting contractors and workers back to work in all of these areas that have rural health clinics. So we're very supportive. I think the changes that you've suggested are good ones. And so I encourage you to move this thing forward, and I'd answer any questions.
Questions for Mr. Boley? Okay, thank you very much.
Thanks, Chairman.
Okay, unless we have any late arriving Zoom testimony, I think that was the end, the second end of public testimony. And let's see, we actually had it moved by Representative Yin and seconded by Senator Schuler. So we're back to that. And do we have any discussion or amendments? Actually, I have some, but. Well, why don't I present mine, and then we can kind of discuss it as amended. So, and I did send these, the main large text ones out to you folks, because otherwise if you're like me, it's hard to really process something that someone reads to you. So LSO and all of you should have these amendments. Page 2, line 22. So this is an overarching paragraph that exists about using the money from the CARES Act. But there was some suggestion that perhaps it would be better to really clarify the use of this to ensure that it fits in under the CARES Act. And so I would propose after the word response to add, and again, this is on what you should have received this from me this morning. Grants under this section may be used to cover expenses incurred by community health centers, community mental health centers, and rural health clinics in response to the public health emergency caused by COVID-19, or to improve the state's healthcare delivery system, infrastructure, and capacity to provide mental health services, including major renovations or capital construction of facilities. So we basically cribbed the language out of Senate File 1001 and just put it in here to make it parallel. So do I have a second? Second and, oh, not, sorry, John Brody can't second it. Seconded by Senator Pappas. Mr. Brody.
Yeah, Madam Chairman, just a point to raise. Since the bill defines community health center to include rural healthcare and community mental health, I just wanted to, I guess, get the permission from the body to possibly just cut out the reference to rural healthcare clinics and community mental health centers and just use the broad term as defined in the bill for that provision. Or I guess get your feeling on that point. Thank you.
Well, I'll amend my own amendment then, seeing as LSO is not allowed to amend, I don't think, but to just say to cover expenses incurred in response to the public health emergency and delete the verbiage in the middle. That's shorter. Okay, now do I have a second? Seconded by Senator Pappas. Okay, is there any discussion about that? Chairman Scott. There you go.
I had to unmute. Question, Madam Chairman, as I understand your language, it would mean if, say, they had to make a physical modification to their facilities in a hurry to provide additional isolation protection, and had already done it, but it's caused them financial problems, they could come back and get reimbursed for what they had to do and made whole. Is that a correct reading of your first sentence?
I hadn't thought in that detail because this was provided to me by someone else, but I have no problem with that. It would certainly fit into what I think would be acceptable.
That's the way I read it, and just wanted to make sure that I was reading it correctly.
Seems like a good idea because after all, if they were clever, they would have thought of that on 1st of April and not waited for us. Okay, then all in favor of the amendment, please put your hand in front of your face. 1, 2, 3, 4, 5, 6, 7, 8. Okay, there is 8. So a number of people are not here, or Representative Clem and Representative Sweeney seem to have departed, but that was 8, so that'll pass. Okay, then, and be sure I will let other people amend in if you want to. On page 3, the staff comment, and I had meant to work this in and somehow failed to do this, and I'm not sure, LSO might have to amend this. In paragraph B, we have lines 21 through 23, notwithstanding the current statute, they won't need to have a match. So what I would like to insert is before, and I don't, it's going to look kind of ugly having 2 notwithstanding. So this is where LSO might do better crafting. But at the beginning of line 21, before that paragraph, I'm going to notwithstand the public hearing and the county commissioner approval part. And this is part of what I sent to you as well. Notwithstanding 92127D1, applicants for grants under this section are not required to supply public notice and hold a public hearing, and are not required to obtain approval from the Board of County Commissioners for the county in which the community health center, community mental health center, or rural health clinic is located or proposed to be located. And again, that's wording that was given to me. We might be able to trim it up some. And if I have a second, I can explain a little further. Seconded by Representative Barlow. Okay, so obviously the idea is not to remove transparency from processes, but if the goal is to quickly funnel out $20,000 in telehealth equipment or something, to have public notice and a public hearing in the Board of County Commissioners is just really, I think, defeats the goal of moving quickly on these projects. But I'd be glad to hear input. Representative Barlow, you try. Oh, there's your hand. Representative Barlow. Sorry, I'm slowing down after lunch.
Thank you, Madam Chairman. So I think just need one notwithstanding and add 1 and 4 in it. because I think you're trying to get rid of all of 1 and all of 4, the requirements within them. So I don't think you need 2 sentences, just add 1 to 4. That would be my suggestion, but Mr. Brody can weigh in too.
Mr. Brody, have you got an opinion on that?
Madam Chairman, yeah, I think Representative Barlow is dead on. I would just ask if LSO could be granted the flexibility to basically carry forward the body's intent, and just to ensure that those two paragraphs don't apply to the program in this bill.
That's fine with me. Is that fine with my second? I forgot who seconded it. Oh, it was Representative Barlow. Okay, let's see, Representative Clem.
Thank you, Madam Chairman. So I guess I'm just trying to get my head around this amendment a little bit more. So this would be moving the provision that they would not have to go before the Board of County Commissioners. And as I understand, you know, in what we did in the previous legislation that was passed in the special session, that the SLIB board would make some of these determinations. A clinic would come and make its case, and there would be some oversight there. I understand what this bill is trying to do is as far as to get that off of SLIB's back and put it more in the Department of Health. I guess I'm a little bit concerned here. And let me ask you, what oversight will there be then, aside from the Department of Health, as far as making sure that these funds are put out appropriately? I guess that's where the struggle is a little bit for me. Thank you.
Department of Health, do you have any, well, and I can answer that, I guess, in some ways, and that is that the oversight is pretty much what other executive branch things are have oversight, which is the department and our original bill and the giant hanging hammer of the federal government making you pay it back later, I guess. But certainly, you know, that's worth discussion. Representative Clem.
Yeah, thank you, Madam Chairman. And I mean, and that's part of it. I guess the thing that goes into my mind is, of course, the county commissioners know their county best. And of course, when we get into some of these funds, you know, the discussion kind of gets into, you know, picking winners and losers. And so I'm just trying to anticipate competing interests. That's what I'm trying to figure out. So if you have a clinic that's competing against what? If you've got a rural healthcare district, okay. In my community, we've got a hospital district. I'm just trying to anticipate, okay, if some of these building projects and things go on, are they competing against other interests, number one? And then number two, is it going to be able to sustain itself over a long period of time? Or is it going to require some kind of other commitment later on from the county? I mean, there's just some of those nuances that for each county would and individually would be different. Whereas I think it probably would be good for that local control aspect for counties to have a say in that. So that's really where I'm trying to look at is, you know, if we're removing that, then I guess is that good for local control in that aspect? So thank you.
Senator Scott.
Madam Chairman, in response to that, that's why the provision was in the original bill, because that was contemplating grants that were going to expand centers, quite possibly expand their presence into communities where they weren't, or expand within the community the size of the center. And for all the reasons that Representative Clem listed, we thought it was appropriate to have the county commissioners involved. Here, you're talking a much more technical issue. You've already got them in the community. They're part of the healthcare system, and they need to make modifications to handle this new disease that's come along and to handle any future pandemics. So you're just improving an existing operation. You don't have a lot of those other issues where you need the local oversight What you need is the technical oversight the health department can provide, saying, do you really need a negative pressure room? Do you really need this particular kind of telehealth or electronic capacity to continue to function? Those are not things where your county commissioners add a lot of value or have expertise. So we're putting the oversight where it belongs in this case, which is with the health department.
I will just insert in, Representative Barlow, go ahead.
So, Madam Chairman, to that point, I don't think the word existing actually is in this bill. So if we wanted to limit it to not having new clinics or new things start up, which is in the current statute, then I think existing would be a worthy addition. And I'll look for a spot to insert that so that we are actually enhancing what's already there, not adding something new to the point that the chairman brought. Thank you, Madam.
So to that, when we come to that, just looking, page 2, line 17 might be a good place to insert it. I have an email arrived in, I'm taking sort of strange way, but a comment from one of our previous presenters. Ms. Somerville says, several of our community mental health centers serve multiple counties. If county commission is involved, we would need clarification on which county commission would have to approve. I will just also say that certainly for many of the community health centers, you know, they have, this is like the family health, the family practice residency program is an FQHC, and they have an independent community board. So really what jurisdiction the county commission has over basically a private board spending $20,000 on hardware. I mean, I kind of wonder whether they really even are legally able to say yes or no. I mean, if we're asking them to, I mean, I'm not really sure how that fits in with and Chairman Scott can perhaps answer. It looks like he's got his hand up. Chairman Scott.
Yeah, Madam Chairman, on the question of the existing centers, I'd assume that the deadline here was such that as a practical matter, you can't use this to create a new center. So I don't think it does any harm if somebody wants to add the existing language, but I think it's already essentially there because it's just not practical to go create something entirely new with these funds. This is the size of the monies available, and the time frame particularly really does limit these to existing facilities.
More discussion. Okay, so we are on the amendment to page 3, line 20, authorizing LSO to massage together lines 21 through 23, and the proposed amendment deleting the requirement for public hearings and approval of the county commissioners. All in favor, please put up your hand. Okay, that's 10. All opposed? 1, 2, 3, 4. Okay, 10 votes for, so that passes. Okay, I'll just finish my list and then circle back to Representative Barlow for his existing comment. On page 4, the paragraph on lines 6 through 10, I think there was just an awkward wording that is confusing. So my motion would be on line 6, after the word means, delete a community mental health center and So then it will say community health center means a health center receiving federal funding under Section 330 of the Public Health Service Act, Public Law 78-410, including, then deleting the word and, health centers serving migrant and homeless populations. Then after the semicolon, add the word or, and insert from above a community mental health center, semicolon. Does that make sense to people? I'm just moving the community mental health center at the end of the paragraph and moving the or, just so that it's clear that we don't have, I'm sorry, I shouldn't explain it before I have a second. Do I have a second? Oh wait, that's Mr. Brody. You can't second it. Representative Yin. I'm promoting you. Mr. Brody, did you have a comment?
Yeah, just I guess during one of the earlier iterations of this bill, we did have the words in the order that was being offered through your amendment. And we had somebody raise confusion that the same problem existed, that it wasn't quite clear that mental health centers were separate from the Public Health Service Act. So what I would ask, and it's more just a drafting convention, is that we have a paragraph 1, community health center means, and then we go into subparagraphs. So subparagraph A would say a health center receiving federal funding under Section 330, and then the rest. And then subparagraph B would identify a mental health center. And then there would be no ambiguity as to those two things being the same, but it would be clear that both fall under the definition of a community health center. I just wanted to, I guess, throw that into the ring.
Is that a friendly amendment to my seconder? Representative Barlow, or yes, or are you just trying to second? Okay, I don't seem to have any blue hands up now. Okay, so my amended is amended by LSO because I was just trying to clarify it. Is there any discussion? Okay, all in favor, put your hand in front of your face. Uh, 14, okay, very good. And one last one before I circle back to Representative Barlow. Page 4, line 13, just delete the word outpatient. I omitted that there were some various kind of crisis type beds. So do I have a second? Seconded by Representative Barlow. Okay, any discussion? All in favor, put your hand in front of your face. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, 14. All right, that passed. Okay, Representative Barlow, did you want to make an amendment?
Thank you, Madam Chairman. Just a technical thing. There are 2 Section 3s in the bill, so I just point that out for LSO. And then, Madam Chairman, on page 2, line 17, after the word "to," insert existing. So it may be important to existing community health centers and rural health clinics. Obviously, with the definition change, I'm sorry, that's my.
Is there a second? Seconded by Baldwin. Okay, any discussion? Representative Sweeney.
It wasn't on that issue.
I'm sorry.
It wasn't on that issue. I want to come back.
Okay, thanks. Sorry about that.
Sorry.
Any further discussion on this amendment, adding the word existing? Okay, all in favor, put your hand in front of your face. Okay, we have that passes. All right, any other amendments? Representative Sweeney, did you have something that you wanted to discuss?
Just a question on about 3 amendments ago on the county commissioners. I believe I got confused. Did we take the authority away from the health department and give it to the county commissioners?
No, we just took away the requirement for the local county commissioners to approve the project.
Thank you.
Okay. Are there more amendments? All right, then whoever from LSO is taking roll, if you would.
Madam
Oh, wait,
Chair,
Senator Bouchard.
Madam Chair, I would just question if we could go back to the page 3 amendment. Would it be possible to do something there where we just had a way, if there was an objection, that maybe there was two competing healthcare in one county, for instance, healthcare providers, and there was just some objection that could come up, and then they would go, then they could have another process. I mean, I just think there should be some safety net in there, and I don't have the wording for that yet, but I think that would be a pretty easy process, and LSO could probably help us there. So I'm just thinking of something simple. I don't want to clog things up, but I do. I think that we have maybe some kind of secondary way to. And I'm sorry. I apologize. I'm looking at my computer when my camera's up here. I should be looking up here, Madam Chair.
Right.
But anyway, that's just a thought, and I wanted to express that. Thank you.
No, let's see. Chairman Scott. Oh, you're muted still. There you go.
There we go. In response to that, we've got a fair amount of protection against that. These things are widely scattered over the state. And I think the prospect of having a couple of competing ones in the same county is relatively low. You might well have a situation where the local community health center and the local community mental health center want to do something similar, and each one needs it. They're serving different populations. And so it'd be appropriate for both of them to apply. But I don't really see, this is not where we would need that protection is where we were doing a major expansion of something, and that's not contemplated here. So I think we're probably all right on Senator Bouchard's point as it stands.
Representative Barlow.
Thank you, Madam Chairman. So this kind of goes to that question, but it's also in the current statute, we just exempted 1 and 4, but number 6 also, 1 and 4, 1 being the county commissioners, 4 being the in-kind, but number 6 also requires that grant applicants provide proof of designation as a rural health clinic or FQCH center. And that goes again. And so we've added in the community mental health. So we probably need to exempt this 6 as well if we're going to be complete with this. So, Madam Chairman, my motion would be to add 6 to the notwithstanding language on page whatever it was. Thank you.
Is there a second? Seconded by Senator Schuler. I think that's a good catch. I'm skimming that over. LSO, do you have any input on that? Mr. Brody.
Madam Chairman, I think that amendment is wholly appropriate. So that'd be my only comment.
Well, that's good. Okay, and any further discussion about that one? All in favor, put up your hand. Okay, that passes. Representative Stivar, you might need to tilt your camera a little bit. I can just barely see the tips of your fingers. Okay, so that passed. Very good. Okay, any Representative Barlow, did I just forget to take your hand down or is it up again? No, that's fine. I just, I don't seem to be as sharp as I was this morning. Okay, then I think we have them all covered. Can we call the roll?
Madam Chairman, This vote is on 20 LSO 716 as amended. Senator Baldwin,
Aye.
Senator Bouchard,
Aye.
Senator Pappas,
Aye.
Senator Schuler,
Aye.
Representative Barlow,
Aye.
Representative Clem,
No.
Representative Dayton Selman,
Aye.
Representative Hallinan, Representative Hallinan,
Excused. Oh, wait, no,
Aye.
here he is. Okay.
Aye.
Representative Roscoe,
Aye.
Representative Stivar,
Aye.
Representative Sweeney,
Aye.
Representative Yin,
Aye.
Co-Chairman Scott,
Aye.
Co-Chairman Wilson.
Aye.
The bill has been adopted.
Okay, we're moving along, folks. Are we good, or do you need 10 minutes to offload your lung? Five. I see a few hands for 5. Okay, let's take a 5-minute break and come back to 41. Oh, now Stivar wants 10 minutes. We will come back at 2:45. That's 8 minutes. 2:45. Remember to turn off your videos and whatnot. Okay, who's back? Very good. 4, 8, 9. Sorry, I'm trying to read my email on my phone. It's not quite the same when people can't just walk up to the front of the room and say they want to talk. While we're getting people organized, let me just double check. Elizabeth, are you back on?
Ma'am, I think they actually might be on as the behavioral health division in the waiting room, but I am uncertain.
Are you able to talk to people in the waiting room?
I have not been able to, ma'am. I've been trying.
What we're just checking on here, committee, is whether we should try to let in WICHE so they can provide the information on the community mental health workers and not just sit around too long on their Zoom call. WICHE, if you're listening in, send an email to Elizabeth Martineau or some LSO person that you've communicated with. It's just that the bills seem to take a little longer than we anticipated. Okay, why don't we go ahead with this last bill just to knock that out. And then if we hear back from WICHE and want to swap the mental health with the telehealth, we might do that just on their behalf. So last bill is the LSO 725 healthcare provider loan repayment. And I'll just again do a little bit of 30,000 foot and then let LSO go through the bill. This is another statute that we have on the books. And as a matter of fact, I have an amendment because I discovered that we actually, way back in the ages, had separated out physicians and dentists into 92118, and then allied healthcare provider 92119, which does say hospital, medical, surgical, and so on. And I think that my recollection is that Department of Health actually has the money kind of in a pool, but I think I sent to you, I think I sent at least to LSO, that we probably need to insert 92118, which unfortunately is probably going to double the size of the bill because we'll have to probably say everything twice. But certainly that was the intention. Anyway, this is another program that has not been funded since about 2016 when we had our last downturn. And several of you were on the family practice residency subcommittee or task force, whatever we called it. I know Representative Sweeney was, Senator Baldwin was. 2 years ago, we, over the years in various settings, we have heard a lot of testimony about how, gee, it sure would be helpful to recruit providers if we still had our loan repayment program, which is still on the books, but we haven't put any money in it in the last some years. And a lot of states around us have significant loan repayment programs. So it seemed, again, because now I will admit that this bill is a little more challenging as far as its coverage under CARES Act. I am going with a couple of workforce enhancement lines in the CARES Act. And obviously, if, as we go through the governor's office and the AG's office and such like, if they're like, well, this is just never going to do it, then they may not stand this up. But I think if you're keeping alert to what's happening in Washington, there has been a lot of discussion under this new HEROES Act that is kind of not entirely happening, but some loan repayment provisions may be coming out of Washington, D.C. So even if this particular bill, if we look at it and we're like, well, we're not sure the CARES Act covers it, personally, I think it would be great to have it in case the feds pass a bill that is more clearly authorizing loan repayment programs. If they pass it in August or something like that, it'd be better to have this ready. That's my thinking, but I just want to be honest about that. So the current program enables doctors, and I'm merging the two, 119 and 118, doctors, dentists, and a whole lot of other kind of healthcare people to put in to have up to 100% of their outstanding educational loan. Right now it's capped at $30,000 a year for docs and dentists and $20,000 a year for the other types of providers. Now, again, just because I was being enthusiastic about, fine, if the feds are going to give us money, let's shove it out the door. I didn't put a cap in here. That's how it is now. We have not specified so far, but we could be clearer because of the CARES Act money, which does talk about substantially dedicated to mitigating or responding to COVID-19. I didn't want to get too tight in statute, but we could if we wanted to. Obviously, I think it would be aimed at primary care, family practice, internal medicine, pediatrics, hospital, respiratory therapists. Certain categories would probably be more pertinent than say, urologists. But I haven't specified that, thinking that we could leave that up to rule, which I left the rulemaking pretty broad in this. So this is a little bit more of an open template. LSO, if you want to go through the specifics, carry on.
Thank you, Madam Chairman. John Brody, LSO. I guess at the outset, I will just mention there is uncertainty whether this bill complies for funding under the CARES Act. Some of the materials that were provided to the committee included the guidance that was issued by the Department of Treasury. On the April 22nd guidance that I believe was provided to you, the initial kind of introductory explanation provides 3 requirements for CARES Act funds. One, that the costs that these funds are being used for are necessary expenditures incurred due to the public health emergency related to COVID. 2, that the costs were not accounted for in the budget most recently passed by the state. And 3, were incurred during the period that begins on March 1st, 2020 and ends December 30th, 2020. So there's certainly a difference of opinion could exist as to whether the expense incurred would tie to the expense of providing the assistance by the department, or the expense incurred by the the healthcare provider in obtaining the loans for their education. So I guess just to get that out of the way and let everyone know that it's not entirely clear. Again, federal law can change, and the bill is drafted in a way that if additional funds are provided or the current status changes, I think the bill can adapt to that. Moving to the bill itself, this bill is structured similarly to the one that the committee just adopted, 716. The changes that would be made to the other statute, 92118, would basically be the same as what we're doing to 92119. Because we're dealing with time-gated funding, we thought it was best to simply acknowledge the fact that other expenses or other funds may be used under this program that don't exactly fall into the standard way this program has been operated. So on page 2, beginning on line 12, we simply just tried to insert some language acknowledging that fact, and I guess allowing for then the meat of the program to be put into non-codified law so that the legislature doesn't have to later go into the green books and repeal a bunch of stuff. So I guess it's fairly self-explanatory. The applicant would have to submit an application to obtain the loan assistance. The assistance received would be for if they had worked in the state in response to COVID-19 for 6 months. And that would have to occur between March 13th, 2020 and December 30th, 2020. As everyone knows, that December 30th date is the CARES deadline, basically, for the funding provided to the states. The work they do in the state has to be substantially dedicated to mitigating or responding to the COVID public health emergency. That is verbiage taken from the Treasury guidance. And then this is language, if you move past that wording, then we go into the 100% repayment. That is pulled from the current program in 92119. A couple things I wanted to highlight to the committee in the staff comment. The first being that as the bill is currently drafted, I think you could read it and come to two conclusions. One being that you work in the state for 6 months and then all your loans are repaid for both medical school and undergraduate regardless. Or somebody could read this, I think, and believe that your loans, the payments that were due during the period in which you were working in the state and your work was substantially dedicated to responding to the public health emergency, that those payments would be covered. 100% of those payments would be covered under this bill. So it may be something to consider if the committee wants to clarify that, or if you think it's clear enough, then obviously no action would need to be taken. Secondly, the committee may wish to consider whether or not the 6-month requirement is a block of time, meaning the person has to be here for 6 consecutive months working on the public health emergency, or if they're in the state and for a total of 6 months, they provide those services. I think the bill could be read both ways, and it's up to the committee whether or not you feel it's necessary to clarify that. Relatedly, and I mentioned this, we pulled the term substantially dedicated from the Treasury guidance. That term isn't defined in the guidance. I would say a good argument could be made that there isn't really a plain meaning for that term, and there could be a difference of opinion on what substantially dedicated means. So again, just wanted to put that on everyone's radar, whether the committee believes some clarity should be brought to that, whether it's through a definition or not. And then lastly, we have some limitations that are in the current statute that we accept out. So the first is 92119A2, and that provides that the assistance provided to the applicant cannot exceed $20,000 per year. Obviously, the issue with that is that this money expires in December, so the limitation of $20,000 a year is a bit of a square peg, round hole kind of situation. So we took that out, but the committee may wish to consider something in a similar vein on whether or not to limit any payments. The second part was a requirement that the healthcare provider agree to provide services for a minimum of 3 years. Again, with the 6-month requirement for receiving the assistance or to be authorized to receive the assistance, it seemed appropriate to take that component out of the requirements under this bill as well. And then lastly, kind of in a similar vein, as with the last bill, I included a copy of 92119, or I included a copy of the statute that applies to the bill, in this case 119. So it may be worth the committee's attention to just look through that provision and see if is any other language that you feel isn't appropriate in administering this program, or anything along those lines. Section B, we offered page 4, line 12. That was inserted more to try and express the intent of the bill, in that the idea is that we have these healthcare workers that we want to maintain and that we want to keep in Wyoming, and then they're an integral part of the services being provided. So Section B, I think, really operates more to just communicate that and provide some guidance perhaps to the Department of Health on the purpose for this bill. Subsection C, this is just sort of some guardrails on the bill, on the assistance provided, and kind of requires the department to work with the licensing board and professional association on some rules, and kind of in figuring out who should receive assistance and to what extent. Moving to page 5, section 3, section 3. Just wanted to point out, we don't have an appropriation, a specific appropriation of money in this bill, so that'll be something that the committee will need to consider. And also, unlike 716, with which the committee has already considered, this bill does not include a reversion of funds provision. So the funds that are appropriated currently under Section 3 are to the program, period. So the committee may wish to consider whether they want, after a specified period of time, for example, September 15th, as was in 716, whether it'd be more appropriate after that point, if there's any remaining funds, to then have those revert back to the governor's office as intended under Senate File 1001. And again, this one is effective immediately, just like 716. So that's the bill, quick and dirty. And if there's any questions, obviously happy to answer.
Questions, Chairman Scott?
There we go. Yes, Madam Chairman. And I've been looking at the staff comments and thinking about them and listening to the Mr. Brody's presentation, and let me make sure I understand this properly. And let me say at the outset, I'm a strong supporter of the loan forgiveness program as an effective way of recruiting new medical personnel to Wyoming. It's been used by us and many other states effectively. And it would seem that 3-year requirement is an essential part of that. The problem I'm having with this bill is whether making it fit under the CARES Act requirements is going to stretch it too far and get us in trouble. So one of my questions is, if we put left the 3-year requirement in, and they'd have to repay us the loan repayments that we'd had given for them, if they left before the 3 years was up, would that tend to destroy the nexus that allows us to use the federal funds here? That's one question. Second, just mechanics of the timing. Am I right in thinking that if we pass this at the coming special session, there won't be 6 months left in the year, so it would have to be somebody that already come, so we couldn't use this then as a recruiting tool for new people? If we dealt with that by shortening the time period to 3 months or something like that, would that again put us at enhanced risk for not being able to use the federal funds for this? Those sort of things are troubling me, and you, LSO, you understand the guidance better than certainly better than I do. Can you expand on those a little?
John, any thoughts?
Yeah, I guess I am not confident that the CARES Act funds that are provided to states can be properly used as this bill is currently drafted. I have real questions on whether or not we're satisfying those 3 requirements that I mentioned at the outset of explaining this bill. Whether or not, the bill includes that 3-year work requirement or modifies the 6 months that the person must be working in the state in response to COVID. I think those concerns remain the same in my mind. I think it is a good point to raise that by the time the governor's office, should they sign the bill, there won't be 6 months left in the year. So certainly that would, I think, warrant some discussion. But again, I guess I would just communicate that I'm a little nervous on whether the COVID funds ultimately wouldn't have to be paid back under this program. I wish I had a main line to the Treasury Department so that I could kind of bounce these concerns off them. But the guidance is what the guidance is, and it unfortunately just does not answer this particular concern. I hope that sufficiently provides an answer.
So, if I could just insert a couple of thoughts here, and I understand what Mr. Brody is saying. My first thought is more federal programs may be in the offing. I know there's this HEROES Act, which the federal Senate is not wanting to consider exactly as it is, but there's been a lot of discussion about loan forgiveness programs, which we don't know what that will look like. So I'm kind of inclined to say, draft this up so that we can use loan repayment dollars if they come down the pike. And if it doesn't happen if we end up thinking, if nothing comes down the road and we can't spend CARES Act, then nothing will happen. I will say there's been quite a bit of discussion, through my email and various others, the whole 6-month thing. And I have a suggestion that I emailed to people that maybe amending that to say present and working in the state on or before March 13th, and then not putting any time thing in. But in other words, it wouldn't be a recruiting tool, as Senator Scott has said, other than certainly and Senator Scott will remember when we were on the family practice residency program, there were a lot of people who were doing, these were just the residency specific, but people who were here, but then they're not planning to stay here when they're done with their training because they can go home to Nebraska or Arkansas and get their loan repaid. So it would be less of a recruiting tool than a retention tool, which to retain our workforce is also a good thing if we make it work. I'm going to start calling. We've got some folks with their hands up. Senator Baldwin.
Thank you, Madam Chairman. First off, I'll be a no vote on this because I believe the timing is bad. I'm a great supporter of this program. And I think that's for obvious reasons. I think it's a great retention tool. I think it's a great recruitment tool. I don't believe it fits into the CARES Act, and I think we're treading on dangerous ground by trying to do it now and trying to do it in a special session. I would be of the opinion that maybe if we're going to revive this program and bring it back, it needs to happen as part of regular legislation and not a part of special legislation. But it is a great program. I have nothing against the program. I think it has good points. I think we need to have that 3-year provision in there. But I don't think it fits under the CARES, and I don't think it fits under the special session rules. And I think we would be better to look away right now, but I would certainly be a supporter down the road if the funds are there. Thank you, Madam Chairman.
Representative Sweeney.
Thank you, Madam Chairman. I'm for this only because if something comes down the pipe, as Madam Chairman has indicated, we need to be prepared. I see this as a potential tool for those that are already here. They've got debt. They are on the front lines. They've stayed here. They may have even been in school still or the residency program, and um, there's a good portion, the March 13th through the end of the year, that a portion, not their entire debt, but the portion dedicated during the virus would apply. I kind of believe. So I would ask you to think about it that way. Is it a pie in the sky? Perhaps. But nothing ventured, nothing gained. And if we do nothing, we have the potential of absolutely missing the boat on this as the feds continually change up. So I would encourage, I totally respect what the good senator, both good senators said. But we all know there's, unless something dramatically happens with, say, uranium, we're just not going to see the revenues return to make this happen again. So that's my comments. Thank you, Madam Chairman.
Representative Roscoe, you briefly had your hand up. Do you have a question still? And you're muted.
Why is it so hard to find that button? Thank you, Madam Chair. I guess I was just thinking we could go either way, right? If we have a special session the end of June, we could either pick it up again if money has come in by then from the feds, or we could, if it doesn't, we could get rid of it at that time. Is that not correct? I mean, that's not really resolving anything, I'm sorry to say. Thank you, Madam Chairman. That's all I have to say.
Well, I will say, as far as a special session at the end of June, this is pretty much the opportunity. I mean, we have discussed maybe having, another brief meeting to deal with the Medicaid and the licensure, but I kind of doubt that we'll be able to draft. I mean, we could table it and say, try again for another meeting before the June end of session, seeing if more information will come out of DC in the next week and a half, or we could try drafting it broadly to cover any eventuality between now and fall. Senator Baldwin, I see your hand up again.
I'm sorry, Madam Chairman. I just like it.
You're allowed to use your hand.
I just like hitting the blue button. I don't get to do it very often. Just a little bit of pile on it, and not a big deal, but I feel like in this bill as well that we're leaving out a substantial portion of those providers, doctors or dentists or what other providers that don't have outstanding school loans. And I think that's a large number in the state. And that being said, I would be much more supportive of something that gave a stipend to all those providers that were practicing since March 13th or whatever that date is, that practiced and dealt with the COVID situation. I think that would be much more equitable, and I think it would be more accepted by the medical community. And that's only my opinion, but that was what I would throw in, is I believe we're leaving out a substantial portion of those who have helped and who've participated, and maybe just helping a small portion if we do go through with this.
Well, I don't necessarily disagree, but I'm not sure how to craft that. Even harder to craft than this one was. More blue hands before we look for public comment. I admit it's a little bit of a pickle, but I'm just trying to take advantage of, if the feds are bound and determined to shovel out money our way, I'm just trying to scoop some up without being run over by the parade horse. Okay, let's see who we've got in the waiting room. Let me get my list here. I think we've had a few additions. My message on that is so far back. Elizabeth, I'm just going to ask you to steer me because the list is so far down my inbox now, I can't find it. Who's first up?
Ma'am, you will have Andy Somerville first.
Okay, Ms. Somerville, come on, welcome back. I see Andrea's rectangle.
Madam Chairman,
Ms. Somerville. Where did
it's
you go?
the co-host will not let me start my video. I don't know if that's a good thing or a bad thing. Oh, there we go. All right. Thank you, Madam Chairman. So we just have a few brief comments on this bill. Overall, again, Andrea Somerville from WAMSAC. We're very supportive of loan repayment programs for your community mental health providers. These are an essential tool to supplement what is usually a lower salary than these providers would make out in private practice. So it's really important. It's also incredibly difficult sometimes to access the federal student loan repayment programs for a lot of various reasons that I won't go into today. So in general, we're very supportive of it. Couple of points I wanted to mention, just again, to thank you guys for including mental health care workers in the draft of this bill. Sometimes mental health care workers get left out of the conversation with COVID because they're not necessarily the doctors on the front lines, and we understand that. But I want to assure you guys that your mental health care and substance abuse treatment providers are working very hard, not only to support the general public and their clients, but also to support the healthcare workers themselves, the doctors, the nurses, the first responders, in terms of dealing with work-related stress. We have centers that are offering wellness programs, offering telehealth services to them, so that they are out there providing those services. One of the things that I wanted to comment on was the discussion on the substantially dedicated portion. So on page 2, line 23, that term, as we all know, comes from the U.S. Treasury guidance, and we are, in fact, working on a couple of different fronts to try to gain more understanding of that. In recent conversations that we've had with SAMHSA related to the direct care money that might come down the pike, we've tried to wrap our heads around what substantially dedicated is, or how do you quantify which patients are affected by COVID. And in general response we've gotten in the last week, 10 days, is that they're assuming everybody is. And they're assuming that all healthcare workers are affected by COVID and would be substantially dedicated to, because it's part of their daily lives in whatever fashion, whether they're a mental health care worker or a physician. It's certainly there and present. Now, I don't have that guidance in writing despite requests yet. If I get it, I will happily share it with the committee. But I just want to let you know that we've had those similar discussions, and I would be a little cautious on putting a definition in here into what substantially dedicated means, and that it might tie our hands later. So if the feds come down with their guidance and are more flexible with that, and we put something in that's more stringent, we could potentially kind of shoot ourselves in the foot. So I just wanted to make that comment. In general, for student loan repayment programs, we would encourage you guys to consider making the program easy to use. One of the biggest complaints we hear about the federal repayment programs through HRSA is that it is enormously complex, depending on what region you are, what rating you receive. We have numerous providers that apply consistently and are denied for various reasons, whether it's trying to spend money throughout the state, geographically. It's complex program. It's a long application process, and it's often not successful. So when you're thinking about what requirements to put in the program, I would encourage you to make it as easy as possible to access. We certainly support transparency, and that follow-up to make sure that we're getting our money's worth, essentially keeping those providers here, whether it's an incentive to reward the people that are staying in the state working on COVID, or it's a recruitment tool. Either one is fine. But again, just encourage you guys to make it as simple as possible. I just want to make a quick comment as well on the retention that has the 3-year retention piece. Depending on how you decide to structure it, we're supportive of either way. The retention piece could be important, but we might suggest, instead of a 3-year, if it's COVID related, to back that down again to make it easy. trying to track a 3-year retention and then enforce that 3 years from now and potentially try to claw back dollars is a huge administrative burden that would add complexity to the program and make it less appealing, frankly, for the state and the providers and the employers that would have to be entangled with that. In a HRSA federal program, you actually have a 3-tier contract between the student loan vendor, the feds, and the person involved. And so it gets very, very complex. So if you guys scale back this 6-month requirement to a shorter time period, we certainly understand that and support that. If you shorten it from 3 years to 1 year, we want them to remain in the state. We would be supportive of that. We want to try to be as flexible as possible because we agree with the comments that if the feds are going to have money out there and we can use it as a tool to support mental health providers and keep them in the state, and frankly, all medical providers, and keep them in the state, that would be wonderful. And I would also note that we just had a new graduating class from UW, and a number of those are in their provisional licensure this year. And being able to offer incentives to them as well would be something to consider in terms of how you craft the bills. So again, we're supportive of anything that you guys can craft. We appreciate even just putting it in place in case we get additional guidance from the feds or additional funds that come down, so we could take advantage of that. And with that, I would stand for any questions.
Questions for Ms. Somerville? Nope. Okay, thanks very much.
Thank you, Madam Chairman.
Okay, Elizabeth, who have we got up next?
Jan Cartwright, ma'am.
All righty, Ms. Cartwright, welcome back. I see her rectangle. There she is. Welcome back, Ms. Cartwright. You're muted still. There we go.
Thank you, Madam Chairman. Jan Cartwright, Wyoming Primary Care Association. We support this bill. Obviously, our organization does recruitment and retention for our community health centers. At this point, some of our health centers are also eligible for the National Health Service Corps loan repayment program, but only those health centers that have certain HPSA scores are eligible. So I want to be clear that we have another option. But I think in general, Wyoming is a sitting duck when it comes to being able to recruit providers of all levels and talents and expertise, simply because we don't have any way to help them come to our state. And then when they get here, obviously, the work is hard. And so we're very much in support of this bill. One of the things that I want to note is that some of our health centers did provide extra incentives to their frontline staff who were treating people, testing them for COVID. And also just that stipends would be taxed, whereas the loan repayment would be tax-free. This is a program, again, that exists in the Office of Rural Health. And so I'll leave it up to you as to in terms of how long you will go out in terms of the buyback for getting the loan repayment in terms of whether you do it as a year or 3 years. But I will say that the Office of Rural Health is already managing that program. So I think that they have the expertise that would be needed. Not only is it important to get people here, but we want them to stay. So I think that this is a good answer in terms of what we need, not only for the current situation we're in, but for any future situations. And I thank you for allowing me to make comment.
Question for Ms. Cartwright. Well, that does remind me, once again, I forgot to call in the agency first. I'm very lame. So I see, have we got someone from the Department of Health that can do your agency report first?
I can let Stefan Johansson back in, ma'am.
Please do. Thank you. Hello, Stefan. Sorry, I keep forgetting you guys somehow. I don't know why.
Madam Chairman, can you hear me?
I can hear you.
So just, I'm not sure if there was a specific question still on the YouTube delay, sorry. From Department of Health, just a few general comments. Had our policy administrator do some legal analysis on both the CARES Act requests that we were making as a Department of Health, as well as some of the legislative ideas, proposals, and actions that we've seen. Specific to this bill, I think to echo Mr. Brody's comments, the issue here, even with the language of, employees or physicians or healthcare providers that would be substantially dedicated to mitigation of COVID-19, that's specific both in the Treasury guidance and in the CARES Act to payroll expenses. And so I don't know how the way it is currently written and using the CARES Act specifically as opposed to a future funding source, how that could be directly tied back to payroll expenses. So we echo some of the concerns that Mr. Brody outlined, but not to just be a stick in the mud in terms of recommendations for how this could potentially look. Obviously, like you've all mentioned, if there's another funding source that comes out of the federal government, we don't know if or when that will happen, could certainly be an idea here that gets tabled that we revisit when those funds might become available with less strings attached. Additionally, that what we would recommend is any language in a bill like this where healthcare provider recruitment is specifically part of the state's recovery planning or strategy when it comes to COVID-19, to again indicate kind of the mission there. And last thing I'll mention is again just reiterating what I said before, is not relying on the payroll provision specifically. If this is how the bill would be written, I think it makes it particularly problematic for that continuum I mentioned this morning of audit and clawback risk. So this, I think, is certainly less risky than, for example, buying the health's deputy director a personal jet for travel, but more risky than a public health response to increase COVID-19 testing. So I appreciate the opportunity to make comment, and again, would just echo some of the comments that LSO made earlier. Thank you.
Stefan, I do have a question there. Are you folks following at all the proposals for the loan repayment forgiveness in the HEROES Act and the things that they're kind of working on in Washington now?
Madam Chairman, yes, we're trying as best we can to follow the various proposals in Congress, obviously knowing there's a little bit of a stalemate between the House and the Senate. But in terms of the HEROES Act, last I checked, which was a couple days ago, that is still significantly stalled, especially on the Senate side. So I'm not personally, I won't speak for the department personally, I'm not optimistic that will pass as is. I do think there's a likelihood that additional funding might come out of the federal government related to COVID-19, and we keep hearing discussions about broader authority, especially for state government when it comes to stabilization and additional funds for the COVID-19 response that don't have as many strings attached. But I will just mention and echo some of the frustrations that others have mentioned. Treasury guidance has been relatively broad, and maybe that's a good thing, but in this particular case, in crafting legislation at the state level, it's definitely a challenge.
Thank you, Stefan. Any questions for Mr. Johansson? Okay, well, let's go back to the waiting room. Elizabeth, who else have we got?
Ma'am, we have Eric Boley next.
All right, Mr. Boley. Mr. Boley.
Good afternoon, Madam Chairman, committee members, Eric Boley with Wyoming Hospital Association, and I can't enable my video either, but you probably don't want to see me. Oh, there you go. Sorry. I think I've been pretty vocal over the years of how important the loan repayment program is to our ability to recruit and retain providers here in our state. And while I like the concept of this bill, I too have concerns as I look at the guidance that's come from the Treasury Department with the use of the funds. I have some ideas, and I actually want to echo one of the ones that Senator Baldwin brought up. You know, Chairman Scott and I started conversations early on talking about the heroes that are out there that have been serving every one of our communities, not only the doctors, but the nurses, the CNAs, the support staff that have done so much. And as we listen to Stefan talk about some of the provisions that are contained within it, I think the stipend or some way to reward through payroll the heroes that have taken care of all of these patients and have done so much would be a really good way to take a look at this. If there is a way to do the loan repayment, I think it would be a wonderful thing. I have some concerns about our ability to hook and retain those providers and how we would identify who would actually qualify for it. As you're probably aware, we've had a lot of providers that have come in on a short-term basis, either volunteering or actually working in our state. And so as I look at the language in the bill, I try to understand who exactly would be eligible to have loan repayment. I also think about our longstanding providers in the state that probably don't have loan repayment anymore, but have served faithfully and through not only the virus, but for years. And I worry that they're not being taken care of through this actual or through this mechanism. The other thing I think that we need to realize is that there's been a lot of lost revenue for our providers across the state. A lot of our clinics have had to close down. They've had to make furloughs. The providers that have outstanding debt have gone without income to the levels that they're used to. And so it's exacerbated the fact that they have outstanding debt. And on top of that, you know, I could talk to you about the lost revenue for our hospitals from around the state and what they've been facing too. So I think in concept, I'm very supportive of any type of loan repayment, but I also think that we need to be cautious with the funds that are coming. I don't really think that the HEROES Act that came out of the House is going to pass the Senate in any way, shape, or form. But I do hope that there are some provisions that allow us some flexibility on how we use the $1.25 billion that came to our state. But if we do move this forward, I do think it's important that we figure out the right way to make sure that we're not just paying off debt and then we lose these providers. There's got to be a way to make sure they stay in the state, or we really haven't helped ourselves. But once again, I think the most important thing is we need to recognize and realize that all the heroes that have risked their lives to serve our state through this, and they're going to continue to do that. We're not through the woods yet on this. I think we've still got some rough days ahead of us. So with that, I'd answer any questions.
Questions for Mr. Boley? Okay, thanks for coming by.
Thanks, Jim.
Elizabeth, have we got any more?
Yes, ma'am. The last individual we have should be Lindsay Simino.
Okay. I see Wendy Curran is still in the waiting room. Is she planning to testify on something else?
I am uncertain, ma'am, but we can let her in and check after Lindsay's testimony if you would like.
Oh, I was just checking. I just wanted to make sure whether she had just not left or maybe she wants to talk about the telehealth or something like that. Okay, Lindsay. Hello, Lindsay. Welcome back. You're on mute.
Madam Chairman, that lag in the YouTube video has definitely increased, but yes, I assume we're still talking about loan repayment. I was still in the middle of Mr. Boley's testimony when you called me in, which is fine. I'd like to just echo a lot of my colleagues' comments as far as we support any loan repayment program, anything to promote retention within the state for our mental health workforce. Some points that I do think are valid is that though we do have many providers within the state that may not have student loan debt, we also may have a lot of providers within the state that do as well. I am 10 years out of grad school and have not quite reached the halfway point in my own personal debt, and I know that echoes a lot of providers that are around my age, and that debt increases for our younger providers, our younger provisionals. However, we appreciate the idea of a stipend program. We recognize that other providers do not have debt, and they have done substantially dedicated work similar to us as well. And so if it needs to change, if this bill needs to change to where more heroes are recognized and awarded, we are in support of that. We are in support of really any loan repayment program or anything that shows healthcare providers a thank you, as you will, for the work that has been done. Obviously, yes, it does need to comply with the language given by the Department of Treasury. We understand that that language is not clear. It may become clearer farther down the road. We learn something new every day in this process. And so we are in support of this bill as it is. And we, if it does need to change dramatically into something that the committee is more comfortable with, we're in support of that as well. We would just like to see this conversation continue with possible CARES Act money or other funds down the road.
Okay, thank you very much. Any questions for Mr. Simoneau or Ms. Simoneau? I see none. All right. Thank you so much.
Thank you,
All
Madam
right, I
Chairman.
guess there is no one else in the waiting room, Elizabeth?
Ma'am, there are several people in the waiting room, but I do not have anyone else listed for this topic for public testimony.
Okay, then in that case, then public testimony is closed. I think before we go on and inquire whether we want to move the bill or not, I think I'd like to take a straw poll, because I understand that it's a little bit challenging under the current CARES Act. We have some consideration as to whether we want to try to develop it into something that could be a tool for whatever the feds come out with. But working on it is going to take up probably a bit of time based on the things that we have. So it seems to me that we have a couple of possibilities, which should either be to move the bill and work it over. We could sort of table it and bring it back in a couple of weeks at our proposed meeting, which granted might not actually occur, but I think it will, with perhaps better input from the feds or some other thoughts, or we can just let it go entirely and say that this isn't going to work. Chairman Scott.
Yes, and I think if there's not the enthusiasm for going forward with it at this point because of the troubles and fitting what we need to do into the CARES Act, I think there'd be the possibility of saying, look, the feds are currently dysfunctional enough, so we probably won't get anything from them immediately. And what we ought to do is get a generic bill that would enable us to accept money for loan repayments that would fit our needs, and bring that to the August meeting with the intent of doing as a bill in the general session. I think that's a possibility too, because I'm not sure that we can make this fit with the CARES Act requirements.
Representative Yin.
Thank you, Madam Chairman. Yeah, I kind of personally interpret the CARES Act requirements fairly more broadly than I think the guidance gives. And so I would be willing to pass the bill out of committee and out of the House on the floor. So I'm totally for it. And if they decide to open it up to in the guidance to more things, I think that that's fine, and we could wait for that. But I think I would also be in favor of reworking this bill into a sort of healthcare hazard pay bill, because hazard pay is something explicitly in the guidance that is allowed, and something that we can tailor specifically for all healthcare workers. Because I think, like some of the public has mentioned, that not only are the people with loans the ones helping us out with the crisis, there are people without loans that are still helping us out with the crisis and putting themselves at risk. So I would be for either of those options. And I will leave it at that. Thank you, Madam Chairman.
Representative Hallinan.
Thank you, Madam Chairman. I'd be for option number 3. I think that the COVID issue with this is very doubtful whether we'll be able to make it through analysis for that reason. And I think that we should wait, like Senator Scott mentioned, that we should wait and see if we get some further guidance from the feds as to whether it would be worthwhile to address this issue at this time. And I think we'd be wasting our time to approve the bill now. I think so. Thank you, Madam Chairman.
Okay. Senator Schuler.
Thank you, Madam Chairman. I have a tendency to agree with the good representative from Jackson. I think that there's a basic bill here that has some pretty good options. I also kind of read the CARES Act a little more broadly, that I think you could use the money for some hazard pay. And we actually had an amendment in the Senate during our special session by our good chairman here, co-chairman. It didn't get passed, but I think the way I interpret this is that those folks that are working in our prisons, for instance, in our jails, and our heroes that are working in the hospitals and whatnot, I think there is a potential there for some hazard pay or bonuses, call it what you will. But I think we could maybe do some work with this bill and get some good out of it. Thank you.
Representative Sweeney.
Thank you, Madam Chairman. And I also agree with the good representative from Jackson. I think there's good portions here, and maybe the approach should be, I don't, if we push it off to August, we're not going to do anything because it's going to be too late, I'm afraid. I'd rather try to move this for 2 weeks from now, get it maybe put back together in a different form, and not, but I'd like to move something forward at this upcoming special session, so that it may be totally blown up. Maybe there won't be any special funds, but I agree with Representative from Jackson that you know, the stipend, the bonus, I think that does already fit, and you can view a loan repayment as they can utilize those monies towards loan repayment if they wanted to. It's then their money, but in looking at it more broadly.
Representative Stivar.
Thank you, Madam Chairman. I think we need to table this. That letter that was put out by the Department of Treasury, April 22nd, on that 4-page paper, this does not fit in that criteria. And we need to, the state doesn't need to come back in 4 or 5 years and pay this back. I think it needs to be tabled and looked at another time.
Okay, so those are good comments. And what I'm actually going to do is ask everybody, I'm going to keep a little tally here, just because, and the reason is I'm kind of going through this is just, I don't want to spend, you know, an hour and a half on this if we don't have, you know, 8 votes to move it forward. My 3 boxes on my paper here are go. In other words, we think we can work it today to make it in the shape that we want it. Wait, which could include bringing it back in a few weeks, pending it may or may not be in better shape, but folks will have some opportunity to think of amendments or changes, and we might get more information from the feds. So really the wait and the no, well, I'll ask, you know, and you can just say no entirely. So I'm actually just going to call on everybody in the order of that I see you on my box, which might not be the order that you see yourself, but that way, at least as long as nobody moves, I won't lose anybody. So Representative Hallinan, what category would you like to be in?
No, Madam Chairman.
Okay, Senator Schuler.
Wait,
Okay, Representative Stivar.
No.
Representative Yin.
Wait.
Representative Sweeney.
Wait.
Representative Barlow. You're muted. I can't hear you, Representative Barlow.
Think he's on another meeting.
Might be. I'll come back to him. Senator Pappas.
I'm a yes.
Okay, Senator Baldwin.
No.
Representative Clem.
No.
Representative Roscoe.
Wait,
Representative Dayton Selman.
Wait.
I think Chairman Scott.
No, at this point.
Does that mean wait?
No, it means no.
Okay. Let's see, that's 10, 11, 12. Who did I forget?
Yourself.
No, I know me, but I've got 11, 12, 13, I've something, who's not here? Oh, Senator Bouchard. Well, he had to go. Okay, so there's certainly not enough people to go anyway, regardless of what Chairman Wilson and Representative Baldwin say. Okay, so although we have about half interest in weight, so we won't move forward on this bill today. I'll keep it in my pocket, and you all should look at it and the originating statute. And if you don't have the CARES Act, I have all 880 pages of it. But as was pointed out, we're in a lot of ways, we're not really working under that. We need to keep our ears to the ground and see what comes out of DC. But if you want me to ship you the CARES Act and you want to give it a retry at the hazard pay or some other thing, keeping in mind, and I'll just say, keeping in mind that, hazard pay, you could certainly claim that a whole lot of people should be eligible for hazard pay. Pharmacy techs, grocery store people, people at truck stops. I mean, that could be challenging. But so we'll at the very least keep thinking about it. If the odds are good, I think, Chairman Scott, that we're going to have a second, hopefully brief, but getting longer, one-day meeting before the next second session. Okay, so we will move on now to, actually, I want to bring up the mental health topic just so we can, and move it before telehealth, just because we have someone from WICHE who is going to make a presentation, and I don't want him to have to hang around listening to us any more than, unless he has nothing better to do, which I find unlikely. Chairman Scott, I see your hand is up.
Yes, Madam Chairman. At some point, we need to come back. We've got two potential other bill drafts to authorize. One's on the Medicaid issue we spoke about briefly, and the other one would be to just authorize an upper payment limit bill in the EMS area for consideration at the August meeting for general session, just a drafting request.
And possibly a
we need to come
licensing
back to those.
board bill. Actually,
And the
let's
licensing,
do
that's
those
three.
now. While Elizabeth lines up the WICHE and then just alerts the other folks on for mental health, let's just talk over those. So we can have just a brief presentation. Chairman Scott, and just talk a little bit about the Medicaid idea, perhaps the upper payment limit idea, and then I'll discuss briefly the licensure issue. So members, this would be just to authorize LSO to work with us and bring a draft for our supposed next meeting. It's so, and for discussion then. So we're not going to vote now, but we'll vote on whether to or not to go ahead. So Chairman Scott, why don't you explain those two briefly?
Okay, on the Medicaid one, that was in the Management Council request to us, apparently. We've got, I drafted and Ian went over and improved it, and I think sent it to the committee, a one sentence response to it that is just basically a generic authorization for the governor to expend money in that area. It potentially could be very useful to some of our providers, and we need to have them coming out of this COVID thing healthy and not hurting with great big deficits caused by COVID, because we're going to have a heck of a time going forward with our own budget, and they're looking probably at some Medicaid budget cuts. And I shudder to think what those might do to people. So it would be a basic authorization. It's a very simple bill, but we couldn't really act on it at this time because we didn't have the word and didn't get it, therefore, on the meeting notice. So that would be a potential. I think it's a simple concept and an up or down vote. The one on the upper payment limit, that's just a bill drafting request for really further consideration. The August meeting, it's a general session bill. So it turns out, Mr. Bowley brought it to us, very similar to ones we have passed before for particular providers. It would help the EMS people, and it might bail us out of some real trouble going forward with the budget difficulties we're likely to have. And at this point, I don't think we need to take a vote on it or not. I'd just like to make a request that we go ahead and have something drafted, LSO in consultation with Eric Bowley and his representatives, so we have something to look at and know what we're talking about. So those are those two, Madam Chairman.
Okay, so let's just get some vote on that. The first one would be just to authorize a draft for the next meeting before special session, because that would be the timeliness of it, regarding the Medicaid or payment to Medicaid providers.
Right.
So if you're in favor of that, go ahead.
Madam Chairman, I would say that part of that is if your chairman discovered that the executive branch feels that's not at all useful, that they've got all the authority they need and are likely to use it, then we might say, why bother to proceed?
Right.
But
People who are game for us to go ahead, put your hand up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay, that passes. Okay, then so that we don't really need a vote on the upper payment limit issue right now. I don't think you would be bringing that for the August meeting, probably.
yes,
Okay, then the other one that I'd be glad to have your authorization to have LSO work up. Again, this is a fairly short one. What has come to my attention from several actually of our colleagues is situations, and I won't mention specific licensing boards, but where you've got new graduates who have job offers ready to go, except that they haven't been able to take their national licensing test, whatever it is. And obviously we don't want people who are, can't pass a test. But given the current situation, what we're thinking of doing is actually amending into the, we've got the authority of various boards and things to do things in epidemics under state health orders and such like that. They can, for example, Board of Medicine, Board of Nursing has already used it to issue emergency rules for people to come in from out of state or various such things. And what we're thinking, because the statutes right now, if I looked at one of the boards, we pretty much require that the person has to have passed this test and then such other things as the board deems acceptable. Well, I can certainly see that a board might not think that not taking the test at all didn't fall under their authority to say that that was acceptable. So what we would do is something along the lines of, they can issue a temporary license to people who have passed all of their coursework, have not failed the test, and the temporary license would last only for a certain time, and they would need to be supervised by a licensed Wyoming provider. So that would be the gist of it. And if we may end up passing this off to corporations, depending on what our scheduling is and theirs, that sort of thing. But if you're okay with that, if you'll stick up your hand. 11, I had 11, I think I have 12. Okay, good. So very good. We'll go on with that. Okay.
Madam
So-
Chairman, if I could just ask a quick question. I know we've already voted, but it just seems to me, on working on some licensing board issues, they've certainly been a sticky wicket on that particular issue. So will this be in such a way that they can say, yeah, we can do that, or no, we're not going to monkey with it?
Well, in the current statutes, it's permissive in the sense that department, if you think of the Board of Medicine, Board of Nursing has said, yes, we're going to do these. And now, personally, I don't think that I wouldn't mandate a board to do something with licensing people where they didn't think it was acceptable. I'm not too gung-ho on that. Now, as far as the committee, if you want to say shall in case of a pandemic instead of may, I think that's within the committee's purview. Whether a shall would pass the chambers, I don't know. But I think that's up to us, whether we want to have a shall or a may. But I think if we at least give them the authority, that would probably work. And we don't need to talk too much more about that right now, I think. But Chairman Scott.
Yeah, Madam Chairman, my thought would be the same, that we ought to make it very permissive, give general permission to any of the boards in Title 33, and maybe a couple that are outside that, to waive that particular requirement just for the COVID things, because that'll be easier to get through a special session if it's just a very permissive and time limited, and then consider at our subsequent meetings whether we ought to have a permanent law that would enable that particular requirement to be waived generally if we have a future pandemic or other natural disaster of some kind that prevents people from taking the test. And then we can debate in more detail what we might require and what we might not. But just to do the instant one for this, just for COVID and just for the next year or so.
Okay, so we'll talk about that at the further meeting, seeing as it's passed. But Elizabeth, were we ready with some folks on mental health?
Yes, ma'am. They should be coming in now. We also had WBI confirm that they'd be available if we move mental health up as well.
Okay, great. So I'm actually going to, I think, reorganize this list again a little bit to just let out the people who, because we're not taking action at this time, so it doesn't matter really a ton what order we put them in, but to just be courteous to people that aren't state agency people and used to suffering with us. So if you recall, folks, we have on our interim topic list in general, because I felt very strongly that these problems that we identified in March have not gone away. I don't want COVID to just take over our brains for the next 6 to 9 months. We need to get some work here. But so because we're having to take the testimony and it's a little bit more awkward to really get our arms around the whole issue, I just wanted to make sure that we were getting some testimony, get a start on that. As far as you remember, we had the Behavioral Health Task Force bill that didn't pass. And some of you on this very committee wanted us to deal with it in committee rather than as a task force anyway. So what we need to really make sure we understand is what services are available in outpatient, inpatient, what are our workforce needs, what's the funding. I mean, you know, that it's a very large topic. And so you'll see on the agenda, we've got Department of Health that's going to give us some funding and programming background. We want to hear a bit, and WBI will come in here about adult and youth residential services. There's some information provided in the packet on Title 25. I'm not sure that we need to digest all of that right now, but I've asked Witchy to report further on something that we did hear a bit about last summer in Evanston, if you recall, that in the state of Alaska, there is a program developed for community mental health workers. The idea, as I recall it, and we will hear from Witchy, perhaps I've forgotten it, maybe I've messed up the whole thing in my head since I heard about it, but the idea that you could have local people, community people, basically get a credential, a certificate level, a half a certificate level, to help them provide grassroots level services for mental health needs in their communities. But that also, the thing that really attracted me, you recall that some years ago, we had the education committee did a lot of work with making sure that if you did a degree at a community college, that it would roll over to UW without loss of credit and such like. And so the idea being that we could set up some sort of certificate type program. I think my mind is at a lot fewer weeks than what Alaska is doing, but that can be worked on. And that then if a person wanted to go further, they could get some programming through community college, whether in substance abuse or counseling, and that those things would continue on through associate's level, bachelor's level, master's, that sort of thing. So that just to build out our community workforce, and I'm visualizing this, and I hope that the vision might come true, but that people like pastors, bartenders, folks at the safe house, those police officers, that it would be the type of training, you know, longer than 2 days, but shorter than 6 months, that would enhance their ability to respond to needs in their community without them having to leave and go on to lengthy programs, and just build up our workforce. So that's my intro. So I'm going to ask Mr. Moat from Witchy to do his deal. Thank you so much for waiting. I think you've been here, although you look like you're in a nice location, sitting outside under a tree there. You're muted. There we go.
It's
just introduce yourself for the group.
Okay, if I could share my screen, we'll just kind of motor through this. Okay. Madam Chairman and members, thank you for this opportunity to talk a little bit about the Alaska Behavioral Health Aid Program. My name is Dennis Mohat, and I'm the Vice President for Behavioral Health for the Western Interstate Commission for Higher Education. Joined here by Becky Helfand, our program director at Witchy, but I'll be taking the point on this to motor us through. I know you're running late, so I'll try not to get dragged down. I just want to preface this with, since there's a few of us on this call that remember the 1960s. When I was a kid, the ambulance services were run by the funeral homes. There weren't paramedics and EMTs. An upgrade to that was when they started having orderlies at the hospitals run the ambulance. Now, you know, in that model, it cut out the middleman, but it wasn't the most effective way to deliver care. But in our experience, mostly in Vietnam, we saw the potential of medics to really be able to provide that level of care at the community. And we developed a system of EMS that starts with a first responder and gets that person to an emergency room. And really, that's sort of the model here. But if you think about when you train to become a first responder or a provider of CPR, all of those things are competency-based, and that's what this system is. And so just to put that in your head to think about it. It's another way of building a workforce. I'll go through the basics here first. The Alaska Behavioral Health Aid Program is a training and certification program to ensure basic behavioral health capacity in remote and rural locations in Alaska. And when you say remote and rural in Alaska, you're saying native Alaska. Individual behavioral health aides must complete a series of courses specific to a level of certification. And they must be supervised, and their competency has to be verified. So it's not just sitting in a chair and taking a number of hours. That competency has to be demonstrated. Just like I'm a CPR provider, I did the coursework, but then I have to demonstrate in my refreshers and in my course that I know how to do CPR. And so I have to show my competency. The BHA work model is a work, learn, and certify model. You don't go to school to be a BHA. You get a job to be a BHA, and your training is embedded in the workplace. Alaska has been able to leverage Department of Labor laws to actually run this program as an apprenticeship program, which has really helped offset some of the costs of doing this. Behavioral health aides do not replace the traditional professional behavioral health workforce. They extend their capacity to places they can't get to. The training in this program articulates into associate's and bachelor's degree. Every single credit that you earn becoming a BHA and going up the BHA ladder counts and is transferable to earn your associate's degree, then your bachelor's degree. And many people have then leveraged those degrees to go on for their master's. And I've even met a couple of people who have gone on to the doctoral level. So it's a career and educational ladder. Local clinical supervisors support training, mentorship, and validate that the BHAs demonstrate those competencies. And it's a progressive certification, just like an EMT1, EMT2, paramedic, you build up over time. And as with any kind of competency-based healthcare training, there are periodically required refreshers. So it's a continuous learning environment. So rural Alaska, there aren't roads in most of rural Alaska. You fly or come in on boat. When I talk about the Alaska Tribal Health System, it spans the entire state of Alaska, and each of those areas have a healthcare corporation that provides that care. And just to give you a little picture that the Alaska folks forced me to use to show you just how big Alaska is. The one region there in goldenrod or yellow is the YK Delta area that's centered on the hub of Bethel, is about the size of Wyoming. So that gives you an idea of just how big we're talking about. Well, you were never going to have doctoral and bachelor's level providers in those little villages. And so they really looked at this as a way to ensure that there was somebody in every community that could respond and could provide care. So what is it? It's a system of standards and procedures. There are certification requirements. There's program oversight, supervision requirements, a defined scope of practice. There are competencies that have been developed and refreshed over time that you have to meet and demonstrate you can do. There's training and a related curriculum that can be done both in person and through distance. There's actual practicum that you have to complete to show that you're competent. And it's also continuing education. And there are a lot of partners, the community schools, the universities. They don't have community colleges in Alaska, but they have branches of the University of Alaska out in the villages. They're all part of this. There's a scope of practice that starts with prevention that goes on through early intervention, aftercare, and postvention, and behavioral health aides work all along that continuum. And there's just sort of, this is just the training. There are a lot of hours, but you have to remember that you get a job first. And this training is embedded in doing your job because it's a work, learn, earn kind of an environment. So as you're working, you're learning these competencies, and you're spending these hours. Those little numbers are the hours of training and experience that you have in each of these competency areas to be able to practice as a behavioral health aide. And then obviously behavioral health aide 2 gets a little bit more complex and sophisticated. Eventually to a behavioral health 3, where you're providing some supervision of behavioral health aide 1s, and you're a senior behavioral health aide. And then finally a behavioral health aide practitioner. You're at the top of your game, and you have the full scope of practice as a behavioral health aide. I will tell you that in practice, by the time people get to be a BHA 3, they've earned a bachelor's degree, and by the time they're a BHP, most folks have a master's degree. They get those along the way. So what does that mean to you? I mean, what for a state like Wyoming? I mean, first of all, you have to look at what are the problems you want behavioral health aides to work on, because you want to define. Alaska's defined theirs to be very sophisticated, because they can't drive to the next town over to see somebody. They have to be able to handle a crisis and keep the community and keep the person safe through an extensive period of time sometimes. And so they have to have a pretty wide range. Perhaps in Wyoming, you don't need that full scope of practice because you might want your behavioral health aides to have a more limited scope and a more limited involvement. What are your current providers out there? Where are they? Because you'd really want to build this program to go where they are not, and so that you can really expand and extend their capacities. And then there has to be a clear distinction between certification levels. There is a real difference between being a BHA 1 and a BHA 2, just like there's a real difference between being an EMT and being a paramedic. You can do more. You're more skilled and you have more competency. Also, you have to understand that they need supervision, and how do you provide that supervision? And then what are the competencies you want to train to? So the model in Alaska is a model that you can look at, and it can be a guide, but for a program like this to work in Wyoming or Colorado or South Dakota, it has to fit your environment and your needs. You have to think about it as a system of care, and the BHAs fit within that system of care. And so what is it in that continuum of care? Where do you want them working, and what do you want them to be doing? There are state adaptations of this. In Minnesota, they've developed mental health behavioral aid that's youth focused, that really work within children's systems of care and provide support to the treatment teams and to parents in the home. And you can see there's quite a bit of hours involved in this as well, along with the annual refreshers. In the adult area, they call them adult mental health rehabilitation workers in Minnesota. And there's 30 hours of upfront training. It's a more limited scope than you see with the behavioral health aid program. But again, you're not as isolated in Minnesota that you need people that have the ability to do as many things as you need in Alaska. But there too, they have to have 2,000 hours so 1 year of supervised paid work experience actually doing the work of a rehab worker. So how would you proceed in doing this? I mean, I think you need an inclusive planning process. The existing provider community and healthcare system has to be a part of this from the get-go, because if they don't buy in, you can't just create something out of whole cloth. There needs to be a consensus of action. People have to feel that it's not all right, that there's not someone, most places in Wyoming, that someone can turn to, that when you send somebody home from Evanston after they've been hospitalized, that there's not someone in that community to provide some aftercare and support. So that there has to be a consensus that we can do better, and this is a way that we can do it. You have to invite educational partnerships. You have great community colleges in the state of Wyoming, and they can be integral partners in this. Obviously, the University of Wyoming has to be a part of this, because they have to be a part of that articulation of credit. Because if you turn these people on to learning and they really want to grow their knowledge, if they have to keep going back to the start every time they go to a different program, if they have to go back to Go and all the things that they've learned in the workplace and in doing this work and this certification do not count, then they won't progress to that baccalaureate degree, that master's degree, or that doctoral degree. You have to ensure financial viability. You have to be able to reimburse this. Medicaid has to cover it. And inviting the private sector to reimburse as well. There has to be a certification board. I heard you talking a little bit ago about licensure. There has to be a certification board, someone that actually oversees this and makes sure that they're doing it right, just like we have for EMTs. And then you have to practice continuous quality improvement, because you'd launch something like this and you want to see, is it working? Is it making things better? Are there ways that we can tweak this to make it better? And so that it's continuously improving and moving forward. That's our team at WICHE. That's a picture of behavioral health aides from across Alaska at a central training conference in Anchorage a couple of years ago that I had a chance to be at. And those folks all live in villages, and they're there providing care. And they work really effectively with psychiatrists and psychologists and social workers that are in the hubs and back in Anchorage to make sure that people have access to care. So with that, Madam Chairman and members, I will stop motoring so fast and I will stand for your questions.
You did super. Do we have questions for Mr. Moat? Make sure to put your blue hand up, because I can't, so while the chart is still up there, I can't see everybody else's face. Representative Sweeney.
Thank you, Madam Chairman. Thanks. Good to see you again, Dennis. My question is, in Alaska, are they able, through the process, to utilize telehealth? And in order to gain their certification, hours as they're going under the practice and certification of a licensed professional?
Mr. Millet.
Thank you, Madam Chairman. Representative Sweeney, the way it works in Alaska is that there's, when you're hired, you begin to progress through the curriculum. Some of that's delivered through distance education. All of your work is supervised by a licensed professional forever. And so you are always supervised. And those supervisors actually have to sign off on your competency. So they are both your supervisor and your mentor and teacher, because they're a part of the training process. And then there are residential components of this. So they do a BHA conference once a year, and they bring all the BHAs in, and they have them attend that meeting and have some intensive training during that. But most of the training is done at either through distance education or through applied experience. So it's a balance of didactic instruction, of book learning, and of actual practical training and experience that's supervised.
Senator Baldwin.
Thank you, Madam Chairman. Dennis, it's good to see you. I appreciate the presentation. It seems like it's just been a few days since I saw you last.
Yeah.
Just a quick question for you, sir, and that is, when this first program was initiated in Alaska, how long did it take to actually get stood up and before it became effective or begin to work fairly fluidly?
Madam Chairman and Senator Baldwin, it's good seeing you again too. And actually, time is suspended right now. It's like Groundhog Day every day. And Alaska has a rich experience in this area. They've had community health aides who are super paramedics who provide primary care and public health since the 1950s. They've got dental health aides who are sort of super dental hygienists who provide basic dental care beyond just basic dental hygiene. And that program's been going for about 20 years. There's been an evolutionary process with the behavioral health aid. Early parts of this, they had a human service certificate program, and they called them village behavioral health aides. And that was a more, it was also a sort of a hybrid distance program. And then about 10 years ago, they folded that program into right with the community health aides and the community dental health aides programs, so that it's all a part of the same area of practice, kind of like EMTs and paramedics are all sort of certified by the same folks. And so they did that. It probably took that early phase of village behavioral health aides and sort of having the healthcare system decide that, yeah, behavioral health needs to be at the table too. Probably took about 10 years. But then when it went, they just, because they had the whole apparatus there, they were just able to flow this right in and set it up. They've refreshed the competencies twice. The first time they did that was about 10 years ago. And then I think about 3 years ago, Witchy actually had a contract, and we went up and we helped do the refresh of the competencies for the last time it was done. And so they spend a lot of time developing this. And so I think that's one thing that's good for others who want to adopt this. A curriculum already exists. And so there's a way to adapt that curriculum to another place. There's a whole certification process that someone could look at and again, adapt that to a different environment. So I think that the startup in a new place will not be as difficult, but you never know. I mean, obviously there are guilds out there, and if you increase people's access to alternative providers, even if they have to be supervised by others. I would predict that there will be someone will say, you can't do this, you're intruding into my scope of practice, even though I've never been to Thermopolis in my entire life and provided care there. So that's sort of how it works.
Representative Hallinan.
Thank you, Madam Chairman. And I guess I would like to know, how much does this program cost the state of Alaska? And what would be the reimbursement that these folks receive at various levels? Are they full-time people in these jobs, or are these part-time people? So with that, I'll stand to hear your answer. Thank you, Madam
Mr. Mowat.
Madam Chairman and Representative Hallinan, I don't have off the top of my head the total cost of this. These folks are employed. So the thing is that the state, so they're employed in Alaska's tribal health system works differently than the lower 48. So there are healthcare corporations in each of those areas that I showed. And these folks work in those systems, and they are employed. You can't become a behavioral health aide by going to the local community college and doing it. You actually get a job and you begin to do the work and build up your competency along the way. I do know that the range of pay goes from under $15 an hour to at the top of the scale, it's probably approaching $30 an hour for one of these workers. But if you'll recall, when I was saying at the top of the game, you have the equivalent of a master's degree.
And so if I can just insert in there, Representative Hallinan, you know, my vision for this would be maybe a little bit different than what they're doing in Alaska. I mean, it just depends on what develops, but I was really visualizing something with a bit narrower scope and fewer hours that people would kind of voluntarily, out of their own interest, take on in conjunction with their already existing job, whether they were a pastor or a bartender or an EMT or a counselor at the domestic violence shelter, but that would enhance their skills and their abilities to provide, you know, you think of somebody like, you know, that works at, you know, I don't think there is a mini mart in Shoshone, but can't remember what's there, but, or maybe it's the school secretary at the school in Shoshone or something, but that they would find that we would enable them to enhance their ability to do the work in their own community. So, you know, I'm visualizing it a little bit different than what Alaska's got, but they've got curriculum, they've got certification process. And then and I see Representative Stivar's got his hand up, so I'm getting there, but I just want to say, over the last year, I did discuss this in a very general way with people from the Community College Commission, from people at UW, from the Mental Health Practice Board, and they were all interested. You know, that's a remote location from actually getting anything done, but so my vision is maybe a little bit different and would not be quite so involved. But Representative Stivar, thank you for waiting.
Thank you, Madam Chairman. This is real interesting. I'd like to get a little more knowledge in it. Can we get a copy of his PowerPoint?
Do we have that in our package?
Yes.
Ma'am, you should have received that this morning as an email that I sent, and it's probably way back in that list. It will also be posted on the website later on with the minutes.
Very good, thank you. More questions for Mr. Mowat? None at the moment. Okay, awesome. Thank you so much. I'm sure that we will at least stir up further discussion. And you are the go-to guy. Thank you for waiting so patiently all afternoon, all morning. I'm not quite sure how long you've been hovering over your screen, but very informative. I think has some potential for us. Okay.
Thank you.
Let's see, we've got, Elizabeth, you can line up our mental health. Let's see, do we want to start with maybe Department of Health actually, just to give us a general overview before we take some of the other folks?
Yeah, ma'am, I will start admitting individuals. There are quite a few.
Okay, well, good. Mr. Johansson, here you are.
Thank you, Madam Chairman. I'm going to be very brief in the interest of time and let the committee know that slides 19 through the end of the Department of Health's presentation were really geared to update information that we had provided to the committee in previous meetings a couple of times on behavioral health funding, bed supply, things of that nature. I will just mention on slide 20, per the committee's request, we did try to do some work to estimate the annual expenditures in the private insurance and in the Medicare markets for behavioral health services, but you can see those estimates are pretty broad. Moving on, the next 4 slides, slides 21 through 24, really just update what you've seen before in terms of Department of Health, behavioral health service funding, as well as work that we did with the Department of Family Services related to their mental health and behavioral health related costs across different service areas and residential type settings. We also worked with the Department of Education to update slides that you've seen before related to educational behavioral health costs in RTC, BOCES, and PRTF type settings. And I don't want to step on the toes of either Department of Family Services or Department of Education if there are questions about some of the data in these 4 slides that you're seeing here, 21 through 25. And I know the Department of Family Services, either Director Schmidt or Lindsay Schilling, has some additional detail to provide, which I'll certainly kick it over to them when I finish here in just a minute or two. Moving on, Madam Chairman, and I should mention we are more than happy to follow up to answer questions, but I know after a day of being assailed by a lot of information and information overload, I'm sure our brains could use a rest, especially after a long COVID-19 discussion this morning. So that's the reason for my brevity right now. Slides 25 and 26, again, information that this committee has seen before about the Department of Health's funding and policy structure for the community mental health and substance abuse system, as well as updated contractual obligations and funding through the Behavioral Health Division to community mental health and substance abuse providers. You can see that's been updated through fiscal year 2020.
Stephanie,
I did want to mention, like I said before,
Stephan, hold on a second. If I can just back up to slide 25, you could just remind us where it says the priority populations. You know, we had some discussion in last session, I guess it was, you know, with moving the recently discharged folks from corrections and whatnot. Could you identify who specifically who the priority populations are?
Madam Chairman, it's a great question. Happy to provide the full list to the committee. It is a little bit lengthy, but it does include, like you see there, clients who are diagnosed with serious mental illness, children who are diagnosed with what's called SED, severe emotional disturbance, veterans, pregnant women, IV drug users, pregnant IV drug users. There is a list that's in all of our contracts with the centers that I'm happy to provide the committee. But those priority populations have really stem from the priority populations that are identified in the federal mental health block grant, which is a small amount of money, relatively speaking, to what the state pays into this system. But that's where those priority population definitions really originated years and years ago, was from the federal priorities for the community system.
And so have you gotten to the point now where the priority is nearly everybody? Or, you know, I mean, when everyone is a priority, then it doesn't help the to-do list that much. How much on average, and I appreciate that with 18 providers, that's probably not the same, but how much of the clientele is in the priority population?
Madam Chairman, that's another good question. Unfortunately, I don't have that data in front of me, but it's something we can follow up on relatively quickly. But to your general comment, I think the systems like this and others absolutely teeter on that problem of too many priorities. It's can develop a lot of mission creep, and then frankly sometimes some unfair expectations on contracted providers that, you know, throughout the years the state has said, okay, here's your mission. It's general access services for folks who come in for, you know, outpatient counseling, but also, you know, year after year, take care of the veterans, take care of the SMI, take care of the SED, take care of Title 25, take care of corrections. And like we mentioned or discussed at length with you all last year, and not to sound like a broken record, we teeter on this fundamental philosophical question of, is our system missioned for general access, or is it missioned truly for priority populations? And I think reality is probably somewhere in the middle, but that's really, you know, the microcosm of the corrections bill that passed for the you know, new programming or at least new outcomes-based funding streams for the corrections population to reduce recidivism is kind of a microcosm of that overall problem, Madam Chairman.
Okay, thanks. Go ahead. Sorry.
No problem at all. Finally, I did, Franz Fuchs did some great work here to estimate using multi-payer claims database data that we have, basically including the state employee group, the EGI insurance plan, but using that and combining it with census data to model what, you know, if we assume that other, you know, private insurance plans and market kind of looks the same as EGI, which is a significant assumption, but probably the best one we can make, what the privately insured MHSA or mental health substance abuse spending looks like. So you can see some of the estimated data here, approximately 340,000 lives covered. And again, using the multi-payer claims database, assuming that privately insured spending in Wyoming is similar to EGI, and a few definitions there of behavioral health spending. We'll mention here that claims data in the private plans is generally lower quality than Medicaid data, which is fairly granular and high quality for our analytical purposes. Most private plan data that we've encountered is lower quality than what we have in Medicaid. So just some caveats here, but wanted to point out to the committee that we did put together a per member per month estimate, both for males and females, for employer-sponsored insurance plans. Again, this is estimated and modeled, but you can kind of get a sense of what the per member per month by the various age groups is there, and you can really see a spike, you know, in your younger individuals and younger adults of, you know, around $20 to $40 per member per month, and as you grow a little bit older, that spending in the private insurance market kind of lowers. We also did a similar analysis, Madam Chairman, and sorry for jumping so quickly, but similar per member per month estimates here modeled out by the different provider types. And this shows a similar calculation or estimate that you saw on the previous slide, but broken out by those different types of providers. So at the very top, you see your psychologist and your psychiatrist, cost on a per member per month basis, your LCSW and counselor costs, your facility costs, hospital costs, and clinic costs. And you can see there's quite a wide variation, but generally around, you know, $5 to $15 per member per month, depending on your age. And again, this just shows, you know, getting some utility out of the multi-payer claims database that has been in operation for a couple of years. And not to make his cheeks turn crimson, but Franz has done some really good work to generate utility with that data and be able to use it for a variety of purposes. You also asked for, in this particular scenario, to have some estimates for the privately insured spending in all of these different categories. So we showed that on a per member per month basis, and now this rolls it up with some uncertainty intervals there on an annual basis. Finally, Madam Chairman, in terms of residential services, another request from the committee on the agenda, we did update some information that you've seen before in terms of our total bed supply of PRTFs as well as in more in the DFS world, your residential treatment centers, group homes, crisis beds, and then finally, on the behavioral health division side, substance use disorder beds as well. We also show our bed count specifically to the behavioral health community funded providers across those different settings that you see there, the number of beds and some estimates of how those beds shake out between the total beds in the system provided by our residential community providers versus the state funded beds. And that's a little bit of a tricky issue. We talked about it briefly last year on what is the state funding versus what a center might have that's that leverages private resources, and what dollars fund which services and what cross subsidizes different services. So it's a kind of an initial look at the bed supply both on the state funded side and the total bed side, Madam Chairman.
Stefan, let me go back to the previous slide again, 32, I think it was. Yeah, 32 is what I want. So the list of out-of-state beds under the PRTFs, is that are we paying for patients in all those beds, or do you have contracts with these people? I mean, are we actually paying for 154 people in-state beds, and then we've got 1,640 people that we're paying for out of state? Or just flesh that out for me a little bit.
Madam Chairman, no. My understanding is that this is kind of the volume of beds that are located out of state by provider. So the funding for that would be on a case-by-case basis. And in the Medicaid world, again, it's based on the admission and the acuity and frankly, the agreement between the state and the provider of what that funding looks like. But I think as I understand your question, Madam Chairman, are we paying for fixed cost of 1,640 beds out of state? And the answer to that would be no.
And so just to make sure, and I might have to drill into this a little bit more later, make sure I understand, but so these are bed days. In other words, we might have paid for 1,600, so that could be 5 people for a year each, or something like that, or does that make sense?
It does make sense, but again, I believe these are the total number of beds, just static beds that are located in state and out of state, not necessarily bed days. And again, not what the state, either in Medicaid, DFS, or behavioral health, have paid for on a fixed cost basis. That's not how the funding works.
Okay, well, I won't drill. We might have to dig into this a little bit more later, but go ahead.
Absolutely, Madam Chairman. Like I said, happy to, as the committee has reviewed these or reviews them in the coming days and weeks, happy to answer any questions or have a targeted discussion offline. So again, Madam Chairman, the same kind of data here mapped out that we thought would be helpful, just visually speaking. Again, no judgment calls here, or really policy conclusions. There's just some resources that there is more densely provided in the state, and some resources that aren't very prevalent in the state of Wyoming. And again, that's policy conclusions there could vary depending on the problem that you're talking about. And then similarly for the out-of-state behavioral health providers with PRTFs and residential treatment centers, again, just a visual depiction of the bed supply.
Okay, is that the end?
Madam Chairman, that is the end, but I do want to kick it over to either Director Schmidt or Lindsay Schilling, because I know I raced through that faster than I've ever raced through a mental health presentation with this committee, which I'm sure you'll be delighted with. But I know we did really appreciate working with DFS both last year and this year to compile this data, and it would be very remiss if I concluded the presentation without their feedback, and I'm happy to navigate to any slides that they would like me to.
Okay, so let's hold off our questions until we can hear from all the other folks on this particular slide deck so that we can group it. Okay, go ahead.
Thank you, Madam Chair. This is Lindsay Schilling with the Department of Family Services. And Stefan, if you could go back to slide 32. Thank you. I wanted to take an opportunity this afternoon just to hijack a few minutes of your time and provide a bit of narrative related to slide 32. We think it's an important narrative that's masked a bit by the numbers you see on this slide. So from DFS's perspective, the numbers represented on this slide are simply a count of the number of licensed beds that exist in state and out of state. We have a strong collaborative relationship with our provider network, with our group homes, with our residential treatment centers, and through Medicaid with our psychiatric residential treatment facilities. Our teams also work closely with Medicaid and their utilization management teams when there's been a need for a higher level of care for children known by DFS and children that we support both in a prevention case and a out-of-home placement case. Despite the availability of beds and the partnerships that we've created, there is still a significant gap in the availability of therapeutically appropriate placement services for a very specific cohort of youth. So what we're seeing is that access to services, despite the available beds, has not been impacted by coverage policies or limitations of payers or reimbursement rates themselves. But what we are encountering are barriers that result from a provider network that lacks the therapeutic modalities and infrastructure to provide high acuity inpatient psychiatric services to this specific cohort of youth. For a bit of data behind that, in the last 12 months, we have worked to support 9 youth with significant psychiatric and mental health treatment needs. We understand 9 children certainly isn't representative of a majority of our caseload, but these cases routinely consume a disproportionate share of internal resources, both for our agency staff and other system partners. I think what troubles most of us is the increasing number of these complex cases that we're encountering year over year. So despite the broad commitment by everyone to assist these families, the outcomes have not been good. Of these 9 challenging placement cases that DFS has supported in the last 12 months, 6 of them were CHINS cases. So these are children in need of supervision cases. These are situations in which parents and families through legal processes have sought our help to find treatment for children. 2 were prevention cases, again, situations where families elected to work voluntarily with us to find appropriate treatment. Only 1 of the 9 cases was a protective custody case. Interesting, what these children all had in common were severe and in most cases untreated and unmanaged mental health conditions, aggressive and dangerous homicidal and suicidal behaviors, combined with a mild to severe intellectual or developmental disability that was evidenced by lower than average IQs. So despite our willingness to negotiate enhanced rates or efforts to partner with Medicaid for case-specific funding, each of these children were denied admission by all inpatient mental health treatment facilities in the state of Wyoming. For this cohort of children, that averaged 18 facility denials of in-state facilities. And so when we reference in-state facilities, we're talking about our Board of Cooperative Education Service Providers, general hospitals with psychiatric beds, psychiatric hospitals, residential treatment centers, and PRTFs. Each of these children then went on to average 5 to 10 out-of-state facility denials based on acuity and the facility's inability to manage the high level of service need of these youth. In several of these cases, as youth awaited placement, they acted out, resulting in a delinquency petition. So that moved them from a therapeutic treatment track to a juvenile detention track. After supporting these 9 cases and exhausting all identified inpatient options, less than half of them were ever admitted for treatment. 2 of them were sent home or remained at home with robust safety plans in the absence of other options, and 3 ended up in long-term detention settings. So we just wanted to provide this little bit of information. While existing public and private provider networks are capable of serving the majority of youth that we work with, there continues to be a growing cohort of youth whose needs consistently exceed the treatment capacity of our current system. So whether highlighting these cases leads to a broad system support of providers who are interested in building out programs and capacity to support these cohorts of kids, or whether there's a broader interest of system partners to consider creating some kind of inpatient psychiatric safety net option for Wyoming youth. I really felt compelled on behalf of DFS and on behalf of these 9 families to call attention to a group of kids and a group of families that as a system, we've been unable to help. So I would just ask that as your committee work focused on the adolescent mental health continuum of care moves forward and opportunities become available for candid conversations about ways we can better support these youth and families, I would certainly like to be sure DFS can be at that table with you.
Questions for Ms. Schilling? So Lindsay, I do have a question. In your assessment or experience, is the problem something unique to Wyoming because we lack providers or payment to encourage providers to serve this category of patient, or is everybody basically in America having problem addressing these complex kids?
Madam Chairman, I don't think the issue is specific to Wyoming. I think we're seeing the same types of challenges with out-of-state facilities accepting some of these more challenging youth. I can't speak to why we're seeing an increase in this particular combination of psychiatric and intellectual disability population, but I know at least from the Department of Family Services side, we just don't have access to an appropriate system to help these families get treatment.
Senator Schuler.
Thank you, Madam Chairman. Yeah, I have some real heartburn with this whole issue, and I understand your pain, and I see these kids, all over the area. As a former teacher, I can see an increase in these kinds of kids that are increasingly becoming, more violent and more difficult to deal with. I guess my question is, many years ago, the state mental hospital here in Evanston had a youth section where they treated some of the worst of the worst, and it went away. I've asked the question many, many times, why don't we have it? And I hear questions answers that don't really appease me, like, oh, we just can't staff, these folks. Well, we need to, because I've got to believe that when we move kids out of state, these out of state placements, it's costing the state probably twice as much, if not 3 times more money, to put them in these out of state beds. And I hear the same thing from the school districts when they have to place a student outside the state. It's the amount of money we spend is outrageous. And so I would hope that this is something that we can take on, not only our Labor and Health Committee, but even the Department of Health, and see if we can't come up with some kind of answers for these kind of kids, because I just don't think what we're doing right now is meeting the needs of our constituents. Thank you, Madam Chairman.
Representative Clem.
Thank you, Madam Chairman. Appreciate that. And so let me ask, as far as some of these ones who move from, say, a CHINS or protective custody case to a delinquency, I've been around many of these types of kids, and it seems that's kind of almost a workaround, because we don't have the facilities to treat or to help treat these individuals, these kids. And it seems that the alternative then is a delinquency case, because then they qualify for the boys' school or girls' school, and then they end up in there for a little while, or potentially jail or some kind of juvenile detention. And it almost seems, it's almost as if the system is it's not designed to be that way, but it promotes that, because it seems that that's the cheaper route to go than to send a child out of state in a PRTF where it's very, very expensive. So I guess I appreciate the information. I guess I'm looking for maybe some idea of how do we fix it, or not incentivize this idea of, we can just transfer over to a delinquency and now they qualify for boys school or girls school, and that's the cheaper way to go. I hope that makes sense. Hope you follow me, and looking for some suggestions. Thank you.
Ms. Schilling.
Madam Chairman, so I think I just want to go back and be sure to reiterate that the challenges that we're seeing with this particular cohort have nothing to do with how expensive services are. We simply can't find a provider willing to take a child based on the severity of their symptoms. So typically what we're seeing is while we're trying to find services, going through the clinical reviews, going through the admission criteria, with these unmanaged psychiatric conditions, the children act out in some sort of delinquent fashion, and then are in trouble in different ways. I think we've had a lot of really good conversations with St. Joe's. We've had a lot of really good conversations with Yes House, good conversations with WBI. If there were interest, I think, in our private provider network to develop these types of services in state, I don't think we would have any issue, finding ways to partner with them on reimbursement to try and make that happen. So I think those are conversations that have certainly started, but it doesn't help the situations that we find ourselves in currently.
Chairman Scott. I can't hear you, Chairman Scott. Are you there?
Yeah, Madam Chairman, just simply trying to figure out with the screen partially occupied how I unmuted. The question I have is, if my memory serves me correctly, a bit over a year, maybe now a year and a half ago, WBI dropped some of its adolescent beds, and the explanation they gave the local legislative delegation was the state was simply not paying enough, and they had to go to a more profitable use of those beds. Is that an accurate description of what happened, and which of these populations did that affect? Did that affect your very severe complex cases, or was that the ones that were going, did it affect the larger group going into the PRTF world?
Ms. Schilling.
Madam Chair, I think I heard that somebody from WBI was on, so I can't speak to kind of their business models, but the situations we're up against right now, the feedback we're receiving from WBI is the denials are being upheld, not because there isn't bed space, but because they lack the therapeutic supervision and the bricks and mortar safety precautions that would have to be in place to take some of these really aggressive children.
There was a hand. Oh, here we are. Representative Stivar.
Thank you, Madam Chairman. Do you think it's part of the problem is the way some of the rules have been changed over the last few years?
Ms. Schilling.
Madam Chair, for clarification, rules specific to what?
All right, I happen to have a young man that's been in the same boat. He's dual diagnosed, developmental and other problems. And I know he was denied by every place in the state of Wyoming, and I had to send him out of state every time because nobody would take him. And it was insurance paid. He kind of flew under your guys' radar. But the rules changed, the rules have changed of isolation, that kind of stuff. Do you think that's part of the problem?
Oh, so Representative Stiver, just for clarification, you mean different requirements
I
on,
believe it's Chapter 45 rules through Department of Health. I think they're the rules. I got to go look real quick.
but on the way you're able to manage someone's behavior with isolation or restraints or that kind of thing? Is that what you're referring to?
That's what I'm referring to.
Does that help, Ms. Schilling?
It does, and I don't think I can answer that question. I think if there's somebody from WBI or St. Joe's or another psychiatric facility, they'd be best positioned to respond.
Okay, well, we'll hear from them later. Any more questions for Ms. Schilling? Okay, thank you. That's been very useful. I'm sure we may call you back. You never know. You may not have escaped to your dinner just yet. Elizabeth, who have we got next?
Ma'am, I believe you do have Emily with WBI on as the next presenter.
Perfect timing.
Madam Chair, can you see me?
Well, we see a nice black rectangle with a yellow edge.
How about this?
And now I see a different black rectangle. I feel like I'm at the optometrist.
Well, I'll go ahead. I have with me WBI CEO Mike Phillips. We can't social distance and be heard and wear a mask at the same time, so I'm not letting him be in the picture. But we had a prepared set of remarks, but you guys have been working really hard all day, and we appreciate your efforts to look at all of these subjects. If there's anything specific you'd like to address, I can tell you that the PRTF bed capacity on the Department of Health presentation is slightly inflated. I believe those are licensed numbers, but actual capacity is significantly less than that. And truthfully, the available capacity for PRTF beds is not currently being utilized. Both St. Joe's and WBI have beds available and have had beds available, at least since the beginning of the year. So I would say WBI has 34 beds and St. Joe's runs, they told me yesterday, they like to keep their census around 52. So that said, I think both organizations would be interested in a conversation around how to meet the needs of some of these difficult to treat youth. And it's a conundrum because these youth can damage property significantly. They can harm staff. They can elope. They can run away. And it's a concern about how you treat someone in a medical framework and yet have expectations for behavior change. So we definitely can have those conversations. We have continued to try to meet the needs for state hospital committed youth. There have been a few this year, but they tend to be that very population that's lower functioning and have been labeled with a lower IQ as well as mental health and behavioral issues. So we don't have a contract with the state hospital. There's a misunderstanding that the state hospital has contracted with WBI to be the state hospital for youth. That's a misnomer, but we do accept as many state hospital patients as we can manage based on staffing, the capacity to do a one-on-one, and our ability to meet the treatment needs of that individual. And I'll stop there.
So I'm sorry, what was your name again?
Emily Ganoff, Wyoming Behavioral Institute.
Okay, so what I hear you saying is that with you folks, and as much as you can speak for St. Joseph, you have actual bed space for human beings, but you perhaps do not have the staff or the structure that is able to care for these particularly challenging acute dual diagnosed children. Did I take that correctly?
Yes.
And so would you say that what you need in order to put the child into that bed would be either more staff or remodeled facilities? I mean, would those things help?
Madam Chairman, this is Mike Phillips from WBI. Committee members, thank you for taking the time to visit with us this afternoon. There's lots of issues when you deal with some of those more complex patients. For instance, let's just take autism as one. It requires a specific program and specific space to be able to really adequately treat those patients. And introducing that patient into a milieu that's not specifically designed for that doesn't necessarily benefit the patient, and it can affect the internal workings of the other patients that are on that same milieu. So when we look at some of these more complex cases, behavior duly diagnosed with autism or MRDD or any of those kinds of things, there are special programs in the country that have the bed capacity and the space to be able to manage that from where we sit with our PRTF, and I'm not speaking for St. Joe's, but I've toured that. It's very difficult to work a patient like that into a milieu with other patients that are not similar. And it's difficult to create a specific program for a patient or two patients over the course of a year, you know what I mean? So space is an issue, certainly staffing is an issue, but largely it's programmatic offerings for those more complex behavior patients.
So in some ways, actually, the problem is similar to what we have in physical health, is that we haven't got the patient volume, say, to provide a pediatric nephrologist or something like that in the state. Is that part of it?
Yeah, in some cases, and it's not that we couldn't provide some immediate acute stabilization, but for longer term treatment, we just don't have the program dedicated to be able to serve those patients.
Do you have any responses to Representative Stivar's question about the change in regulation as far as how one can manage behaviors that, perhaps 20 years ago had different things allowed?
Certainly, federal regulations always impact your ability or the manner in which you're able to deal with more difficult behaviors. So I would say there certainly are impactful changes that occur all the time.
Representative Sweeney.
Thank you, Madam Chairman. So I'm a little confused on the adolescent side. I thought the state did have a contract for those referrals because the adolescents weren't able to be taken care of by the Wyoming State Hospital in Evanston. So what I'm hearing, Emily, is that you're not under contract, and correct me if I'm wrong. I'm missing something here.
Emily or Mike?
Madam Chair, Representative Sweeney, to my knowledge, there is no contract with the state hospital that's in effect at this time. There was an older contract, but that had long ago expired, and we've not had a conversation about a new contract.
Let's just break here for a second and clarify with Stefan, seeing as his name is still up there anyway. Stefan, can you clarify this?
Madam Chairman, yes, it's correct that there is no specific contract for adolescent psych services between the Department of Health and WBI. Just to clarify a little bit, though, when we talk about Medicaid children who are Medicaid eligible and in need of inpatient psychiatric services from a provider that would accept them, it's very similar, in fact, identical to how Medicaid provision and reimbursement works with every other provider, where if you are an enrolled Medicaid provider and meet those conditions, then you're essentially quote unquote contracted with Medicaid and the Department of Health. So it's not a specific contract with the state hospital or with the Department of Health for adolescent psych, but WBI is a Medicaid provider of adolescent psych services. The other question that has come up twice now is, did the state hospital used to care for children? And the answer is yes. The state hospital has since evolved into primarily a Title 25 and a Title 7 facility. So civilly committed adult patients and forensic evaluations and inpatient services for either pretrial detainees or other forensic or criminal clients that need mental health services or evaluations. There is certainly not an opposition in concept to having a youth wing, so to speak, at the state hospital. But Senator Schuler, to your point, and I know it's frustrating, we don't have currently the expertise similar to what WBI is mentioning, developed in that area to adequately provide that service. And as you know, our capacity for the past several years for Title 25 and Title 7 has been strained. We have wait lists on both services, and we hope to dramatically improve that with the opening of the new facility in Evanston that will happen later this summer. To really markedly improve the wait list and the service provision at the state hospital. But Madam Chairman, if I may, and I really don't mean to get on a soapbox here, but this is very similar to the conversation the legislature had about the two facilities, the state hospital and the Life Resource Center several years ago, that resulted in a task force, which is the fruits of that are now being seen with buildings coming out of the ground in Evanston and Lander, as well as new missions for both facilities. The reason I bring that up is because there's currently no Department of Health facility that's missioned to what Ms. Schilling at DFS was talking about as a safety net provider for certain types of adolescent psychiatric clients or certain types of adolescents that have certain psychiatric needs. That does not exist. And I think this conversation that we've had, especially over the past couple of years, might warrant the resurgence of that conversation, but specific to adolescents and children. And I know it's a difficult time right now to be thinking about additional services, especially facility-based services in the state as we face some uncertain revenue environments. But that really was a good model with the Facilities Task Force to decide what is the role of the state when it comes to providing facility-based care for certain types of individuals, in this case with the state hospital and the Life Resource Center, adult clients. And I think we're seeing the fruit really be born from those projects. So it's a little bit more complicated than just having a contract with an entity that will provide adolescent psychiatric services. And as WBI, Emily, and Mike were just testifying to, it's a money problem in many cases, but it's also it's a treatment modality issue if you have the certain expertise. Ms. Schilling will tell you, as our folks in Medicaid would, that even when we offer to out-of-state facilities that do potentially have additional treatment programs or expertise, when we offer or work to have enhanced rates, extraordinary care rates, et cetera, we often still get denials for some of these adolescent clients that really do have your more severe and your most severe comorbidities and problems. So it certainly doesn't represent the majority of the clients that we're facing, that this is a huge systemic problem, but it's large enough of a problem for these handful of cases where it really is just the hardest to treat clients that probably warrants, Madam Chairman, if I may be so bold, with the mental health topics that have been assigned to this committee, the Appropriations Committee, and the working group between the two committees, a really thorough look at the adolescent population specifically. Thank you.
So thank you, Stefan. So with the Facilities Task Force and just the changes in what we're doing with Evanston and Lander, and kind of the reconstruction of the Lander facility, there's been a little bit of discussion that there might be room on the Lander campus to set up some sort of a unit, and this number was not suggested to me, I just pulling it out of the air, but it sounds like maybe like 10 beds would do us, maybe even fewer, but they're probably fairly long-term people, I don't know. have you folks thought about that? Do you think that what we have built or what, I mean, certainly there's land, but what's the potential at the Lander facility for housing something like this?
Madam Chairman, it's a good question. To answer it initially, yes, we have thought about that, especially as we make plans at both campuses in Life Resource Center at Lander and at Evanston for building demolition in the coming years of the old campus of what could potentially be repurposed. So there's certainly physical space potentially available at Lander and as you mentioned, other places around the state as well. What it comes down to is, in my opinion, is mission and expertise and staffing. So it's really, what is the purpose of doing that? What is the state setting up the Department of Health to take on? And I think that needs to be a deliberate approach, very similar to the populations that were defined with the facilities task force, as opposed to here's an adolescent psych facility with very broad admission requirements, because then the state really starts to have some mission creep when it comes to the types of patients that are being sought to admit there. And so if you'll recall from the facilities task force, it was really geared towards those adult clients where the private sector, either nursing homes or other types of facilities, either cannot or will not admit clients of that type of nature. And so those were defined and put into statute. And I think that would be step number one, to have the legislature and the executive branch go through that exercise to determine, who are the clients that we're talking about, how many of them do we think there are in a given year, and what types of conditions, what types of comorbidities really describe or define that population. And then secondly, Madam Chairman, as I mentioned, is the financial and the resource question of how do you staff that? How do you resource it? Is it existing space? Is it new space? Is it repurposed space?
So I've written those down, and then I'll call on. I see Representative Clem has his hand up, but I'm just in my own head, I'm thinking that certainly the resource discussion is very difficult. But on the other hand, if some half of these kids are having to be sent to their home, and frankly they're potentially homicidal, that's not a very good situation. Representative Clem.
Yes, thank you, Madam Chairman. So thinking about this, I guess I struggle as far as the state would have to do as far as developing a new program or putting the infrastructure, or even private entities doing some of those things. And I don't know how sustainable that would be for such a small population. I guess that's part of the hangup of where this comes in. But I think, the other side of all of this is the whole idea of prevention, to prevent some of these hard cases from developing from, even to begin with. And kind of circling back to the conversation that we had last year, it didn't really go anywhere, but, and what I'm hearing from the providers as well, right? We've got some PRTF beds that aren't being utilized. I'm sure that's the same also with RTCs and group home beds as well. So how do we utilize those beds to their most efficient capacity, and treat kids, I guess, to the highest level as we possibly can? And I think where we fall short is, again, looking at how we utilize these beds, right? Particularly for group home and RTC beds, we use Medicaid, that's it. Part of our issue is they don't accept private insurance. Now, I think that's different for PRTF, so I can't really speak to them. But I think one of those things that we need to look at is how do we treat kids who have various types of insurance? There's a gap there, I guess, is what I'm trying to say. And if we can close that gap and so that we are treating kids, so that we don't have to wait until the problems compound, and now we're at this, this pinnacle here where we don't know what to do. The earlier you treat a young person, the better. And I'm just looking at some of the roadblocks there. So at least in my mind, and this is great discussion, and I'm going to be quiet here, not to bog things down, but I really do think we need to circle back and see where those gaps are in existing resources versus, we've got this very hard to place population, and what do? Do we develop a whole new program, and is that sustainable over time? I don't know that. In the meantime, we have gaps right now that are existing in our services that we haven't addressed. And I think we need to look at that seriously.
Thanks. So committee, we're doing well here, although we still have an entire another topic. So obviously this topic is much too large to resolve or even, but it sounds like one thing I think I'm hearing between the initial discussion, Ms. Schilling and Representative Clem's comments. So, we've got this little joint subcommittee thing between JAC and Labor, which is going to really what they're looking at, from what I hear from leadership on that, is kind of the structure of the block grant to the community mental health programming. I think that's where that's going. But as part of that, I really designed for my own thought process a sort of a flow chart, starting from a person. Here's a person, and then just, okay, what do they access? What do they need? Where might they go? A kind of a visual aid to this. So what I think maybe we need to get, and I don't know, I may spin off a couple of legislators to talk to a couple of the folks, but what I feel like it would help us to have for maybe not a special session meeting, but the August meeting is kind of a flow chart of a child with some severe mental illness, but that is at home and could potentially, stay at home. But what happens to the child in essence? So they're in school, they're referred here, maybe in the private sector, they go here, they end up not at home. I mean, we need to understand, and that way, what my point is that way we could really say, okay, here are the holes, here are the gaps. So we need to really just kind of draw up, and the charts in Department of Health was good, but they were very numerical, and I think what we need is a little to bring in the facilities, the payment, and that would help us find the gaps. And I don't know, Department of Health and DFS, do you think you can work together to create something like that? Would you like a few legislative people to help you? What do you think? Because I think we need to work along with this a little more.
Madam
Steph.
Chairman, if I may, I would be more than happy to work with Lindsay or anybody else at DFS to prepare either this committee or the working group between the two committees, JAC and Joint Labor. Lindsay, her nickname around here is Benedict Arnold now. She used to be one of ours, and we have a good working relationship. So I'm happy to renew that working relationship and prepare something for this committee. Like I mentioned, it's something that we have a model for in terms of what is the best analysis to inform this type of decision and inform this type of exercise, like you were mentioning, Madam Chairman, to determine what that type of client looks like in a flow chart, and in addition to that, what their volume and density is across the state. And to Representative Clem's point about scale, he's absolutely right. If there's 9 clients or 10 clients in a given month or over the course of a year that really are the ones that are slipping through the cracks of the traditional financing and coverage systems, then it really is that conversation about does the state and should the state and how does the state act as a safety net for those types of patients or those types of adolescents. So I think we can certainly put something together. I will put a brief caveat on that. The timing will be crucial. We'll put as many resources as we can behind it. But just to remind the committee, we're also managing the statewide pandemic. So we will put resources behind it, but just probably can't turn something like that around in the next 2 weeks.
Well, Chairman Scott, would you object if I detailed Senator Schuler along with Representative Clem to kind of help Stefan and Lindsay brainstorm, just so that because from their background, maybe a little bit on the outside of this agency system, but it sounds useful, they might be able to produce something that they could turn into legislator ease for us a little bit. Would you object if I did that, Chairman Scott?
No, I wouldn't object to something like that. I do suspect here that we're talking about a couple separate problems. One of them being some very severe individuals where, like in the physical health, there's certain things we just don't have the volume to be able to treat in state. And we're always going to have to send out of state. And that may be a money talks issue, which is a nasty problem to have given our budget situation. And then I think there's a much larger group we can treat in the state, but some of those DFS figures suggest to me we're sending a lot of them out of state when maybe we don't need to. So I think there's several different problems. And I have a suspicion that one of our problems is that the experts and the legislators aren't effectively communicating and aren't understanding each other and are getting confused between those two populations and are having trouble identifying what the problems we're really trying to solve are. So this is going to be a nasty long-term problem for us, I think.
Well, good. So we'll send.
I think detailing a couple legislators help get us started with is going to be useful, but we do have to be sensitive to the demands that COVID is placing on everybody right now. And this may take longer than we would have otherwise anticipated.
I understand that, and that's reasonable. But on the other hand, a journey of 1,000 miles starts with a single step, or whatever that saying is. And
I think that's probably a good first step.
Senator Schuler, if you don't mind me assigning you, and Representative Clem, just because the two of you have some base knowledge, just start emailing Stefan and Lindsay, and I just feel like we'll make better progress at the August meeting if we have gotten things a little bit more pinned down, because otherwise, I don't want us to just keep flailing for years. That's not a good thing. Okay, thank you. Let's see. We heard from Department of Health. We heard from WPBI. Is there anybody else that wants to testify on the mental health issue? Probably some.
Madam Chairman, we do have a few public testimony folks. I don't know if there's any other agencies that want to testify.
Oh yes. Do we have anybody else? Any other agency? Thanks for reminding me. Okay, public testimony. And folks, I don't know who all the public testifiers are, but just be alert that given how we're moving along, that we'll be much more attentive if you're not too long. So let in who the next person is. Let in the next suspect.
Ma'am,
look, it's Andy Somerville again.
Madam Chairman, thank you, and I will be brief because I don't want to stand between anybody and dinner at some point in time later this evening. So I just want to make a couple of quick comments on the two of the topics that you discussed. Just very quickly on the WICHE mental health worker program, we are very interested in that. WAMSAC is in a unique position in that we don't represent a particular professional trade organization. We employ all of these mental health professionals. And so we're always interested in how we can make that better, especially with coupling that with a continuing education piece to keep moving them up the ladder. So I just wanted to express our interest in that. We think that could be great. And then second, I will just do a quick rundown, not too in-depth on some of the data that was presented by the Department of Health originally on the mental health and substance abuse centers. And I just wanted to say, I understand that we'll be working with the Joint Committee on more detailed information on the block grant, but I just wanted to give you guys a quick snippet to let you know kind of what we're trying to pull together for information on that. Chairman Wilson, you had asked a question on how much of our priority population are our clients. And I think we can pull the precise numbers for you, but the percentage is high. To be very honest, on our state contract, the priority populations are quite high. And then on DOC, the DOC population, which is not currently a priority population on the state contract, the percentage of clients that are DOC involved is also quite high. In some cases in our centers, it can be 60, 70% of their clientele are somehow DOC involved. So I know that conversation is ongoing as well. On the data slides, there was a slide. Let's see if I can find the number here for you real quick. Pegging insurance rates with the EGI, assuming that all their private insurance companies pay the same. My providers, my centers have told me that that is not the case. In fact, the state's policy is generous compared to most of the other insurance companies that they work with. We appreciate the Department of Health's first stab at that data. I think this is the first time that we've actually kind of dived into that private payer piece of it. And then lastly, I'm just going to share my screen here with you real quick to give you a snapshot. And I think that you guys, I sent this to LSO, so you should probably have it in email as well. So this is just pull that up here. This is a quick snapshot of a medium-sized community mental health center. And so they broke out data for me for almost this entire fiscal year 20. We're not quite done with it, but you can see in box number 1, it gives you an idea of the income sources for that medium-sized center. And you can see by far the state contract is the largest percentage of their budget. There's also some federal dollars, tobacco funds, some separate state contracts like Gatekeeper and DOC contracts as well. And then down here, this $100,000 that they listed is 3% of their budget. That's the client share of the sliding scale fee that comes with the state contract. And then in box number 2, they broke out really what we wanted to highlight was the percentage that our centers are not collecting on some of these sources. And so here on line number 1, private insurance, their average service payment is $37 when they get done. They expected almost 700,000. They only got 170. So you can see they've got a 75% unreimbursed. Now that includes both claim denials and deductibles and copays, which is a pretty big issue for the clients that our centers see most of the time. As we've notated down below, just because you have health insurance, which I think was in the Department of Health presentation, they might have it, but it's really only good for them in catastrophic events. They simply can't afford the $3,000, $4,000, $5,000 deductibles that come with that. And so because of the nature of some of the clients there, the centers can't collect that money. And so in this box, and you can take a look at it in more detail, and I'm happy to answer any questions on it. It just kind of breaks that down. You'll see that insurance by far is the most unreimbursed category, but there's also some issues with Medicaid and Medicare, which has to do with staffing issues. So we just wanted to give you that snapshot. And then I wanted to just highlight again on the state contract for our mental health services, this client sliding fee scale. The average payment that they get from one of those clients is only $14 when they can even collect it. And so you'll see again, the clients are participating, but it's not a substantial amount, and it's certainly not a substantial amount of revenue there. And so with that, I would certainly stand for any questions on this. Again, this was just meant to be a quick snapshot as we start to dive kind of more into data and the block grant and working with the joint committee with JAC. So with that, I will stand for any questions.
That is a pretty painful slide.
That's just one of.
I'm glad I'm not the CFO of that place. Okay, any questions for Ms. Somerville? Okay, and you emailed that to us?
Yes,
Okay,
LSO
great.
has that, and I can re-email that to the whole committee as well.
That would be super. Thank you
Okay.
so much.
Thank you, Madam Chairman.
Okay, Elizabeth, who's next?
Ma'am, I believe Ramsey Scott is available. And
Okay.
then as for Andy, I have already sent that to the committee.
All right.
Thank you so
Ramsey,
much.
You were on briefly and you went away into your black box. Oh, there you are. Mr. Scott, welcome.
Try that now. Okay. I completely lost where I was, where we are. So I'm not too sure if we're talking about topics for the next meeting or not. That's what I had signed up for. So I figured I'd check to see where we are before I waste everyone's time.
So we're actually still on the mental health topic.
I am waiting for that. So I think they popped me up a little too fast in the queue and surprised me with the video. So I'll just step back and let y'all continue.
Okay, we'll let you come back in a little bit.
Sounds great.
Who is next?
Ma'am, I believe that is all we had for public testimony for the mental health topic.
Oh, well, actually that isn't up. I misspoke to Ramsey Scott. We have to still circle back to telehealth. Okay, so that's the end of that topic. I don't know if we felt like we got anywhere, but I hopefully at least know a little bit more and can take some further steps. And let's pick up the telehealth network, which I understand that Dr. Bush had to depart, but hopefully Elizabeth and the Department of Health and UW have rounded up someone to show us his slide deck, I hope. Where are we at?
Ma'am, because Stefan had to leave, there was no one else I could see in the waiting room that was from health who was willing to present. We do have individuals from the Business Council and the university.
Well, let's let the university take a stab at it. They're involved. Their lucky day. I see Sandra Root Elledge on my screen. Oh. I don't know if it's you or who's going to try. Oh, and Dean Jones. Hello, how nice. Who wants to try to explain the telehealth network slide deck to us?
And
Or
should have Canyon Hardesty.
Kenyon. Elizabeth, do we have Kenyon Hardesty?
I do not see her in the waiting room unless she is under the name Quinn, and in which case that may be.
Oh, that could be. She had gotten disconnected at one point.
Oh, here comes Quinn. Well, my apologies to you folks waiting so many hours to tell us about telehealth, but I guess we bit off a little more than we could chew.
Well, Madam Chairman, we appreciate.
Small when I made the agenda.
Madam Chairman, we appreciate being included in the agenda.
Is that Canyon?
Yes, this is she, Madam Chair. I'll change my name too. Apparently it's my daughter's. I'll go ahead and pull up the slide deck that the Department of Health had put together, and in the process talk a little bit about I guess the telehealth network, or maybe Dr. Jones, if you would want to introduce yourself, and then will I pull those pieces up for individuals to reference.
Okay, I can do that, Madam Chair, while we're.
Jones, go ahead.
Yeah, first of all, thanks for giving us the opportunity to speak with the committee today. This is really something that we have been, well, the Wyoming Telehealth Network has been around for a while, but and we have been discussing bigger plans for the network over the last year or so, but obviously the pandemic and the necessity for building telehealth more quickly has certainly gotten us to kind of push this much higher in our list of priorities. But as we see it, this is an opportunity for us as the university to be, as a land-grant institution, to be able to serve the state, to build on this network such that I think ultimately our goal would be for any provider in the state of Wyoming who wants to use telemedicine should be able to link into the Wyoming Telehealth Network to be able to provide services. And I think that's where we're going with this. This is where we want to go with this. And Canyon, if you're ready.
Yeah, I'm still having a little bit of trouble pulling up the slides. I mean, we created them in collaboration with the Department of Health, but I can talk through some key talking points. I know that you guys have copies of these slides, if that's better. Can be pretty quick. Is that okay, Madam Chair?
members, I think we actually received them in our packet, or they might even be on our on the online. Is that right?
I'm downloading them. It's just going to take me a second. I apologize. I'm not
Kenyon,
normally this unprepared.
If this is all right, I could provide a couple comments, Madam Chairman, if that's.
Go right ahead.
I'll just introduce myself. I'll just introduce myself. I'm Sandy Root Elledge. I'm the Executive Director of the Wyoming Institute for Disabilities. And as you could hear from Dr. Jones, we're in the College of Health Sciences at the university. I'm especially proud of the work of the Wyoming Telehealth Network and the significant progress in statewide coordination as a result of the efforts of our faculty and staff. WIND is especially successful in identifying and addressing state needs through leveraged partnerships. And this is very consistent with the Wyoming Telehealth Network as well. So we've been able to leverage partnerships and interests to address provider and patient needs in the state. So as Dr. Jones said, I believe we're well positioned, especially with the endorsement of the College of Health Sciences and University of Wyoming, to further expand and enhance the activities of the network. So I know Kenyon is prepared to talk about that, and I will leave that.
Okay, and very good. Oh, you've got it up here. Did you just put that up? Okay, good. We do have it in our packet of the meeting materials, members. So, but we'll let Kenyon. Here she goes.
Thank you, everyone, and I wish that others were here, but I know we have individuals who are joining us online that will hop in later to provide additional perspective and testimony as needed. So very quickly, we'll go through what is telehealth. I think that's critically important. And I'll step back and introduce myself. I'm Kenyon Hardesty. I'm the Director of Community Education and Training at the Wyoming Institute for Disabilities. So within the College of Health Sciences at the University of Wyoming. And we do hold the current contract with the Office of Rural Health, Wyoming Department of Health, to facilitate the telehealth network. And as both Sandy and Dr. Jones mentioned, this is a project that leverages additional funds and expertise throughout the college and university. So I do think it's a unique position for us to be in. And really our responsibility is a coordination of telehealth efforts across the state, which I think many of our partners have joined us online, and something that we will continue to see grow, hopefully in the infrastructure as well as, of course, the services are being delivered. So when we talk about telehealth, we're talking about several different pieces, right? When I think people think about telehealth, initially they think directly patient and provider interaction. That is one component of telehealth, but definitely in general, telehealth encompasses both direct service delivery as well as patient and professional education. As well as this larger issue of public health and overall health administration. So if we think about the utilization of technology for the purposes of improving individual patient care as well as system healthcare approaches. One of the things that we want to make sure, and I think everybody is aware, is that there was a Wyoming Telehealth Consortium that was created in 2009, really to promote telehealth. It was initially funded at that point in time, I think through some substance and tobacco settlement funds, but then in 2017, we lost that funding. So it's still something that we're required to do, but however, currently it is not funded and has been funded, as we said before, through the Office of Rural Health, Wyoming Department of Health, Office of Medicaid, and then leveraged funds through the College of Health Sciences. I think what's critically important to recommend here is that when we talk about the Telehealth Consortium, which is what is legislatively mandated, and we talk about the telehealth network, we're not talking about physical, virtual infrastructure. We're talking about coordination of key partners who are all working to improve services. So think about it as if you could think about it as an actual physical building where all, pieces and parts of interdisciplinary teams and programs are working together to improve practices, that's how you should maybe be thinking about the telehealth network, and specifically then the telehealth consortium, which is what the network comes out of. So the telehealth consortium, as it's mandated, includes the Department of Health, as well as Enterprise Technology Services, or ETS, and then the University of Wyoming, as it relates to the contract for the telehealth network, and then critical partners who are conducting direct services, as well as advocacy and education. Those include Broadband Council. I believe that there are some members here that have joined us from there. Wyoming Hospitals, of course. Key partners at the medical associations, primary care associations, Wyoming Medical Society, all of those individuals, again, who are dedicated to improving health, but may play different roles than direct service delivery. So within the consortium, these key partners participate. We meet on a monthly basis, really, to coordinate efforts. Additionally, what's listed on the slide here is the Board of Medicine, all of the other licensing boards. And then critically important, and I think others have joined us, are really talking about the telehealth champions in the state. This work has been going on for over a decade, if not more, and would not have been able to happen if we didn't have private as well as public healthcare providers pushing telehealth. Again, we've become very familiar with it in the last 8 weeks, but it's definitely something that's been going on and supported in the state for quite some time. And lastly, on their healthcare quality improvement organizations, whether that's regionally located with maybe Mountain Pacific Quality, or other organizations that might support. So again, thinking about that the consortium was legislatively mandated, and it is something that continues to function for the purposes of improving telehealth in Wyoming. When we look at the telehealth priorities in the state, and these come out of systemic conversations about what is needed to improve telehealth in Wyoming. A key part of that is really supporting the telehealth consortium. It's supporting the work that's already done, already being done in the state to support telehealth. And I think a lot of people, when they think about telehealth, again, think about the infrastructure and the provision. And one of the things that the consortium, through the collaboration with the university, we do provide Zoom plus healthcare, actual encrypted licenses. So to address that a little bit more, because I know there are some concerns about confidentiality, and I noted on the agenda that there were some cybersecurity issues. Zoom plus for healthcare is a HIPAA secure form of that video conferencing technology. We've had lots of checks and balances in those places, but a lot of the things individuals are hearing related to larger Zoom issues do not relate to the healthcare license or the Zoom plus healthcare license. Those Zoom licenses are available, although the Telehealth Consortium and the Wyoming Telehealth Network provide education about best practices across the spectrum of services and platforms. This has been a unique opportunity that has allowed the state to very quickly respond to the COVID pandemic. And I think we went from about 500 licenses that we were working with individuals on a regular basis to we currently have the capacity at about 5,000, but currently have about, I think, 2,200 of those being utilized across the state by private providers, mental health care providers. We have some breakdown if that additional data is needed. So that is a key priority, is continuing to provide support and infrastructure to continue the utilization of telehealth, not just today, but of course into the future. Additionally, ensuring that there are best practices. We have a responsibility to make sure that people just can't offer telehealth, but they also are doing it in line with best practices. Again, a wonderful way to collaborate with the University of Wyoming and other partners to bring those best practices. We want to make sure that we're providing ongoing education. Of course, provider policy and procedure implementation, so what telehealth looks like in local offices, and what those office flows looks like. We've had to retool pretty quickly for people to get up and running with that, and we want to make sure that those additional policies, procedures continue in the future, and again, are aligned with best practice. And then most importantly, we think is to make sure that with these collaborations, with the funding that are received, is that we make sure we're doing what we should be doing, right? We want to make sure that not only that telehealth, what we're promoting aligns with best practices, but that it also, we evaluate it and do research on it to ensure that we are meeting the needs of the communities that we serve. And again,
Kenyon, I'm going to interrupt here for a moment, and it could be that you have a later slide, but I just want to make sure. So, so I understand that the consortium, as initially in statute, was funded evidently through tobacco fund money, and that there is no funding now. So, does the consortium is really just the meeting of all those people in that list, I think, right? And so now we've got the telehealth network, and I would like to know where the funding for that comes in. And then looking at the Zoom Plus Healthcare licenses, are you through that funding just making these licenses available to whatever providers want them, or are you able to just purchase 5,000 of them and then you offer this presumed package price to the providers? And I guess that'll do me for now.
okay, I'll make sure that hopefully I address these pieces right. So the consortium, yes, is the meeting of the key partners. And then the telehealth network, the University of Wyoming, actually, this is the third contract that has supported the telehealth work. Previously, we've now supported that contract for about 6 years. And so there are several different funding sources, and I'll defer to the Department of Health to outline those specifically, but those fundings do come from several programs within the Department of Health. It is a later slide, I think, down the road that actually shows the total amount of the actual contract that we have. This is an updated, this is the contract we have for this current fiscal year. So that starts July 1. The current contract we have is less than this. But this contract that is listed here are the funds that come from the Department of Health. We have another, which is not included on here, and I would hope that I could report back on those exact numbers of the leveraged funds from the University of Wyoming that come into this. And Dr. Jones and Sandy can speak to this as well. But we were able to significantly leverage the University of Wyoming Zoom encrypted licenses as part of this. So initially, when we were only offering about 500 and working with individuals to actually utilize that video conferencing technology and then help them figure out what worked the best in their own facility. And eventually, for those facilities that wanted to use that video conferencing platform on their own, they could sure do that. In March, I think 14th, we spent a lot of different time working with the university because we had to go from 500 licenses, which were originally covered in the contract, to now over 5,000, which are not covered in the contract, but currently Dr. Jones and Sandy have done a wonderful job of getting the university to support that additional cost. It is a significant increase, as you can imagine, especially using the HIPAA secure license version of this, to go from 500 to over 2,000 over the course of 6 weeks.
And so do the providers then pay you for the license at some percentage, or is that just something they get by signing their name, or what?
Yeah, as it stands now, there is no charge for providers to receive those Zoom licenses. You're correct. Wyoming providers, to clarify that. Individuals have to be practicing and licensed in Wyoming to receive those.
Okay, and so the Zoom Plus Healthcare is that essentially like the Zoom that we're becoming familiar with, but HIPAA compliant?
Yeah.
And then encrypted in some way? It doesn't have, like, if you needed some sort of monitoring device hooked up to it, that's a separate thing, or?
Yeah, if there are other peripherals that need to be attached to the computer or to, other platforms, yeah, absolutely. But it's similar-ish to the Zoom that you receive.
And
Yeah.
can you tell me roughly how much an annual license for a Zoom normally would cost if a person just wanted one? Do you know?
Well, you have to enter a contract with Zoom. I will tell you that the current quote that we're being provided by Zoom is about $52 a license. That's just for one license for one provider. So I can follow back up, with individuals, but we are able to secure that lower rate because it's a bulk purchase on behalf of the entire state versus an individual provider. So I can get back to you guys with very specific numbers on what that looks like for an individual provider, but there's a significant cost savings to providers across the state.
Okay, I should let you go on there. I'm probably tying you. Go ahead.
Yeah.
Does someone else have, or I suppose there's more to go. Sorry, I interrupt you right in the middle. Carry on. No, I don't see any blue hands.
Okay, no blue hands. Perfect. So, I think I covered those, some of the key priorities, right, that come out of those
I do see a blue hand. I lied. Senator Pappas.
I just wanted to mention to you, I've been using Zoom for years and my license costs $150 a year. So that's what a single license costs.
Right, but yours is not HIPAA compliant.
Correct. So it would be even more for HIPAA compliant one for
right.
So we get a pretty good break.
Very good. Okay, go ahead, Kenyon.
Great. Yeah, so we went over the priorities quickly, and these continue to be the priorities, but definitely, we've fleshed those out in other ways about what that looks like with need for patient remote monitoring and some other pieces. These were our overarching key priorities. We can sure drill them down at a later time if you'd like. You'll see that with the current contract that we have, there are some key activities that are supported. Again, those monthly consortium meetings, a lot of best practices, education and outreach. We do monthly webinars, we do technical assistance calls. We have staff that spend significant amounts of time with providers, getting them up and running, with the provision of telehealth. One of the key things that's happened over the last couple of years is really a focus on specific task forces by discipline. So to get individuals together in the areas of behavioral and mental health, to talk about what individual barriers and challenges they're facing that telehealth can really help them overcome. So these were identified based off of state need, as well as, of course, interest in areas where we really felt like there could be significant improvement in access for our most vulnerable populations and populations in general across Wyoming. So we're working with the public health nursing offices. There's been some wonderful advocacy and education that's come out of our allied health group, which is made up of speech language pathologists and occupational therapists, physical therapists, and then some exciting work with the hospitals. Really, an opportunity to make sure that, again, everybody's on the same page with moving forward with what those best practices are. So the telehealth networks helps to support those. And then again, on-site training and technical assistance. Some of the key outputs, I mentioned these before, and kind of fitting given all the conversations that have been happening today about mental health and behavioral health. We do have a significant number of individuals who are involved in the telehealth network, who are offering behavioral and mental health services, which is critical, right? We talked about lots of needs for access here, and I think this is a true need in the state, obviously, and a wonderful opportunity to continue to support those providers doing such important work. We do have quite a few primary care providers, and I think in some additional materials that were provided through Katie to the committee indicated several kind of the numbers of additional specialties that participate in the network and receive licenses. You've seen here, bottom here, telehealth encounters. These are the number of clinical encounters that are happening. You can obviously see what happened in March, about 8,000 of those visits, and then up to pretty significant 28,000 telehealth clinical encounters, through this encrypted Zoom license. Which is significant. I mean, if people are receiving telehealth and their conditions can be supported through that modality and it's appropriate and they're safe and at home, hopefully we've achieved the goal. Lastly, I think there'll be continued conversations, we know, about broadband and other access. As we've been doing additional surveying, working with our other consortium partners, access for patients in rural areas based off of their connectivity is a significant issue. So I know one that's being talked about in many different areas, but that definitely is something we would like to see a continued conversations about in order to improve telehealth. You mentioned looking at, yes, Zoom provides that connection for us to join face-to-face, but also there's a significant need for peripherals, meaning connecting up a pulse oximeter or maybe a blood pressure cuff or those pieces, either directly into the technology or making sure the patients have access to that is something that we definitely are seeing as a huge need. And there's lots of opportunities, there's lots of innovation going on that I think that we can really tap into, but definitely something as more individuals are engaging in telehealth and to ensure that we're meeting those standards of care to make sure we have that. And I think a couple of our other partners may speak to this third bullet point is the need for increased provider and patient education. We talked about the importance of the network currently doing training on evidence-based practices, but definitely an additional need is to look at patient education, not only about the use of the technology, but also just about what a telehealth encounter looks like. And there's been some initiatives in the state to do some good education on that. And then lastly, and Dr. Jones, you may want to speak to this a little bit, is the looking at increasing some pre-service clinical education and practicum experiences for all the students, not just in the College of Health Sciences at the University of Wyoming, but really looking at how we can, from a telehealth network perspective, from an advocacy and an education perspective, make sure that the competencies that we know, that the best practices we know across the state and nation are integrated into our pre-service and our clinical education programs. Dr. Jones, did you have anything you might want to additionally mention on that?
Yeah, Chair, just that I agree completely. We have some of our divisions in the College of Health Sciences had already started to really integrate telehealth in their student training. Speech language pathology department, probably well into 2 years into doing this with their students. And we were probably one of the first graduate programs in the country that was really doing telemedicine quite a bit as part of our graduate student education. But obviously our other units will be doing this as well, nursing and social work. And our residency program really ratcheted it up quite a bit during March and April as well.
So Canyon, I have a question. Were any of you on back some hours ago when we talked about the Community Health Center grant potential for CARES Act money?
Madam Chairperson, we were on just at the very tail end of that conversation, but it sounds like a really exciting opportunity to meet some significant needs.
Well, so I'm just wondering, looking at this slide, whether the FQHCs, the family practice residency clinics, places like that, whether they might find it useful to purchase peripheral equipment, for doing, like you said, pulse oximeter, or I don't know that you could do ultrasound, but some, various things that they might have in their clinic and that perhaps they could loan out to clients, especially rural ones, for the winter months, so they have to drive in the snow or something? I mean, would that be something that would be useful, do you think, for rural and community clinics, a way to use funding?
Madam Chair, I could answer that. The Educational Health Center of Wyoming, which is an FQHC, we did receive funding from HRSA to be able to enhance any telemedicine services that we were providing. So we were able to purchase things like some pulse oximeters and blood pressure cuffs, and things like that, to be able to get out to our patients to be able to use. And I know that there was other funding that came along, I think, from Health and Human Services for the same purpose. And we have been using those funds to be able to enhance our services to those patients.
So we were looking at potentially having more funding. Do you think all the clinics that needed it got it already, or are there other clinics still that, I'm just looking at uses of that money?
Sure, Madam Chair, I would think there are probably still some needs around the state. And the amount we received, I think the first go around from HRSA, I think was about $62,000. So it wasn't a staggering amount. I mean, it was great. We were appreciative of it, and we were able to make some purchases with that. Obviously, I think there are probably other community health centers around the state that could benefit from some funding for that. Yeah.
Okay, just curious. Let's see, do we have more questions for Canyon or Dean Jones or Sandra, I think it was. I'm not seeing any blue hands. Everyone's having a sugar low. Can't push their blue hand anymore. Okay, well, I certainly appreciate you guys filling in for Dr. Bush's. I had one other question, and that was, I on my own, I have a little working group. We're kind of working with cybersecurity, and in talking with hospitals and clinics and whatnot. And this, I started off about 2 years ago. The ability of small clinics or hospitals or nursing homes to have good cybersecurity on their EHRs and that sort of thing seems a little bit challenging, because, if you've got one doc, one nurse, and a business office person, they may not really have the skill set to do good cybersecurity. I mean, probably no one's going to hack them, but even the smaller hospitals. So I'm wondering, and that doesn't frankly look like we're going to have any general fund money for this anytime soon, but and this would be outside of the Zoom Plus, because obviously that sounds like it's got its own, that has its own security systems. But I've been trying to consider a way to make, ETS or other IT type services available to healthcare providers for cybersecurity needs. Would you see yourself as having any potential role in something like that?
Madam Chair, I think to answer your questions, I think one of the pieces would be us to further understand what some of those issues are and the potential opportunity for, the telehealth network and our other champions, obviously, including ETS, to facilitate that. Without knowing kind of some of the issues that those small offices are facing, I definitely would hope that we would be part of those conversations and be able to bring in or identify expertise from in-state or out-of-state to help facilitate those conversations. But it's obviously critically important, but at this point in time, I'm lacking an eloquent answer. I apologize.
Well, I think it's the first time I brought it up to you. So just put that in your pocket and bring it out when you're lying awake at 2 a.m. sometime and you need something to think about. So I'll just let you stash that. Okay, were there more? We should probably move on because this has been a really good start for us to try to get our mind around this. Thank you all very much for putting up with waiting for this length of time. So Elizabeth, I think we have Ryan from Broadband Council here. Is he available?
He is in the room and should be available to speak.
Awesome. Ryan.
Hello. Well, hello, Chairman Wilson.
I
This
see
is
you.
Ryan.
Although it looks like you're being arrested or something in your photo. I
Oh,
can't
that could
tell.
be. Here we go.
Oh.
There you go. Reveal. I'm not at home, so we're testing the network abilities as we speak.
Oh, good for you. Well, you're coming through nice and clear from there.
Awesome. Thank you.
Where are you?
Honestly, I'm in Morrison, Colorado at the moment.
Oh, well,
So unfortunately, I'm on the wrong side of the border.
that's right. All right. Well, you'll have to explain yourself then, but go ahead, Ryan, tell us what you've been up to there.
Well, I just wanted to touch base and kind of give you guys what we've been working on in the in the broadband realm at the Business Council and with the Broadband Advisory Committee. I'm going to try and share here. Okay. Well, I apologize. This technology isn't as easy as I am used to as well. I'm working off of other technology besides my laptop at the time. I emailed earlier a PowerPoint to the committee, basically outlining what the Broadband Council has been working on and where we've started. The Broadband Council actually was started through legislation in 2018. But that by all means was not the beginning. The beginning was clear. It's actually unrecorded, but it started all the way back as far as I can find 10 years prior. So it's been an ongoing event. To start with, we were tasked with establishing the broadband plan. That was part of the 2018 legislation, which we have done and which was completed in 2018 and presented. That actually gives points to our providers, our broadband providers, to go out and apply for the federal grant funds from the FCC and the USDA. Just by completing that gives Wyoming a leg up of states that don't have that in place. So that's where this presentation starts. So to move on from there, the second page is just an introduction. We have 11 board members, 4 of which are standing board members. They're Patrick Lawson, he's with the Northern Arapaho Tribal Industries, Gordon Knopp or his representative, Representative Summers, and Senator Dockstader are standing on our board. We have 7 at-large members, which cover from the USDA to Cheyenne Regional Medical Center. We have 2 broadband providers on our board. We have a representative from AARP and Simplot out of Rock Springs. So it's a wide breadth of understanding on the broadband front. Outside of the overall committee, we have 4 subcommittees, and one of which is important here, is our telehealth subcommittee. It has been in existence since 2018 and is continuing on. Has 4 members on there, Mr. Tom Laycock, Mr. Randy Miller. Yes, thank you. Then let's see, Tyler Vasco is on there, and I believe Barbara Sessions is on there. It gives us a wide variety of expertise when it comes to broadband and telehealth, and when it comes to working with the Wyoming Telehealth Network as well. And definitely Randy places a lot of input into the group. Beyond that, we go to the education. The education subcommittee was develop information for the citizens, government providers, basically participating in discussions with the Department of Education, ETS, and others. It's not only the education for legislators, for our congressional delegation, for our providers, just trying to be that single point of contact for information on broadband in Wyoming. The third subcommittee is funding. We're constantly exploring potential funding opportunities for Wyoming broadband, both all the way from state to federal, local, and even freestanding input as far as broadband support. And then the final one, which also plays issue into all of broadband, is the known barriers. That committee actually works to identify the barriers to broadband development across Wyoming and to provide insight on how to change those. So that's kind of where we are right now with our subcommittees. And of course, they've been very busy on all their different aspects, definitely with the added exposure of broadband. So moving on, the next slide is just something, it's a page out of the original 2018 broadband plan. It's our mission, vision, and moonshot. It's kind of where we want to be going, where we want to take the commission as we move forward. And then inside of that, we're trying to address the individual stakeholder needs. And that's across from the individual citizens, businesses, broadband providers, and governmental agencies. So trying to be all encompassing of the stakeholders, because as we all kind of understood before, broadband is not, you can't compartmentalize broadband. The way it is now, we see it with telehealth, we see it with medicine, but if you look at broadband in a whole, you go from the simplest of the simple to send an email to the complicated point of taking inventory of your refrigerator. So that's the breadth of depth, or the depth, I guess, of how everybody's lives are affected by broadband. So moving forward from that and taking into account our mission and our stakeholders' needs, we're looking more towards priority recommendations. You know, we can't be successful unless we are able to identify the kind of the leading edges of where we need to be to improve broadband as a whole. And for right now, it lays in these areas of leveraging the public and private partnerships. Those are necessary to build our goals, as has been laid out by the legislation in 2018. And it again comes to removing barriers to deployment. Again, there's barriers to deployment on several different areas. It's being able to identify them and work with everyone to make it successful, to successfully remove those barriers to deployment, to where the internet providers, the broadband providers, can then build out in a little more streamlined fashion. Third bullet point is to increase the access to funding. Again, the more we increase access to funding, getting that funding out on the ground, out in the field where they can move forward, then that's just gonna, it improves the broadband overall. The fourth point, integrate the emerging technologies. There's new technologies being built every day as far as the broadband's concerned. The FCC continues to expand the availability of bandwidth, frequencies to the wireless providers. We keep getting build outs on fiber and trying to improve, getting improvements on those technologies and bringing them to Wyoming and integrating those into our solutions as well. And then finally, to touch on something Canyon mentioned about the bullet point of Broadband 101, it's getting the education out there to the users, make sure they know what they need to successfully handle telehealth and to successfully get the information that they need from their home out to their provider with limited interruption, if you will. And then also the same way, getting that information that we need from the disconnects that we have at the homes. That's the one thing that I have heard during this pandemic is it's not so much the connectivity to the facilities, it's the connectivity to people's homes and that last mile that we're so struggling for. So figuring out how to address that, getting that last mile into the homes and getting that information to the providers to where we can work together and make solutions going forward. That's where our priorities lie as of today. Now, I've been here since January, and they've had previous successes. They brought connectivity into Guernsey and parts of that eastern parts of the state. They've helped to expand other areas. We've had fiber expansions. Internet providers have not stopped building since the internet was invented years ago. They're just having to do it at a faster pace, and we've been involved pretty much all the way. So, but since January, I wanted to bring some of the success stories that we've had. The broadband providers are beginning to send us the information for the Wyoming broadband map, to where it'll make it easier to identify the areas that have issues. And the information that they're going to provide allows myself and the council to look at that and help make a plan to not only to identify, but to provide resolution of those areas and get that service where it needs to be. And the next one is the final development of the procedures needed to fund the broadband grant applicants. That program's had some problems, but it's a work in progress, as most things are. And we've just been able to finally get all of that put together, get it approved, and now we're ready to go. So it couldn't come at a better time to be able to put the icing on that cake and put it on the table. Our collaborative efforts have been widespread, especially in the past 8 weeks. It's been ETS, the Wyoming Department of Education, the Wyoming Department of Health, the Wyoming Telehealth Network. Federally, we're looking at the NTIA, the FCC, USDA. SBLN is a new one. That's the State Broadband Leaders Network. We are able to receive and transmit significant amount of information on what's happening across the country through that leadership network. The Digital Inclusion Network, the Wyoming Telecommunications Association, and a Wyoming Business Alliance. Those are the ones that we're always engaging with, trying to move this effort forward. We're currently working on broadband developments for Crook County, for Albany counties, Niobrara, Platte, Goshen counties, Camp Guernsey, and Natrona County. There's a lot of activity and a lot of conversations all across the state. These are the ones that are some of them are getting moved forward for broadband funding. Some of them are getting ready to launch RFPs. There are different stages all along the way, but these are the ones that are kind of coming up from the beginning stages. We've been able to identify additional funding sources through our contracts, through our contacts at the federal level, the economic development agencies, environmental and public works, additional opportunities from FCC, USDA, Department of Defense, and Homeland Security. And again, a lot of these have been built over since the middle of January. Next, we've been able to establish a very good conversation with our congressional delegation, and we've been providing whatever information they're looking for the betterment of broadband in Wyoming. And then likewise with Governor Gordon's office, state legislators, the city and the county governments, and then answering several calls to Wyoming citizens concerned about broadband and moving it forward and getting where we need to go to help them out and do what they need to do. So that's kind of a big general overview. Just want to give you guys kind of where we're at. We do a lot of information, and what we're trying to do is lay the tracks for success. I compare this to the train, because without the tracks, you don't have the train. And without the train, you can't haul anything. And data and internet, broadband is pretty much the same way. If we don't have the tracks going to the house, they can't get anything. And then once we have the tracks there, we can put anything we want in there. As you all probably are aware, you can watch YouTube while you look at Google email. You can do so many things all at once, and that's indicative of the track and train analogy. Once you have the track, you can put pretty much whatever you want on it. So I hope that helps. I stand for any questions you may have.
Super. Ryan, could you, before we take questions, could you give us a little bit, flesh out for us what some of the funding opportunities in the CARES Act have been? Because of course that's another source of, and as there's been some specific mention of telehealth in the CARES Act bill? Is anything of that really going through what you're doing? Or I know that there's also a sort of some sort of broadband or telehealth consortium that is putting in for grants really that are healthcare provider specific, or what? Talk to us a little bit about what there is there.
Specifically related to CARES Act, the right now, excuse me while I shift here, there's phase 3, and then I believe there was a phase 3.5 as far as the CARES Act was concerned. And a lot of what I understand of the phase 3 of the CARES Act was basically as the 1.25 billion that we received was the business support, the unemployment support, and trying to place the supports on the additional expenses, which includes the FCC Keeping Americans Connected Act, where our broadband providers went out and connected people for free and are currently maintaining those free connections based upon that act that was put in by Chairman Pai. You know, they've championed that across the board to where our students can get done. More to your question, from what I understand on phase 3, that is to kind of reimburse everyone and get everything right with what was spent to satisfy the response, the initial COVID response that was required to be able to teach our kids at home and expand telehealth and do the things that were required to keep us going to where we are today. The phase 4, which I've heard responded to here as heroes, I have been told that that's where the money will probably lie as far as what we can use. It'll be a lot more flexible to where we can use it to build out and actually better our response to such an epidemic as COVID. But that's my high level response or understanding.
So in the phase 3, whether through CARES Act or maybe elsewhere, you're not really seeing money that would enable construction of towers or trenching or that kind of thing. It's more internet, reimbursement for internet coverage or something, or what?
Yeah, it's more reimbursement like the FCC open, I can't remember what it's called. E-rate is what provides the connectivity to our schools. Well, because it's E-rate, they're limited to where they can transmit that. It's not open to the community. Well, the FCC went in and relaxed those rules during this pandemic, and they have what they now call the community access point, to where the schools, and several of them across Wyoming are doing this, that they've put out a outdoor antenna and made it open for anybody that wants to access it. And then that traverses the E-rate network back to wherever it needs to go. So right now that exists, but it only exists because of the pandemic and the what's been allowed, I guess, as far as the rules are concerned. I'm not sure that might answer your question.
No, well, because I'm participating with some of the legislators that are looking at the sort of the more broadband task force, in the discussion about the last mile that you had. I mean, it doesn't really sound to me like having an antenna at the school, given the topography of Wyoming, it doesn't seem to me that it's going to reach very far.
No.
When you think of some kids that are on the school bus for an hour in rural areas.
Yeah, right. And that's the I guess that's the larger draw of all of this, is trying to figure out, in a lot of the conversations I've even been having, in meetings with ETS, is getting a starting point. If we can even get that community access point, then we can start somewhere, begin a quick response, and then be able to put a long-term plan in place. Is the one standpoint that I do have on broadband, and I don't, to me, I don't care how it's tackled. We've got one shot, more or less. This is our shot to get this fixed. And if we go out and just kind of, we want to hurry up and get it done, we can, and it is possible. But what it has the problem or the pitfalls to that will be that what's built may not be sustainable. And if we don't build something that's long lasting and sustainable, then ultimately long term, it's not going to do us any good. It's not going to do the state of Wyoming any good 30 years from now, when we each need a gigabit at the home.
Senator Schuler.
Thank you, Madam Chair. I just, one quick question. I appreciate your time and energy with this. I appreciate the fact that you guys have some moonshots and some great goals coming forward. I noticed that your focus for the near future looks like it's pretty much all the counties on the east side. So I would be very interested, and I think some of the other representatives and senators here would also like to see what the map looks like on the west side of the state and what's been done with mapping there and how we are there. So thank you, sir.
Right.
Thank you, Sean. Yeah, as far as the map goes, the mapping is actually covering the entire part of the state. And again, I need to reiterate that I've only been here since January, and I traveled around through the 17th, from the 12th of January to the 17th of March, and otherwise until very recently have been at home. So as far as the mapping goes, it covers across the state, and I've been responding to requests and overviews across the state. You know, Park, Teton, Afton, Pacific Creek. I haven't heard much from the Evanston area, but you know, don't despair. The western part of the state isn't out by any means. I just haven't been able to get there yet.
Representative Stivar.
So, sir, Madam Chairman, so you're getting a map of all the fiber optic cable too?
That request is out there, but honestly, due to security, that will be protected on my side. The idea behind grabbing or asking for the backhaul fiber will be to have the information available at the Business Council, to where if we do have need, or we do have a request for connectivity, then we can identify who's in the area and then go back to those providers and say, okay, you know, you've got fiber here. I've got this request from, you know, in this case, a clinic in, I don't know, Kemmer that wants fiber. Okay, who can I talk to get that information? But honestly, to maintain the security for the providers and not release privileged data, we'll have that information, I believe, if they want to provide it, but we'll leave that on the privilege side. Does that answer your question?
Oh yeah, that's the answer I was looking for. You understand that there is a fiber company right now overpulling the Enron route.
Oh,
it's a 432 they're putting in.
Oh, shh.
Nice.
Is that a secret, Representative Stivar? Ryan, what do
you guys think?
Well, you just let him think. So, Ryan, I'm just going to say what I'm sure you know, which is that I have a cabin in northern Albany County, and when I look at the provider's map, which is by census block, those very rural areas have pretty big census blocks, and it says my cabin has connection. And what I know from that is if I hike up on top of the hill and the airwaves are just right, and I kind of stand on one foot and spin around, I might get a text out, but it really wouldn't be enough for an EKG, I'm pretty sure. So just be a little wary of what what the provider map shows, and I'm sure you already knew that. Okay, any more questions for Mr. Kudera? No, excellent. Well, we're still building, we're gathering. You're sort of the man of the hour in a lot of ways, Ryan. Go forth and multiply.
Very good. Anybody has anything, feel free to get in touch. Thank you.
All right. Elizabeth, do we have anybody else who's in here to talk about telehealth?
Ma'am, I don't have any other presenters for telehealth. I do have quite a number of folks interested in talking and providing public comment.
Well, I guess we should. I did receive a text that Director Ceballos was in there. I'm not sure if he wants to talk about this or something else. Do we have any agency? I'm trying to do good. Do we have any agency people who want to comment on this issue first? You should wave at Elizabeth or something.
I do not have any in the waiting room from the agencies.
Okay, then.
Other than the UW individuals who are in here currently.
Okay. Well then, why don't you start letting them in, whoever we've got.
The first person we should have is in Andy Somerville.
Oh, she's not gone home yet. Okay, let her in, Andy. There she is. I see her box. There we are.
Madam Chairman, this will be the last time I join you for public comment this evening. Thank you guys for putting up
I
with
won't say anything about that.
I appreciate it. I just real brief comments. We've already talked about some of the access issues in terms of the telehealth struggles in a previous conversation. So I would just reiterate those, that last mile to the facilities, as well as education, both on the providers and getting education out to patients. I think that's probably the biggest next critical step, is to really make that something that's out there all the time and is more available to our patients, so we can get them better connected, as well as dealing with their device and internet issues on their end. But my last comment is just want to give a huge shout out and thank you to the Wyoming Telehealth Network, the University of Wyoming, from all of our community mental health centers. They have been absolutely invaluable the last 60 days and have done flat amazing work in no time at all. And my providers wanted me to relay that. So I'd stand for
Very
any
good.
questions if you have
Thank
any.
you. Questions for Ms. Somerville? Okay, thank you. Who's next?
Next, we have Ramsey Scott.
Oh, Mr. Scott, here you go. There we are. We see his square, his rectangle. So, Mr. Scott, are you in the right time this time? We're talking
I
about
think I
telehealth.
am. Can you all hear me?
We can hear you.
Excellent. Ramsey Scott, Public Policy Manager with the Wyoming Alzheimer's Association. I'll make it very brief since we're a few hours behind. We just want to make sure that when these new funds, however they might be sort of allocated, however much they might be, and what sort of priorities are placed on them, that we're ready, Wyoming is ready to take advantage of it. Counting upon general fund dollars is not something I think would be a wise decision at this point. So any money that we're getting from the federal government to be able to sort of bolster this system is going to be key, not just for economic development, but for healthcare in general, especially for those living with Alzheimer's and other dementias. We really need to focus on the infrastructure. You've already heard it from the Business Council. That needs to be a long-term thing. We also need to make sure that when doctors are taking these telemedicine visits, that they're getting reimbursed at the same rate they might be if it's in person. And then we also need to make sure that as a state, we're really pushing to make sure we're educating our medical community and then our patients as well, about the benefits of telemedicine, and try and maybe demystify it a little bit. Something that I've been learning a lot about as I've participated in these calls and lectures and symposium and whatnot, is that there's a lot, it can be very scary for people, especially if you're not very tech savvy. And so I think that one thing we could do, even while we're waiting on funds to happen and the infrastructure to be built, is to start educating our community, both medical and the public and at large, about not only the benefits of this, how it works, why it can be just as easy as going to see the doctor. And so I will leave it at that and wait back in the queue for our general discussions. I'll also stand for any questions if anyone has any.
Questions for Mr. Scott? Okay, thank you.
Thank you.
Elizabeth, who's next?
Next, we have Eric Bully.
All right, send him in. Eric, there you are. Oh, you're on, there you go.
Hello, Madam Chairman. Good evening.
Good evening.
You again today. Obviously we're supportive of telehealth, and I also want to give a great shout out to the Wyoming Telehealth Network. I actually sit on that committee. There are a couple things that a lot has been said, but I absolutely feel like telehealth and expanding some of the CARES money fits right into the guidance that we've received. The telehealth network, I think, should be funded. They need some funding. I would throw out a dollar figure of $1 million to help continue what we're doing and continue to push telehealth across the state. I also think that it's important that we stand up and get the health information exchange going, and I think it fits right into what we're doing as well. For a period of time, it'll be sustainable, but then as we look to the future, we're going to have to use subscription fees. And I would advocate for CARES funding to help stand up and keep the health information exchange viable and moving forward. It's a critical piece of continuity of care, driving down costs of healthcare. You've already identified one of the big challenges I think that we face, and with Ryan and his comments, there is some funding out there, but for infrastructure, again, as I look at the guidance, I've got it right here in front of me, as I look at the guidance for the CARES funding, connecting the last mile, getting folks connected, building towers, I think it all fits into the CARES funding because it actually promotes and expands our ability to provide access to care during pandemics. And so there's been a lot said. I think parity is kind of covered, but I think parity is really important so that our providers want to participate and utilize telehealth and engage their patients. And I, as I think about that also, we have a lot of our care right now that is still going out of state, even using telehealth. And so I think if we could build a really robust telehealth network and have it stood up across the state, we could bring our providers in state together and create our own pool of providers to provide those telehealth services to our state employees and others that are now seeing doctors in Texas and other states. So as you consider how to expend and allocate these CARES funds, I would really encourage you and ask you to take a really close look at funding the telehealth network, funding the HIE, and then also putting money into infrastructure so that we can build a robust telehealth platform. And with that, I'd answer any questions. I appreciate your time.
Eric, just remind me, is the health information exchange that sort of program that enables electronic health records to talk to each other, or am I thinking of something else?
Madam Chair, that's exactly what it is. So we've been working diligently for the last couple of years. We had a failed attempt at a health information exchange years ago. We found some federal funding and we've been working closely with them. We've got a contractor, we've got hospitals that are now connecting, we've got private physician offices that are connecting. But yes, it's used to transmit data so that if you're seen in Cheyenne and the next day you're injured in Evanston, through that health information exchange, the doctors, the facilities can take a look at your medical records and help to make sure that the care you receive is good, or we're connected into other states. So if you go to Utah, if you go to Colorado, other states, that information can be shared with the doctors that see you there as well.
I will say that there certainly is discussion among some leadership in the legislature about using CARES Act dollars to work on the last mile problem. So
I think it's important. That's just one small piece of it, Madam Chairman. I mean, we got areas that don't have any service at all. You identified your cabin, but I've used my example a million times. I went to the Wyoming Medical Society meeting at Jackson Lake 2 years ago in the summer. We had a meeting about telehealth, and then as I drove from there over Togety Pass and down to Fort Washakie and finally into Lander, I didn't have any service for almost 170 miles. And that's one of the areas that telehealth could really benefit the citizens of Wyoming. So we still have some areas that need to be taken care of, and that's where I think the CARES funding could really help us out.
Okay, more questions for Mr. Boley? Okay, thanks very much.
Thank you.
Elizabeth, who's next?
Last one for the telehealth is Kevin Bonenblus.
Super, send them in.
Oh, sorry, ma'am. There is one more individual who has just shown up. Mike will be after Kevin.
Okay, well, we'll take Mr. Bonenblus. Director Bonenblus, we see your rectangle.
All right, Madam Chairman, can you hear me?
We can hear you.
Okay. And I realize that the hour is late, and I subscribe to the theory that the mind can absorb what the seat can endure. So I will keep this as short and sweet as I possibly can. But I thought I would let the committee know that we are right now, I think, experiencing a monumental change relative to telemedicine and telehealth. And that is that with the onset of the public health emergency, the board put in place special rules where physicians and PAs licensed in other states can practice in Wyoming without a Wyoming license. We've got safeguards in place to make sure we're not getting any bad actors. But the important thing is that what we've done is we've put that in place. We've got over 1,200 physicians and PAs from other states who have signed up to be able to provide care in Wyoming. And the overwhelming majority of them are doing it through telehealth. And they are from especially the major hospital systems outside the state, neighboring states, whether it's UC Health in Colorado, it's Billings Clinic, it's University of Utah Medical School, Rapid City Regional. And what they're doing is they are addressing what I think we've all worried about over the years, and that is, why do we put patients on the road to come to a city outside the state for a preliminary meeting, visit, just to come back and do services later and then come back and do follow-ups? So what we've seen is a tremendous interest in that. Just as an example, we've had over 300 pediatric specialists from the University of Utah seek that exemption to be able to practice in Wyoming without a license at this point. And we think it's doing some great things. So what I would say is this, Madam Chairman, is that I think what we've waited for a number of years on telehealth is sort of the acceptance of the 3 Ps, if you will. First, you have to have patient acceptance. And I think we're finding more and more, it's not just the younger people, but it's like me, kind of long in the tooth, that are saying, yeah, I'll do that rather than have to travel a distance. And then we're having provider acceptance, which is, of course, does a provider want to do it? And just to give you an example, I have a former board member, highly esteemed. He's a surgeon, and I never thought in my days I would ever see him doing telehealth. And he indicated he's been doing preoperative and postoperative visits via telehealth. And that's somebody in Wyoming. And then last, the payer acceptance, because of course that's unfortunately what drives the whole bus. And so what we found is that, especially with changes made by both CMS and then also by organizations like Blue Cross Blue Shield of Wyoming, et cetera, that bridge has been covered. And so all I would say is I hope the committee will appreciate that. I think this is, to borrow a phrase from a political figure you may love or you may hate, never let a good crisis go to waste. And I think this is the silver lining, or one of the silver linings, for the COVID situation. And that is that I think we've gotten the telehealth genie out of the lamp, and I don't think it's going to go back, but I think that's good for Wyoming. So one thing the board of medicine is going to try to do is turn the corner and see how many of these physicians and PAs we can persuade to remain licensed in Wyoming after the public health emergency is over and after the exemption expires, because we're recognizing that this is a fantastic model for Wyoming, fantastic model for Wyoming patients. And so I just wanted to make sure the committee knew that out of a lot of this train wreck of COVID-19 has been something very, very positive. So I don't have a whole lot more to explain, but I didn't plan on speaking to the committee today, but I thought you ought to know that and be aware of that. So with that, Madam Chairman, I would stand for any questions, or I would also get out of the way and let folks go down the hall and pour themselves a beverage. So
Thank you. Questions for Mr. Bonenblust? I guess not. Thank you so much. Okay, Elizabeth, who was last?
Last, we have Mike Morris.
All right, come on in. Hello, Mike. We see you, but we don't hear you. Oh, now you're muted. Nope.
How's that?
There you go.
Okay. Good evening, Madam Chairman, committee, Mike Morris with the American Heart Association. Early at the end of the session, there were some interim topics that were discussed. One of them was stroke registry. We believe that telehealth fits right into that. If there's any CARES money that could be available to fund stroke registry, we believe that it would be appropriate. There's not a lot of evidence yet, but there's quite a bit of anecdotal evidence that COVID is expanding arteries and causing strokes in younger people. So that's my ask for this evening is that we look at stroke registry as possibly being funded with the CARES Act.
So, Mr. Morris, what would be needed specifically? Personnel, space, computer, internet connections, software? Is that?
No, it's Madam Chairman, it's already really built out. It's basically a subscription from the hospitals. I've heard as low as $2,500 per hospital, but basically for the state of Wyoming, all in, we're going to be at about $150,000. And what that does, it's a database that we're able to share information. We're able to get real-time diagnosis from, say, a Dr. Wheeler in Casper to somebody in Evanston or Pinedale that can help treat a stroke and mitigate some of the damages caused by stroke.
And so the 150,000, is that an annual subscription?
Yes, ma'am.
Okay. Questions for Mr. Morris? Or, oh, I think you sent us some material on that, didn't you?
I did.
Yes. I saw it in the inbox. I haven't read it yet, but I know it's there. Very good. Okay. Thank you so much.
Well, I won't keep you longer. Thank you for your time and dragging on all day. So.
Well, hopefully our arteries aren't expanding. No more questions for Mr. Morris? Okay, thanks so much. All right, is that the last person that's on the list for telehealth?
Yes, ma'am.
Okay, then we finally arrived at 4:30. And really, there may be people waiting on this, but we're not really needing testimony in particular. What my purpose was in putting this list here was to just give providers, people heads up, lest they fear that these topics had fallen off of our radar screen entirely, to kind of identify what we're hoping, what information we would like to hear before August or by the August meeting. And that was really just because when we start posting and putting things out 3 weeks ahead, sometimes we don't get very good information because the people didn't have time to collect it. So I'm just going to read these, and if there are people who are waiting and want to say something, that's fine, although it doesn't have to be lengthy at this point. But just to remind the committee, last August, I think it was, in Evanston, and maybe the second meeting too, but we talked about a possible self-directed care waiver for the aging Medicaid waiver, and Health Department at that time asked for really a little more time to evaluate the costs, whether it would end up saving money or whether more people would try to enroll. So we want to pursue that as a way to possibly provide better care at less cost, and who knows. Okay, so then we do have these skilled nursing facility assisted living rebasing. There is that statutory requirement, and we know we have heard this request before. We were not successful in getting that put into this year's budget, and frankly, with the budget going forward, I'm a little dubious about whether we'll be successful again. But I felt, owing to at least we should at least make a slight waive at requirement. The community service and private providers, that's going to be part of our continuation of the discussion on the mental health services. Prevention programming, again, that's again part of the whole mental health services, you know, the fact that we don't have a task force, so we're going to have to think about all these things ourselves. I do want us to follow up. Several years ago, there was a budget footnote. I think it started maybe 3 years ago. There was a budget footnote that rerouted suicide grants. Instead of formally having been through PMOs, it went through the county commissioners. And I think we need to follow up. So heads up to the county commissioners and Jeremiah and all. We need to make sure we understand whether that has been successful or what's happening there. Then the question about the graduates from the healthcare providers and workforce, from the healthcare, that was, you know, we started working on that last year up in Riverton. The information was not as fleshed out as we might like, and we need to just continue working on that. Management Council has requested that we follow up on the workman's comp rate holiday. You know, we did hear earlier this morning from Director Cooley about what the balances of, or no, I guess that was unemployment compensation that we heard from. But anyway, the workers' comp, sorry, I'm drifting there. The rate holiday is a request for Management Council. And then they have also asked us to consider something that I only became aware of over the last 6 months or so, and that, in fact, not all employers and employees are covered by workers' comp. Some are allowed to self-insure if their employees are not rated as hazardous. And it's not entirely clear that the employees are really receiving the same level of benefit or assistance. So I will take public comment on those, but again, we're not considering these topics now. We just kind of giving people a heads up. So if you have comments to make about people's heads, ask to be let in. Elizabeth, who have we got?
Ma'am, the only public comment related to this is from Ramsey Scott.
Well, send them back.
I'll make it very brief then, since we're just doing heads and not actually talking. I won't be too much of a talking head. Just want to say we really, especially when it comes to the rebasing and the waiver, choice waivers, we really would love to see you guys tackle this in depth. We would very support some action on that. And I can connect with y'all offline and send you some of the information, how it might affect the 10,000 people with Alzheimer's, but especially the 28,000 unpaid caregivers who supply $413 million of unpaid care in the state. Those waivers would really be significant to them. So thank y'all so much. Appreciate y'all being running the marathon here, and have a great weekend.
Thank you, Mr. Scott. Oh, Mr. Scott, come back. Representative Sweeney has his hand up.
I have an answer then, sorry.
Oh, Representative Sweeney, is your question for Mr. Scott?
No, it is not.
Oh, well, then you can go, Mr. Scott. Sorry.
Thank you so much. Appreciate y'all.
Representative Sweeney.
Thank you, Madam Chairman. Earlier this afternoon, Representative Henderson had sent, it's a COVID topic, evidently on presumption. Some states have established or are considering adopting a presumption that a worker who comes down with COVID-19 contracted the disease at the workplace, thus making them eligible for workman's compensation. I think we may have introduced some legislation, but I don't think we passed it. And I don't know enough about it, but I'm wondering if we should have staff take a look at this, and being we're the Labor Committee and Workman's Comp.
I'm pretty sure that was in House, I think it was House Bill or Senate File 1002, but I think Representative Barlow has his hand up.
Thank you, Madam Chairman. So that is true. We did put it in there. It's presumptive. It does not have to be workplace related. One of the things I'll point out from the materials that were provided to you is that we're with the extra hazardous or the hazardous employees, We're a state program, and we're holding the employers harmless both on the rate increases and on the cost. So we've tried to cover that from every direction. This is from a national organization that has concerns about it, but I'm not going to say it isn't applicable to Wyoming, but I think it's less applicable than many other states. Thank you, Madam.
Thank you, Representative Barlow.
Thank you.
Okay. Just before we fold up shop and depart, have we got any last comments on all our work?
Madam Chairman?
Yes, Elizabeth.
Well, thank you for the upgrade. I noticed in the public comments list that we had Eric Boley was going to ask or discuss a bill draft potentially. I don't see him in the Zoom meeting, but I felt to mention it as well since he had specifically requested to discuss it.
Oh, was that Senator Scott? Was that the discussion of the upper payment limit, or was that something else? Do you happen to know?
That's what it was, and I think we've dealt with it successfully.
Okay. Representative Yin.
Thank you, Madam Chairman. I know maybe I just missed this real quick. So the notice of topics for the next meeting is the follow-up on workers' comp. So is this specifically about not just the rate holiday part, but the differences between workers' comp and self-insured on covering employees for the larger companies that are self-insured that aren't covered by workers' comp?
That is my interpretation of the assignment. There's I think that second category especially is just way too big and is going to require testimony. It's really not suitable for a Zoom 15 minutes, I don't think. But yeah, we won't let that fall off.
All right, yeah, it's definitely concerning to me because I think there are quite a few of those bigger companies that are self-insured. So
I think there are more than we might have thought. Representative Hallinan.
Thank you, Madam Chairman. This is just a comment on the issue of these kids that are very difficult in the behavioral health area. I think that whatever this committee does, that they're going to look at this issue, I think it's got to be very complicated for them to have a report for us by August. I think we need to contact some kind of center where they do have treatment for these kind of kids. And I think we need to contact the experts, and those are people probably in the university centers before we can address this issue. So I hope that the committee can do that. These are people that you've appointed to a committee, but I doubt that they're going to have anything ready for us by August. And so I'm just saying that I think we need to really go for the experts on something like this, experts from places where they have treatment for these kinds of kids, and experts from the universities where they have some kind of expertise that's way beyond anything that we have, anything locally. Thank you, Madam Chairman.
I think those are good thoughts, Representative Hallinan. And I wasn't really expecting a whole report by August. I was mainly hoping for sort of an identification of the panorama and the problem. a little bit more of a roadmap rather than a resolution. But okay, any more questions? So folks, just a reminder, we've got 2 bills going forward. Senator Scott and I will talk in a while, but not this weekend, I sure hope, about what we might need to do as far as timing for a little follow-on. We had enough people interested in maybe contemplating again the provider repayment program or some similar thing. We had the Medicaid or Medicaid provider payment boost and the discussion of the licensure. And probably what I will do is maybe send out a doodle poll or something and at least obtain a few ideas on dates. We would certainly not plan to have it be lengthy like today. We won't put any topics in, I don't think, Chairman Scott, other than the consideration of the bills, which ought to enable us to
Yes,
confine
and
it.
we're going to be very strong about that.
That's right. And we're, so we won't have any agency reports, only bill, we might have them in to talk about bills, but that we'll try to really, sorry, this went longer than I thought, but I guess we're often that way. So at least I think we did good work, committee. All right, so the meeting is adjourned and we'll see you all later. Thank you, everybody.